hypotonic child who also had the same mutation. So all of these manifestations, we need to be very clear. Fatigue, the mother will say that the baby just walks a few steps and tends to keep falling. We may think it's muscle weakness, but it's usually due to fatigue. And the child may be better in the morning and more worse in the evenings. Difficult in children. So congenital myasthenic syndromes are not just limited to the neuromuscular junction disorders symptoms, but they can also have mental retardation, they can have seizures. So particularly in the presynaptic one, you can have these features. You can see this brother and sister who had ptosis, which was missed out. They are not symptomatic for ptosis at all, and they had a disconjugate eye movements, and some skin lesions we do not know for. You can see the decremental response is very, very prominent in this patient. You can see. So that's very important. So neuromuscular junction disorders can be associated with central nervous system manifestations. So in the presynaptic disorders, you get a RNS if you do with the tetanic stimulation or subtetanic stimulation, you should get a picture just like LEMS. So as you can see here, it's very low amplitude CMAP you can get, and after brief exercise it increases. So LEMS-like picture. So postsynaptic, classical, you can see infantile onset, childhood onset. You can see the almost symmetrical ptosis. You can see the eyeball movements are almost frozen. And these are identified to have CHRND, the epsilon subunit of the neuromuscular junction gets affected. And these patients were mislabeled by us and by others as congenital myopathy or mitochondrial disorders, never received any treatment, never received, instead by muscle biopsies or no genetic test. And you can see the decremental response in these patients. It's a very interesting case. This boy had some ACHR positivity, and because of which he was on steroids. You can see he's a little bloated because of steroids. But what's important, every child with the neuromuscular junction disorder should undergo a genetic testing so that we do not miss out on this important group of treatable disorders I keep reiterating. So this child had excellent response to pyridostigmine. Now we know that presynaptic disorder, postsynaptic disorders, we have to be careful, and also presynaptic, where to give pyridostigmine and not to give pyridostigmine. So you don't give pyridostigmine when the patient has got slow channel syndrome, because they're going to deteriorate or have respiratory distress, and that could be disastrous for the patient as well. So you can see this patient was an 8-year-old boy with very early onset. His eyelids are almost symmetrically drooped, and he had swallowing difficulty also. DTRs are exaggerated in this patient, and then the CK is normal in these patients, except in the dystroglycan CMS group, where you can have elevated CK. So this patient with this much of ocular signs did not have any diplopia. And you can see that the patient has a CHRNE mutation. So another man who came at 30 years, but the onset was in childhood, and he also had a CHRNE mutation, but you can see that the CK is normal, and excellent to very good response to pyridostigmine. This is interesting. See, you see the patient came to us at 56 years, was diagnosed as myasthenia gravis, and he was on multiple immunomodulatory drugs. And when we took a careful history, he said he had ptosis from childhood, which did not bother him at all. So he didn't bother. But when he developed his bulbar symptoms, he went to the neurologist, and they started him on pyridostigmine. And patient had no response and multiple immunomodulatory drugs. So when we asked him, and he said ptosis is from childhood, then we did the genetic testing. So this is CHRND, so the delta subunit, which is very rare. So on the right side, you see this patient just seen 4 weeks ago. This is my very latest case, who was just 32 years, and he had some episodic respiratory distress, and then he had exertional breathlessness. No diagnosis made. He went to a physician, and finally, suddenly, he had an acute respiratory stridor, for which he underwent a tracheostomy, and then he came to us. And when we see the sister's photo, you see that she had symmetrical ptosis. So we thought it could be mitochondrial disorder. Sister is having maternal side. He said mother had ptosis, but we didn't have her pictures. And then when we did the genetics, we got a CHRND homozygous mutation. And of course, though it is reported as VOUS, we did this, and this is very important. So we got this raw data analyzed again in a different pipeline, and this homozygous mutation is indeed pathogenic. So it's very important. So this is CHRND. So of course, we'll knock off his tracheostomy in a short while, and we've just put him on salbutamol, and when he comes back, we will treat him appropriately, either with pyridostigmine or with fluoxetine. So this is my very latest case that I would like to share. Otherwise, this patient is going to be on a tracheostomy lifelong if we don't make a correct diagnosis. So I won't show this videos because we'll move with the Yes. So this is the other group of disorders. As I said, the development and maintenance, mostly it is the DOC7 which is commonest, then the MuSK. So here you see that the ocular muscles are rarely involved, and they usually have normal eye movements, unlike the previous group that I described. And they do have significant bulbar involvement, and they can have wasting of the trunk. A triradiate tongue can be there. If you find it, I just saw that in one patient. And do not use pyridostigmine in this group because it can exacerbate and they can worsen and have respiratory distress. And they have very good response to salbutamol and fluoxetine. So you see, this is a lady and her niece who had onset at quite later onset of age, from 28 years of age and 24 years of age. And you can see that they had ptosis, and they had the older one came on a wheelchair to us. And DTRs were normal, so we said, okay, we must be dealing with something to do with neuromuscular junction disorder and genetically mediated. And of course, you can see the mutations I have put up over there, so the patients had a DOC7. Now, what do you give in DOC7? It's a slow channel syndrome. So you don't give pyridostigmine at all for these patients. They can worsen again. Fluoxetine, up to 120 milligrams, you can slowly increase. You can see this patient is on 80 and the other patient is on 60. And for the younger one, we had to give salbutamol also, 8 milligrams. So what was tragic was when they went back to their physician and they had excellent response and they came back walking to a OPD, the physician said that this salbutamol is given for bronchial asthma, so please don't take it, stop it. So they stopped it, and 2 weeks later they came again, the older one in the wheelchair, to my OPD. So we have to tell them that please do not stop it. We took so many decades to understand that this is the drug for this disease. So also give them advice that not to stop. And salbutamol takes weeks, months and years to respond. So you have to the doctor has to have endurance, the patient has to have endurance. It's not going to happen overnight. I'll just share you the schedule. Of course, it just shows that I have 12 more minutes. So I'm not going to go through any of the videos if my time is going to be short. So MuSK is another form of neuromuscular junction, which is limb girdle myasthenics. These do not have ocular and they may have bulbar or no. And most of the time, it is a limb girdle syndrome pattern. So asking for fatigue, asking for easy fatigability is very important in this patient. So you see this patient who came actually he resigned his job from Dubai and he came and he was very severely weak. He would walk 5 feet and he would just flop and he would buckle and fall. And then if you look at his picture, ptosis was not identified, neither does he report. His eye movements are full range. He had a very peculiar tongue, as you can see. The moment he puts out, it gets folded, and there's a central wasting of the tongue, which we had seen only in this patient. And the other patient, you can see, they do not have muscle wasting or hypertrophy and who had limb girdle weakness. So they all look like limb girdle syndromes. And the first patient, in fact, had a very excellent response in the ward itself for 2 milligrams of salbutamol, and he went back and joined his job. And what was interesting, he had MuSK antibody positive. And we also got it confirmed from Professor Angela Vincent's lab, and it was indeed positive. So they can have an autoimmune response to a genetically mediated disease also. So that's important. So just because the antibody is positive, we don't, and sometimes it's 0.4, then they will give us 0.5, and that's taken as positive, and then the patient is getting immunomodulation for days and years with all its side effects. So this doesn't work actually, I think. Let me see. Is he handling it? No. So you can see this patient had very severe fatigue. And why I'm showing you this is that he just had like a picture. You can see, if anybody sees, this is like a limb girdle muscular dystrophy. Gowers sinus positive. Now as he walks, you will see he has a waddling gait, very classical, and his CK was minimally elevated. And this patient had all his reflexes, which were very brisk and exaggerated. So you can see the nice waddling gait. So this patient came to us, a limb girdle syndrome, and then the patient actually had MuSK positive myasthenia and doing very well. Again, here we do not give pyridostigmine, we just give salbutamol and fluoxetine. A rare mutation, that is agrin, as you can see. This patient, you can see the fatigue that he has. He's just 14 years. Unfortunately, he didn't respond very well, but of course he can walk around. Ephedrine was not available. We tried in several, even in Gulf countries, but we did not get. And you can see that this other lady, you can see she had a limb girdle weakness, and you can see the tongue. She received pyridostigmine. Of course, we only started because she had a dramatic response in the OPD when we gave her injection neostigmine, and she said, I'm doing very well. But 2 weeks later, she came back with this multiple bites of the tongue. With pyridostigmine, your tongue gets swollen sometimes, particularly in musk, myasthenia, and in this slow channel syndromes. So you can see the tongue bite she had. So we had to stop the pyridostigmine. She's on salbutamol. Not doing very greatly, but she can walk around, carry her baby, and do well. But it took us 9 years to diagnose this case. Though we knew it was neuromuscular junction, we didn't have genetic those days to do. And now, of course, genetics has revolutionized our diagnostic capabilities. So, as I said, I'm not going to get on to the thing. So this is a very interesting group of disorders. This is the dystroglycan CMS group of disorders, where you have a limb girdle syndrome. Patient has all features of a limb girdle, muscular dystrophy, and CK is elevated. As you can see, in our patients, we had as close to 6,000, and we had about 14, but now we have another 4 or 5 in addition. And these patients do respond very well to pyridostigmine and salbutamol because they're fast channel syndromes, but this LGMD CMS phenotypes respond to pyridostigmine. So you can see this family. You can see the first patient is around 65 years now, who came to us in 20 years ago. We did a muscle biopsy which showed dystrophic features, and that's all we could do those days. And then this young girl, the niece who came to us, so this was the girl who came to us in 2017, and she had quite profound fatigue, as you can see. And then we called back the entire family. We got it. We found a founder mutation in this family. And of course, then we had 3-4 families. Also 2 sisters who had, you can see the calf hypertrophy, very much, they had a lot of fatigue on walking and fatigue on climbing stairs particularly. And that's the founder mutation that we have in about 4 or 5 families. So this was the first patient who had muscle biopsy and shows classical dystrophic features. So we had nothing more to do at that time. So decrement, see, if these limb girdle myasthenic syndromes, it's nice if you do the decremental response in the proximal muscles, not the usual orbicularis oculi, ADM. They don't have weakness in the distal muscles, so you may not be able to demonstrate the decrement. But you can see we do the femoral nerve. Of course, Dr. Vijay is here, who has done a postdoctoral fellow and done all of these things, are quite experienced. You can see the nice decremental response. We also do of the common peroneal nerve. Well-tolerated, proximal muscles, very good, and patients don't have much pain at all, unlike you do on the facial muscles. And you can see the lovely decremental response in these patients and the nice graphs. Anconeus is another stable muscle, not difficult to do. When you don't find in other muscles, you can do the anconeus muscle. I wouldn't go into the detail, just want to give you a glimpse of what we do. And then if you do not find in any other muscle, you might find the decrement. If you really want to show that this patient has got a neuromuscular junction defect, then you can do that. So we have another group with associated central nervous system manifestations. You can have, these people generally again have a limb girdle syndrome, may have mental retardation and epilepsy, and they generally do not have ptosis or ophthalmoparesis. They can have mild cognitive impairment, as I said, and no other great manifestation of neuromuscular junction. So this is one of the group, GFPT1, where again this patient, you can see she has a little ptosis, this lady, but it was not bothering her, or even the physicians did not notice that. And this boy is actually, you can see his foot, sometimes he walked like a Disferlin gait. So, and his CK was minimally elevated. So 157, not greatly. So we had a mutation in the GFPT1. So you can see that girl, she has a lot of fatigue, but the fatigue sets in after maybe 40 seconds or almost 60 seconds, not dramatic like myasthenia gravis. So this girl, of course, came to us from the child psychiatry department and for mental retardation. And when she had a seizure, they sent to us. And also she had developed severe fatigue. She would just walk 3 to 4 feet and she would just slump down. And then we did admitted her, and we said, okay, it must be myasthenia gravis. Of course, this was 10 years ago. And then we saw that there was a large thymus. And we thought we'll do a thymectomy in her, and we did not have easy access for genetic testing. But we admitted, and the girl ran away saying they didn't want to have the thymectomy. And that was good for them also, because we also should not have subjected. We got the mutation done, and this is called as a DPAC-T1. This is again a dystroglycan CMS, where you can have mildly elevated CK, you can have mental retardation, you can have seizures in these patients. So, and in genetically mediated CMS, even if they may have huge thymus, as I said, they can be an overlap with an autoimmune and a genetic component. So do not subject them for thymectomy. So of course, I'm not going to go into the any of the videos. Of course, all of these videos are nice to see. So rhapsine is one. They can have stridor at birth, infantile stridor. and they can have arthrogryposis at birth, and they can have ophthalmoparesis. So in the world literature, rhapsine is the commonest, second commonest. So CHRN is the commonest, rhapsine. But in ours, it was the least. So there is ethnic differences in the identification and the genes that give rise to CMS. You can see this boy not diagnosed for long, and he had severe mental retardation, you can see, with facial abnormalities. The sister is young, she's very intelligent, and she's doing well now. And so you can see this, both the patients had CK, which was normal, and she's doing well, and they've been treated with pyridostigmine and salbutamol. So this is a synaptic space involvement, okay, called Q. These are slow channel syndromes, important to identify. So I put it in highlight, slow pupillary response. If you find, that's why you have to do a thorough examination of the patient. Slow pupillary response, if you have, you think that it's a slow channel syndrome. And classically, you can have a double CMAP. So look out when you're doing your routine nerve conduction studies for a double CMAP. So this girl came to us about 16 years ago, diagnosed as possibly presynaptic. We missed out on the double CMAP. And we put her on pyridostigmine, of course, from NIMHANS, and then she was on a ventilator till 14 years of age. And then she brought the younger sibling to us of 2 months duration with apneic spells. And then we said, we'll do a genetics, and we found this called Q mutation. Unfortunately, that baby had a prolonged apneic spell back home when they went to Kerala and succumbed to that prolonged apneic spell. Then this girl, all we did was stop the pyridostigmine for her and put her on salbutamol. And you can see she came to our OPD with the tracheostomy. And now the tracheostomy continues to be there because she's been for 14 years. So we could do more harm to the patient sometimes for lack of knowledge. But now we are learning better. We are knowing better what we are doing. So all we have to do is stop the pyridostigmine. Don't start pyridostigmine if you have a doubt. And she's on salbutamol now. She's finished her graduation also. Interesting case. I think another 2-3 slides I should wind up. And you can see this is a slow channel syndrome. This patient came to us at 54 years. My resident called and told, ma'am, there's a case of myasthenia gravis on BiPAP in the ventilator. I said, that's very unusual that we will see myasthenia. So it must be some other thing. But they said she's 54 years, 6 months she's on the BiPAP. I said, fine. When we took the history, right from 22 years of age, she has fatigue. She couldn't carry a newborn baby when she was 22 years. She would just twice or thrice just drop the baby down. And when we said, let's do a genetic, of course. And you can see the BiPAP machine there. And the mistake was she was on pyridostigmine, 4 tablets. She had received immunomodulation already. And so pyridostigmine is what kept her on the BiPAP. So all we did was first in the ward, we stopped the pyridostigmine. We kept her on the BiPAP. We got a mutation called Q mutation. And then we said, we are going to just stop pyridostigmine. So if you give me time, I will show you this video of hers. Of course, I have another minute. You can see this is what she was in the ward. She has very significant fatigue, and she was on BiPAP, she was on tracheostomy, and we stopped her pyridostigmine. I can't fast forward this. Oh, I'm so sorry. Maybe somebody can help me. Yeah. I'm not good, tech savvy at least. Yeah. You can go a little, yeah. So see, this is within 3 weeks after discharge, she's still on the tracheostomy, and she's able to, I know, of course, when you fast forward, sometimes, it keeps loading. And she's at home, her fatigue has come down, you can... Something happened? No. It's still loading. So she improved very well just with salbutamol. She's on 8 milligrams of salbutamol. Her tracheostomy was closed after 6 months. And of course, sometimes these are very heavy videos, and so it tends to this thing. So she's doing very well. Now, that's really rewarding for the treating physician or the neurologist when you see a patient who wants to be on BiPAP lifelong, and anytime they could get blocked or they have so much of trouble. So there are many patients like this of us who were on tracheostomy, who were on BiPAP, and now that we have just... so that's the thing. And then I will go on to the conclusion slide. So you can, of course, she improved very well. So you can have this repetitive stimulation. You can see the double C map in the patients when you do the normal. So just give me another minute, and I'm going to, because of this thing. So therapies, just 2-3 slides I'm going to put. So just understand whether it is slow channel syndrome or it's a fast channel syndrome. Is it the group of disorders where you should not give pyridostigmine, and is it a group of disorders where you can give salbutamol? No issues, you can give for any form of the disorders. Slow channel, you decide on fluoxetine, as I already told you. In the genetic report, they will tell you is it a fast channel or a slow channel. Even at CHRNE, there are slow channel group of disorders. So do not give them pyridostigmine, although you can give them salbutamol. So this is the overall picture, and you can see. So what's the dosage? Let's go to pyridostigmine. Like any other myasthenia gravis, you can treat them. There's nothing great, up to 480 milligrams per day. Salbutamol, and this is 3,4 DAP. Of course, it's not available, so I won't tell that. Salbutamol, we just start with 1 milligram per day for about 2 to 3 weeks. As I said, the doctor needs to be patient. The patient needs to be patient. The endurance is what is important. Salbutamol takes time to act. They may develop some tremors if you start them on high dosage, dyspepsia, insomnia, and tremors. So it takes, as you see, it takes months to a year for clinical effects, but be slow. The effect is very good. And judge the efficacy only after a few months. Tell the patient that it's going to take time. And you can see the dosage which I've already written. Literature says up to 16 milligrams, but one of my patients is on 32 milligrams per day, DOC7, doing excellently well. I know he's from Andhra Pradesh. He came on a wheelchair at 28 years and never walked in his life properly. And after we gave him salbutamol, and within 1 month he called back in Telugu, I don't know. He said, Nenu cycle toktanu ippudu, nenu pendli cheskunnanu, pilla puttindi, and everything he told me on the phone. So it was very, very thing. And now and he increased the dosage by himself to 32 mg. Although I said don't go beyond 16. So he's taking 32 mg on his own and he's doing very well. So this is how we learn medicine from our patients itself. So and now I'm very confident that even up to 32 mg we can give the patients. So fluoxetine maximum is 120. You start with 20 mg and slowly increase. And only one of my patients is on 100 milligrams. But please tell all the side effects of fluoxetine about suicidal risk and let them be on observation. So to conclude, let's say that CMS are potentially treatable disorders, usually mislabeled as congenital myopathy, mitochondrial disorders, anything that you want. Needs a high degree of clinical suspicion, like a CID. We have to go on asking, look at old photographs, look at childhood photographs. Don't miss out on that. Don't miss out on the dystroglycan group, which can have high CK. Don't make a diagnosis of LGMD. Do RNS, even if you think it's such a non-invasive procedure, and if you get a decremental response, be very happy. At this minute, I have 2 CMS in the ward, and most likely the child has a DPAC T1 with mild mental subnormality and easy fatigability. And treat cautiously and be patient. As I said, salbutamol takes weeks to months. Avoid pyridostigmine till genetic confirmation, and it can be dangerous. And I think with that, I end my talk, and thank you for the extra 2 minutes that I got.
Thank you very much. If possibly, I usually don't allow those 2 minutes. But because the topic was so exhaustive, and possibly it required the whole day of congenital myasthenic syndromes to talk about, because even then, possibly you will understand a little more. One small suggestion to clinicians otherwise is when you see a patient with ptosis, please ask for a previous photograph. At the age of 5, at the age of 12, at the age of 18, you will get them. Nowadays, everybody has a cell phone. Everybody go on, but maybe a question or two from the audience.
Oh, hi, Rashid. Come this side. I know you can't see me. Nice to see you, Reshma. Yeah.
Hello,
yes.
ma'am. Sometimes we see patients with congenital myasthenia syndrome having ACHR antibody. We had an ALJ14 with ACHR. So in those cases, should we treat them with immunotherapy as well, or only the treatment for CMS will suffice, ma'am?
Yeah, I think I showed a slide where ACHR came positive, the child was on immunomodulation. I think we should not. As I said, there can be an immune response to a genetically mediated defect at the neuromuscular junction. So I think we should just treat them as a genetically mediated disease and not, because they were not going to respond.
Thank you.
Thank you.
Yeah, thank you very much. I've heard this talk before also in many meetings. One question is there any overlap between genetic muscular dystrophy and CMS or no? I mean, no, many of them may present as limb-girdle syndrome. But suppose if somebody, to give an example, if somebody has Becker's dystrophy or something, is there an overlap or no? Not really.
No, there are CMS with combinations. So CMS with congenital myopathy, CMS with mitochondrial, and now I have a case of CMS with possibly plectin, that is LGMD2Q. So you can have CMS, but the component of CMS may improve. So it's very well known that you can have two diseases together, CMS and a combination of others. LGMD2Q, particularly with plectin, is well known with CMS. So possibly they won't dramatically improve like the pure one.
Yeah, Nalini, that's an excellent lecture. I'm listening for the first time on congenital myasthenia. Okay. So my question is, as a general neurologist managing with neuromuscular diseases, how do you really approach when a patient comes with either ptosis or a limb girdle? Directly do genetics after doing one decrement and the EMG, so that you are sorting out for the patient first and then approach the treatment?
Yeah. Thank you, Sita.
And how reliable this genetics is? Now, because everybody is getting coming with a genetic report.
Okay. Thanks, that's interesting. See, now our clinical approach to neuromuscular junction, I mean, for any person with myopathy or muscle disease is, I mean, I can have the hand phone. Yeah, of course, it's the last question permitted to me. Okay, so when you have a myopathy or a muscular dystrophy, our first approach is that clinical phenotyping, bedside phenotyping is important. Most of the time we will know that this is what the patient has. A bedside good phenotyping has to be done. And our approach more than a decade now is genetics straight away. If we know that we have not dealt with acquired disease, it's genetic. Many times it looks very much acquired, but it turns out to be genetic if you take a history. So it's more than a decade. We've stopped muscle biopsies now. In a year, we used to do 2,000 biopsies.
I think you answered the question, Dr. Nalini.
Yeah.
Thank you very much for a very excellent talk.
Thank you. Thank you, madam. Now I request our resident, Srinath, to present a patient on, I would like you to present it as brief as possible. Okay, hold on.
Good morning, everyone. This is about a 25-year-old lady. She's a dentist by profession who was slow compared to her peers in her childhood and had difficulty getting up from squatting positions since she was a child. She had easy fatigability and diurnal variations in her symptoms. She was okay till about 12 years of age. Then she had worsening. She had slurred speech, dysphagia, and ptosis requiring admission. She was treated symptomatically only. Then RNS was done, which was positive. So she was started on low-dose steroids. She was diagnosed as myasthenia gravis and pyridostigmine. She stopped steroids after 3 months because she gained weight. And she was managing her studies and all on pyridostigmine alone. Then she had another exacerbation 1 year back after a viral illness and intake of azithromycin. She was advised admission and IVIG, but she did not take it. CPK was normal, ACHR and MuSK antibodies were negative, RNS was done, we showed decremental response. We examined her when she came here. Higher mental functions were normal, extraocular movements, there was ophthalmoparesis, and bilateral ptosis was present, facial muscles were weak. There was fatigability, and in power in proximal upper limbs was 3/5, and distally it was better. Proximal lower limbs was also 3/5, and DTR were normal. This is bilateral ptosis we can see, and also restricted eye movements that we can see. And this is the facial weakness. There is weak orbicularis oculi action. Here we can see that she had proximal weakness also. She was not able to get up without support. And there was considerable fatigability. She was not able to hold her hands even for 20 seconds. So, in view of the childhood onset, ptosis and also fluctuating weakness and RNS being positive, a diagnosis of possible congenital myasthenic syndrome was made. So, we did a whole exomic sequencing, and ChRNA was positive in this patient. So she was treated with low-dose steroid, prednisone 5 mg, and salbutamol was started 8 mg per day, and she is continuing on pyridostigmine thrice a day. And she did not have, earlier she was treated with fluoxetine, for which she did not have any benefit. Even on current medication, she has only modest benefit, and she is able to carry out her daily activities, but wants further improvement. So coming to the clinical question, how can we further manage the patient? And are there any clues to the early recognition and diagnosis of congenital myasthenic syndromes? Thank you.
Can you go back to the genetic report? I think I've told most of the points that you wanted to know in this case. So here, I don't know, see the myasthenic syndrome 4A slow channel is written. How much of pyridostigmine is the patient on?
60 TID or QID is taken.
So can we reduce on that? Because there is something, there is slow channel or there. Sometimes that pyridostigmine can be harmful for this patient. Okay. They will not show the same response. Instead, because of course, the second one, when they give like this, yeah, but I agree, but if the patient is not responding very well, because there is a component of slow channel also, yes, then that's also autosomal recessive. So just to see, it may be a permutation, combination or trial, you reduce on the pyridostigmine or stop the pyridostigmine and see. Sometimes they will say they want pyridostigmine, so you can just put on 30 mg or 60 mg. That won't show greatly cause damage. Increase the salbutamol. What is her weight? She may be around 50, 60 easily, whatever from 50, the picture that we can 50. See. So she's on 8 mg. Yes, go up to 16 mg. As I said, you can go up to 24, 32, but go very, very slowly. Okay. They will improve, but see, some have dramatic improvement, all may not. And sometimes there is a neuromuscular junction damage because of chronic, what we call as myasthenic myopathy. So myasthenic myopathy patients may not respond. If you do MRI, muscle may show fatty infiltration, may show a lot of degeneration. So myasthenic myopathy is a constant inaction of the neuromuscular junction. So goes in for like a myopathy. So this, if that is set in, they won't improve very well. But still, whatever, I think you should increase salbutamol maybe to at least 16 mg, because just 8 mg, slowly up to tolerable. Reduce on your pyridostigmine. And then fluoxetine you add with salbutamol, because there is a thing. So that's not the thing. Both are given. So actually, if we have to do functional studies in this, then we will do. Sometimes we are doing some functional studies as a project, but homozygous. So because they have also mentioned slow channel, we can try this. If they had given just fast channel, there's no issues. But increase salbutamol. Because a slow channel, you can add on fluoxetine, even any other patient with depression can get. So that's not a problem. So reduce or stop pyridostigmine and see what the response is. They're not going to develop any major thing, because it's just a limb-girdle syndrome over here with ptosis. I think that's what I had already told in my talk. But an interesting case. Even she has some little finger drop, as you saw in that video. So that finger drop, no need to show that. You can see her finger drop, like, no, it's not fully thing, but she has a wrist drop. So usually in slow channel you see this dropped finger, like, no, particularly this position you can have. The moment we see that, we make a diagnosis of slow channel syndrome. So she does seem to have some wrist drop and finger drop in there. Even that can be fatigable. Okay, I think I've answered your final question.
Thank you.
You can do the reanalysis of the data also, so that which is more definitive, so that you knock out what is not very definite and then have a more proper diagnosis. At least genetically.
Thank you.
Thank you.
Thank you, madam. Just cases which are very difficult or some we wanted some valuable opinion, we are trying to present, madam. Yeah.
Absolutely, my pleasure. Yeah. If I know, I'll answer.
Madam. Yeah. Now I request Dr. Murli to come and present on a very important topic for neurologists, I will say. His areas of interest is definitely muscle ultrasound, and nerve ultrasound, and ultrasound per se. I would now request Dr. Murli to present his presentation.
At the outset, I'd like to thank Praveen sir for inviting me to this talk. It is also a privilege to talk regarding my work and also my experience in front of all the seniors in this field. So the topic given to me is muscle and nerve ultrasound. Actually, it is very, very extensive. I would like to cover it very, very fast. So, neuromuscular ultrasound has come into the neuromuscular subspecialty in a very big way. Neuromuscular imaging we do by the nerve ultrasound and also the MRI. Ultrasound has its own positives because it has a very high spatial resolution and we can actually pick the area of the interest in a very focused manner. Whereas MRIs are definitely useful in the proximal areas of the nervous system, that is the plexus imaging and also the deeper tissues than the ultrasound. So first we'll deal about the, first I'll just touch upon the focal entrapments and focal neuropathies, then we'll go to polyneuropathies, then we'll go to the muscle ultrasound, and then we'll go to the ALS, the role of this. These are the various diseases where actually the ultrasound definitely has a role. So this is usually this is the anatomy of the nerve. This is a cross section you all must be aware of, and this is the ultrasound picture. So you can see here there are it is like a honeycomb picture. This is the median nerve at the wrist where you can see both the perimysium and the perineurium and epineurium which are hyperechoic, and the fascicles which are hypoechoic. And on the longitudinal section we see it like something like a cable where actually you see many in between the epineurial hyperechoic lines. There are multiple hypoechoic lines. So this is a normal anatomy of nerve when you see on an ultrasound. So let's go to the carpal tunnel syndrome. This is the most common syndrome where actually it has been, the literature has been existing since almost 2 decades in this area of peripheral nerve. So this is the cross section line diagrams, and this is actually the same nerve which I have shown before. This is as you can see there are many tendons here. These are all the tendons. Tendons are actually so when you actually tilt the probe, the tendons actually get either hypoechogenic or hypoechogenic, whereas the nerve will not change because it is less anisotropic when compared to the tendons. So that is the way we actually identify the median nerve at the wrist. So whenever there is any compression, carpal tunnel compression, we actually see the, obviously when there is a compression, there will be the increase in the cross-sectional area or the nerve edema just proximal to that. So that we actually see it as an increased cross-sectional area at the wrist. We measure the cross-sectional area inside the epineurium. So as you have seen here, this is the way we measure the cross-sectional area. So, but the cross-sectional area varies with the age, with the height, with also the BMI of the patients, and also with the gender. So actually what literature has shown that there was a swelling ratios, what they have actually measured at the wrist, they have measured at the level of the pronator quadratus proximal to that, or they have measured the second measurement in the mid forearm and they have done the ratio so that the patient himself is a control. So if that kind of ratios also were shown to be actually useful in diagnosing carpal tunnel syndrome. There are many other parameters like vascularity, fascicularity, mobility, where actually when we actually flex the wrist, usually the median nerve dips behind the tendons, but if we don't, that kind of elasticity usually will be lost in very severe CTS. So many times when we do ultrasound for the CTS, actually we see bifid median nerves. So bifid median nerve is an anomaly. Actually, there are many types of bifid median nerves again. There could be high bifurcation and they actually divide into ulnaris trunk and also the radialis trunk. This is one of our case, as you can see. Usually such kind of anomalies are usually associated with the persistent median arteries or the persistent median veins, or sometimes accessory muscles also. They can be associated. This is 1 hour patient where actually there was a pulsatile persistent median artery. I would also tell my experience. We saw one patient where there was an acute CTS. Usually we don't call it as an acute CTS. There is an acute thrombosis of the persistent median artery when we saw, and that patient got relieved with just anticoagulation. Such kind of presentations we can see. Bifid median nerves are very common, but whether they are associated with CTS or not is still controversial. There are many factors, like usually if the radialis trunk or diameter is circumference is more than the ulnaris, then there are studies such that actually some factors they are more prone to get the CTS. And CTS, especially in severe CTS in a clinical practice, we do suggest surgery when there is muscle atrophy, when there are fibs in the APB and other things. If there is a patient with mild to moderate CTS and are not willing to take medicine, or medicine is not suiting her, or they are not responding to the medicine, we can actually do hydrodissection. As you can see in this video, we have done hydrodissection in this patient. You can see in the in-plane mode there is a needle going on. This is a median nerve. It is going there, and I am injecting saline with I have injected saline with the steroid. This is actually superior to the nerve. This is a carpal ligament, and in between the carpal ligament, I have actually expanded the nerve. So this is we inject around 2 to 2.5 ml, and this is behind. So we are going behind, so that we free the nerve completely from the adhesions, so that actually the patient gets relief. Actually, in our experience, we find that this technique actually is they'll get relief within 1 week to 10 days, and it usually lasts for 3 to 6 months to 7 months also sometimes. But sometimes patients need second and third injections too. So that's all. So next we'll go to the second commonest entrapment neuropathy, UNE. UNE, that is ulnar neuropathy at elbow, is slightly heterogeneous disease when compared to the carpal tunnel syndrome, because the entrapment can occur proximal to the elbow, it can occur behind the olecranon, medial epicondyle, or it can occur below the medial epicondyle, in between the two heads of the flexor carpi ulnaris also. Again, this being an entrapment, cross-sectional area is very important marker, and swelling ratios have been studies. They all actually were shown to be very sensitive. And one important thing that we have to see is many people will have dislocatable or subluxating nerves. Whenever we do ultrasound for the ulnar neuropathy, we have to do a dynamic ultrasound, that we do the ultrasound in the extension position and also slow flexion. When you do flexion, if the nerve actually translocates anteriorly, then probably the patients must be having a slapping ulnar nerve syndrome if the patient is symptomatic. So that is another advantage of the ultrasound which we don't get in the MRI. This is one of our patients where the patient had bilateral cubital tunnel syndrome. As you can see here, there was a focal enlargement just behind the olecranon. As you can see, this is the olecranon. This is the medial epicondyle, and there is a nerve enlargement proximal to that and distal to that. Actually, there was no. This is just this is the flexor carpi ulnaris muscle, and the nerve appears normal in size. This is a case of bilateral cuts. And many times, in case of patients who are long bed-bound patients, post-operative patients, and who are recently lost weight, we see fibular nerve entrapments also at the common peroneal nerve. And again, it is very common. And especially ganglions, extraneural and intraneural ganglions are very common. These should not be missed. As you can see here, this is a fibular nerve entrapment which was relieved and patient became better. So, and there is again role in traumatic neuropathies. This is another focal neuropathies, especially when the patient comes in acute trauma. We cannot do any kind of electrophysiology because of the pain, or because we don't know the underlying anatomy. There will be a lot of edema. Patients will be in casts and many things. Neuromuscular imaging definitely has actually superior role when compared to electrodiagnosis in the acute phase. And in the later phase, when the patient is not recovering after the nerve repair and other things, we can actually do the ultrasound to see for the fibrosis, pseudoaneurysms, neuroma, all these things. Especially when there are plates also, then ultrasound definitely has a role. Sometimes we cannot do the MRI. And the traumatic brachial plexopathies, definitely ultrasound will have MRIs will have a better role than the ultrasound. So definitely traumatic neuropathies in the acute phase and in the chronic phase, it is definitely useful. And in the early phases, it is more superior compared to the electrodiagnostic studies. And this is a case of ulnar nerve trauma with a glass cut, as you can see here. So this is this patient was not improving actually. As you can see, in the longitudinal section, there is a large traumatic neuroma which is actually hindering the recovery of the patient. That we had actually operated the patient. And many times when we do ultrasound, we see many peripheral nerve tumors. They may be tumor-like lesions like Morton's neuromas. They can be tumor-like lesions like the traumatic neuromas. They can be benign tumors, malignant tumors. This is one of our patients with neurofibroma, which actually initially the patient didn't have much swelling also to the outside. Actually, it was very little swelling. If you see carefully, the patient appeared like CTS. When we do the conductions, there was a conduction block in the mid-arm, and this is a picture. We operated, patient became better. So definitely focal neuropathies, ultrasound definitely has a role, and we'll summarize at the end. Then we'll go to the big chunk of the diseases that we see commonly. These are polyneuropathies. So infections, definitely Hansen's definitely ultrasound has a role. The main intention of treating Hansen's is to prevent the nerve damage, whether it is an active disease or an inactive disease. Active disease, there will be a lot of intraneural vascularity which is manifested by the color Doppler, and there will be long segments of the nerve thickening. Clinical examination, we just tell it is thickened behind the elbow, behind the fibula, but when you see in the ultrasound, there will be long segments almost to the extent of 10-15 centimeters. And we see thickened epineurium and completely distorted effaced architecture also. And we now see patients have completed the treatment with also all the residual deficits. If you do ultrasound, we see the nerve atrophy or nerve fibrosis also sometimes. So pattern recognition of nerve enlargement is very important. So this is ulnar nerve of one of our patients. So in Hansen's, actually, there will be like we saw in patients with cubital tunnel syndrome, there was a very discrete enlargement just at the level of the elbow, whereas many times we see pure neuritic, pure mononeuropathy of the cubital tunnel. I mean, it is a ulnar neuropathy which is non-localizable, or just there will be mild thickening or no thickening. The patients will end up getting Hansen's treatment in our country. If you do ultrasound, then we can see long segment of the nerve thickening just above the level of the elbow, which is very typical of Hansen's. And this is a median nerve enhancement. Even median nerve is isolated, is not usually affected in Hansen's, but if it is affected, usually the level of the enlargement will be proximal to the carpal tunnel, unlike the carpal tunnel syndrome. This is very typical of Hansen's neuritis. So, and as you can see, small vessels, smaller nerves also we can see. This is one out of paper. This is the greater auricular nerve. So, likewise, we can see the superficial radial nerve, sural nerve, and also superficial radial nerve and peroneal nerves also, which are very thickened, which are hypoechoic and disc and architecture. So these are very typical features of Hansen's. Next, the other major diseases which were actually researched a lot in nerve ultrasound was CIDPs, demyelinating neuropathies. Demyelinating neuropathies actually are per se, there is a demyelination with remyelination, so there will be nerve thickening otherwise too. So CIDPs were a lot researched in this way. So these are the, in addition to the nerve enlargement, there was a vesicular. As you can see here, if I can show you, so now we'll have a lot of vesicles. There will be an isolated vesicular enlargement with the nerve thickening, whole nerve being normal in case of CIDP, or only few vesicles will be enlarged, or completely the nerve can be enlarged also sometimes. So Padua has actually proposed this classification. So telling that actually the class 1 will have more of hypoechoic vesicles in CIDPs, class 3s will have hyperechoic, sorry, it is a typography, hyperechoic vesicles. So patients who have hypoechoic vesicles in CIDPs are more treatment responsive is what they have actually proposed. But such things must be actually dealt in a very large series of patients. Paraproteinemia, some resemble CIDP, some are demyelinating, like IgM paraproteinemias, MAG, anti-MAG associated poems, especially, they have actually thickening, they have enlargement of the nerves. And GBS, yes, GBS, the enlargement is usually patchy, proximal, and one more important thing in GB is there will be enlargement of the vagus nerve, which we can easily visualize when we do the carotid in the carotid sheet between the artery and also the vein, jugular vein and also the carotid artery. It will be enlarged. If the enlargement of the vagus, it is usually associated with the dysautonomy and the respiratory failure in patients. And there will be marked MMNCB. Actually, many times we have a difficulty in differentiating MMNCB and also the ALS clinically. Such patients, there is a study also showing that if the nerves are enlarged, most likely that must be MMNCB, unlike the ALS. And MADSAM, as clinically, even ultrasound also showed asymmetrical findings, upper limb dominant findings. The most and well researched actually hereditary neuropathies are CMT1As, where always there will be thickened and homogeneous enhancement. I will show what is homogeneity in the patients. So this is our data which we presented few years ago. We actually seen the cross-sectional area at various in the nerves, and we actually calculated the intranerve variability of various nerves. So as you can see here, there was a wide intranerve variability of the median nerve, ulnar nerve. There was a difference of 9.75 centimeters in CIDPs, whereas in HMSNs it is hardly anything. That suggests that actually in HMSNs or hereditary neuropathies, the thickening is more of a uniform, rather not, whereas in case of acquired demyelination, it is heterogeneous. Likewise, same will reflect in the conductions too. So this is one of our patients of CIDP, where you can see large vesicles, as you can see here, vesicular distortion. So again, metabolic neuropathies, there is a lot, we see lot of commonly metabolic neuropathies, diabetic neuropathies, but most of the patients, what we call in the literature is, if at all there is nerve enlargement, which is more than 2 standard deviations in patients with diabetic neuropathy, probably we may not be dealing with a diabetic cause of neuropathy in that patient. So that is actually a hard fast rule. Most likely the diabetes, usually it will be normal. And next, this is a case of diabetic neuropathies, and with and other axonal neuropathies. There are no large-scale studies in patients with chemotherapy-induced neuropathies, Lyme disease, sarcoidosis. There could be some thickening, amyloidosis. There could be some thickening, but in acquired amyloidosis, usually there are no studies. Toxic, it is confusing. Vasculitis, there may be mild to normal size. Storage diseases like Krabbe's disease, especially there will be thickening of the nerves. So at the end of the polyneuropathy sessions, what it is if the nerves are definitely thickened, in hereditary neuropathy it is usually CMT1A. We can straight away screen the patient for PMP22. If at all the patient's nerves are very much thickened and it is asymmetrical and it is heterogeneous, probably we may be dealing with a patient of CIDP. So, and axonal variants, usually they are normal, nerves appear normal. So it is more about the pattern recognition in patients of polyneuropathies. As I have seen, we measure the nerves at various sizes. We picture out how his patient's nerve enlargement is there on a body map. If you actually just superimpose the body map of the nerves of the enlargement, then we will know how the nerve picture is there in the patient. So that is about the polyneuropathy. So we'll summarize at the end. This is one of our sarcoid patient where the nerve was enlarged. And just 4 slides about ALS. ALS, you all know, fasciculations are very important. Fasciculations have become important from the time Awajishima criteria has been in place. And but fasciculations are not so easy to detect always in patients after needle, because the radius where the needle records is very small. But when you do the ultrasound, the amount of it has a very broad range. So we can actually pick up lot of the area of fasciculations. So that's why actually fasciculations we see on M mode like this. We see as crack. This is a tongue fasciculation. We see as a vertical crack on M mode. Even fibrillations also we can see on ultrasound, but it is it is little bit difficult. They appear just like a worm-like movements. This is one of the very elegantly done study in 2013. As you can see here, Awajishima criteria are definite and probable. If you add ultrasound to that, include the ultrasound derived fasciculations, the diagnostic accuracy actually definitely increases. So this is one of our data which we presented before in 2020. As you can see here, we took almost 20 seconds to record a fasciculation clinically. By EMG 25 seconds, by HRUS it is 9 seconds. We put a scan, immediately we pick up an ultrasound. It is very early. And the number of the sites, the pickup rate for fasciculations also is very high when compared to the EMG. So I'm not showing whole of the data. Then there is little bit of data about the muscle degeneration in ALS also, because the atrophy is a very inherent property in ALS. So echo intensity of the muscle is what we actually see. The muscle thickness is what we see. So it has been actually shown that the muscle thickness is associated with the long time survival. Right now, for the progression, we don't have any marker except the ALSFR index or KIMS staging that we actually do, which we are predominantly clinical. But muscle ultrasound is one which we can use to see the monitoring of the disease also, though we are more interested in the diagnostics. So diaphragm ultrasound, it is very important and very easy to do. What we do is thickening ratio. We do the diaphragm diameter in the peak expiration and also inspiration, and see the thickening ratio, whether that thickening ratio is important or not. So this is one of our patients just for the talk I actually took. This is a thickening ratio of the patient. So whether this is associated with this partial, actually it has been shown that thickening ratio correlates with the partial pressure of the carbon dioxide and also the vital capacity. It is not so easy to do PFT and other things easily, but ultrasound diaphragmatic thickening, it is very easy, hardly 2 to 3 minutes, and it has the best inter-rater variability in any measure on ultrasound. That's all. This is one of the studies where they did a peripheral nerve ultrasound differentiating the MMNCB, which I was telling before. Next, we'll go to muscle. So this is a normal muscle. This is a axial sections, as you can see here. Same. It is what you call it a starry sky appearance. And visual grading of the muscle, we actually grade the echogenicity of the muscle by actually 4 grades: 0, 1, 2, 3. 1, 2, 3, 4. 1 is normal. Rest of the 2, 3, 4. How do we do? We actually take 3 parameters. One is the subcutaneous tissue. Next is the bone. Here you are able to see the bone. Here you are able to see the subcutaneous tissue. When you see here, this is grade 2. The subcutaneous tissue has increased. The bone is still seen. It is slightly darker. In grade 3, we are not able to see. Little bit of bone is seen. And in grade 4, there is no bone which is actually seen. So because the muscle has become so fibrous that it is reflecting a lot of the sound waves, and that bone we are not able to see. So this is a semi-quantitative grading of the muscle system. So muscle ultrasound is useful. Main thing is whether it is a muscle or a nerve. Even by EMG also, that is what actually we look for initially. So we are dealing with a neurogenic process or a myogenic process. Myopathic process actually has a homogeneous ground glassing or rubbed out paper kind of appearance, whereas neurogenic process, because in a patient with partial denervation, partial reinnervation, what happens is some motor units are actually still functioning. That's why we see some areas are normal, some areas being abnormal in ultrasound. So, and muscle ultrasound definitely has a role in ICU weakness, where we cannot actually do EMG and other things. EMG guidance in difficult muscles, we actually do the scan, allocate the muscle, put the needle, we don't know where we are, and especially inflammatory myopathies, see where the echogenicity is more and take the biopsy also. And pattern recognition. Pattern recognition is always like polyneuropathies. Even in myopathies also, pattern recognition is important. So like you can see here, the total muscular dystrophies, the atrophy is rare. Myopathies, the atrophy is commonly seen. Inflammatory myopathies, see-through kind of appearance will be seen. And this is one kind of ultrasound. This is a paper in 2014. As you can see, this is a way to demonstrate the FDP and FDS. The way I was telling on the first scan, this is the oval muscle. This is a FCU, flexor carpi ulnaris. You can see this is preserved. Even this is also preserved. That starry sky pattern is seen. In inclusion body myositis, this is preserved, whereas FTP is gone. This kind of selectivity is very typical. If IBM, we see deep flexors are involved. This is what is deep flexors. Here FDP is involved, whereas FCU is spared. So again, these are some of our cases. Inflammatory myopathy, where we are seeing some areas are spared, some areas are involved, and this is the way we measure the muscle subcutaneous tissue thickness and also the muscle thickness. And this is one of our case of dysferlinopathy, which we saw recently. And even ultrasound is useful to follow up patients of dermatomyositis who are once the treatment is responsive or not also. So though we have not done any long-term studies, this is a study which was done in the literature, which I have published, which we have shared. So that is a summary of a big topic of nerve muscle ultrasound. So the take-home message will be ultrasound can serve as an important tool for neuromuscular imaging. The other one is MRI. So I have told you the importance in cuts, secondary CTS, bifid nerves, and also the nerve interventions. Cubital tunnel syndrome, I have shown you. The fibular entrapments I have shown you. The important parameters, CSA ratios, anatomical variations, and any accessory tendons. And role in trauma is definitely there, and peripheral nerve tumors. Hereditary neuropathies, they are diffusely enlarged nerves. They are more of homogeneous patterns. There are various scoring systems to see how the pattern of involvement is there on the ultrasound. Inflammatory neuropathies, there will be patchy involvement, multifocal enlargement patterns. It is a useful biomarker for therapies also. Leprosy, it has become indispensable. Any patient with leprosy, we invariably do multiple times to see the continuation and also the steroid therapy, etc. It is an indispensable to assess the nerve damage. Axonal neuropathies, still they are a lot under investigation. There is no. I cannot give you any take-home message on axonal neuropathy per se. ALS, as I have shown, fasciculations, echo intensity, we can actually see preclinical phase only whether the muscle is getting degenerated or not. Diaphragmic ultrasound definitely has a role. Myopathies, pattern recognitions, diagnostic values, I told. Ultrasound also can assist in difficult conductions and EMG areas. It can help in Botox. It is of immense value in giving injections, as I have shown in CTS, meralgias. I have not shown meralgia, and botulinum toxin injections too. Thank you. I'd like to invite you for our conference also, which we are doing in the last week of this month. This is the National Midterm Neurosonocon. Thank you.
It's such a wonderful talk. Really, we enjoyed you covered everything in this. Actually, it was such a extensive, and you covered it within time also. So, any questions?
Thank you, Murli. Based on the ultrasound alone, can we diagnose and treat leprosy, even in the absence of a biopsy? Because sometimes you may not have biopsy proof.
Yes,
Thickened
sir.
ulnar nerve, for example.
Yes, sir. Yes, sir. Actually, it is a pattern, sir. Ulnar nerve in leprosy will have a typical pattern. It is enlarged proximal to the elbow, and it is enlarged very lengthy segment all throughout the arm. Also, sometimes it could be enlarged. Whereas it is another common differential is a entrapment at the elbow. It will not have so much long enlargement. So we have not been doing biopsies, sir, especially.
Do you think ultrasound in the coming time will replace EMG totally, especially for ALS and all?
No, sir. Actually, even now the literature is there that the number of the EMG areas or the needle examinations that we do is definitely by ultrasound we can reduce it to make a diagnosis. But regarding replacement, maybe yes, but we need more superior scanners and other things actually. Even now, even what I told, fibrillations also, even fibrillations, it is shown that EMG is not superior. Ultrasound is not superior than EMG in fibrillations.
Yeah, thank you. Excellent talk. Learned so much more. Of course, now, again, I would say it's a decade that we stopped doing the painful procedure of EMG. It's just absolutely stopped. We just do ultrasound. If ALS patient says he has fasciculations and we can see it, we don't have to really confirm it. So we just do ultrasound, paraspinal also. And tongue is so easy, and it's external. Just put it on the hyoid, close to it and do. So Dr. Vijay and all are here. So extensively we do ultrasound. The patient has no pain. They're happy to lie down on the bed. They sleep off also when you're doing your ultrasound. So unlike the EMG. We don't need actually. If your CK is 30,000, why do we need EMG for them? I always say, big calves, 30,000 CK, why do EMG at all? So that's really now EMG is such a painful procedure. The patient comes, we say we'll do some electrical testing, does fasciculations clinically, LS, Corial or Avaji, whatever Gold Coast criteria. And then you put a nice muscle. See, we have a muscle ultrasound for ourselves. It's just 20 lakhs. But of course, there's a 1 crore machine we have published on the nerve ultrasound and all. We have done the normative data for the upper limb and lower limb, doctor. It was one of the thesis. So we did it in this high-end EPIC 7, where it's in radiology. So we use that machine. That gives you fantastic images, of course. But our ultrasound worth 20 lakhs is more than enough now. It's about 8 years that we have. And our residents are very happy to just put the probe and keep demonstrating the fasciculation. So I think we should, at least we've given up on this painful procedure.
Can I say something too? I think you are echoing my thoughts over the years. I think we started with electrophysiology, do EMG, then subsequently do other studies, sometimes MRI, sometimes ultrasound. I think in spite of all this, the clinical stands a very good chance against anything else. And to a large extent, in my practice, I have excluded putting a needle. It's more because needle, if it is to be done, it has to be done by a good person behind it. Same thing with ultrasound. Mind you, the person who has done it, like he does, then I think it's fantastic. But if somebody indulges it or dabs, just I will also do ultrasound, it doesn't work properly. This is very important, like possibly clinical medicine, clinical neurology, by and large. That's, I think, the most important thing. You can exclude a lot of things. You know that you can predict this is what I'll see on MRI, this is what I will see on EMG, this is what I expect on EMG when I do it. So you tell that this is what I'm expecting and then do it, rather than otherwise.
No, I was going to say that it's very nice that all these different methods are available, and each one has its good points and not so good points. In difficult cases, it helps to have as much information as possible, and then you can actually see that the problem is more complex than what you imagine. But in a routine scenario, like Dr. Mohandas said, it's first the clinician, then your setup. I mean, in your setup, certain things are done better than the others, certain things may not be up to there. So every setup will work differently. So it's not an absolute thing. It's a clinician-driven and a setup-driven method of reaching the diagnosis. But more complex the case, more information you get from the more the method you use. Yeah.
As there are no more questions, once again, thank you very much, Murali, for a wonderful talk.
Yeah. I request Mohandas sir to kindly come, sir, felicitate Nalini madam and Thank you, sir. Now we will have a brief inauguration. We have with us Dr. Bhaskar Rao, sir. Bhaskar Rao, sir, our inspiration. He's a first-generation entrepreneur and the founder of KIMS Hospital and all the hospitals, many hospitals under the group. Not only that, he is primarily first a cardiothoracic surgeon. Therefore, a cardiothoracic surgeon who went on to establish such a big group of hospitals to the extent that the market cap is now more than 16,000 crores. That's all in single lifetime and still going on achieving. That's the inspiration for all of us. To start this practical neurology, as I told, the neurology is improving by leaps and bounds. Even for this neuromuscular subsection, now we have about 100 attendees here, and on YouTube Live also about 50 people are seeing. Therefore, as we have learnt this ultrasound or the genetic studies, we have to learn about them. Therefore, they are conducting this, and it will be conducted every 6 months. And in every 6 months, we will try to focus on a specific subset of neurology. I will request Bhaskar Rao sir to kindly come for the lamp lighting. Mohandas sir. Oh, Kaul sir. Sita madam. Madam, please. Lakshmi madam, please. Jayashri madam. Anuja. Madam, Khadilkar sir. Sir, Vishnu sir, please sir. Please sir. Please. Madam, please.
Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Deepajyotir parabrahma. Deepajyotir janardanah. Deepajyotir parabrahma. Deepajyotir janardanah. Deepo hartu me papam. Sandhya deepa namostute. O deepa brahma rupasvam. Jyotisham prabhuravyam.
Now I request Mohandas sir to say a few words, sir. No. Vijay? Where is Vijay? Oh, sir, Murthy sir, please sir.
It's nice to welcome both the delegates as well as the faculty, and also congratulate our department, especially Dr. Praveen, to have initiated this program. I think the person behind him most of the time is Sita, although they gave me the credit. Sometimes I take it, sometimes I don't. But just going back a little while, and it's not all that little while, I started my career in neurology in 1971. 71 was where I joined as a house surgeon to Dr. Gauri Devi in Safdarjung Hospital. And I never left neurology after that. Of course, I decided in my undergraduate career to do neurology, which has brought me up to this place. And why I didn't leave is I did my MD in medicine same time. I worked as an ARO in ICMR along with Dr. Gauri Devi. We dissected a lot of circular villis for their abnormalities. And then subsequently, Dr. Gauri left for NIMANS. No, it was a little later, but she went in between to London, Queen Square, and she was doing a lot of nerve teasing. So I learned sural nerve biopsies at that point of time. We did phrenic nerve stimulation. So I think this is how you add on something. And slowly, you also know how to dispense with them. This is what I was saying. You learn, some of them you discard, some of them you stay with. But I think over the years, I think I came back to Hyderabad in 1983, then joined Nizam's before it became a deemed university, and was very much a part of building up with Dr. Murthy as the head. And over a period of time, as time goes on, you also become the head. Then you also leave. Then I was very happy to come here. That was about 2004, so 20 years, 2 decades down the line. Came to KIMS, built a department, which I think is the really pride as far as I hold. Today I hold it very proud that I hold these people all together. And from Subhash to Sita to Praveen, Jayashree, Anuja. Few have come, few have left, but this has been the core. And the department has grown and possibly is one of the best academic-oriented private setup which you can see in the country. And it gives me real pleasure. Now I'm relaxing. This is the evening of my life, and then possibly neurology. But what I see is people have grown, not necessarily always on my shoulder. They have gone ahead and learned, did so many things, and are doing so many things, which is the pleasure. The first one, of course, who joined amongst all this is Dr. Varalakshmi. I left it for the last, in the sense that initially when we started, we were only 3 people, Dr. Varalakshmi, me, and Dr. Chandrasekhar Reddy, who is now he has a prestigious city neuro hospital, which only runs predominantly neuro specialty with other multi-specialties added. And Varalakshmi has stayed with us, and she continues to stay with us. And she has been very much the fulcrum. These were the 3 people we started. Now we added on. Today's cup of tea, that is the neuromuscular disorders today, I think organized by Praveen, tells you that this is where we are interested in. We like to learn, we like to teach, and teaching has been my foremost thought always. And I always say that I have combined 2 major professions, both medicine and teaching, and they have been their love. And I've really enjoyed this journey, and I see that my younger colleagues, not all that younger colleagues, are carrying on the torch, and I wish them the best. And in all this, I will be amiss if I don't mention Bhaskar, who has been the pioneer, and he had never said no to any development in the department. He will always say that anything you need, you just have to tell me, and that's what is happening. And we are talking about ultrasound up to now. I hope we'll get a focused ultrasound shortly here, which will have a treatable modality. So with this, I think I have already spent more time than I thought I would. Thank you very much.
The best thing about sir is the space. When I came here, I'll take 1 minute only. I got a lot of feedback that, oh, you will work just as a resident, but that's it. He just gives us whole space for us to do whatever we want, and is always there to support us. Now I would request Bhaskar Rao sir to share few words of inspiration, wisdom, as he always does.
Good morning, everybody. Little advanced happy Doctor's Day, which is going to be tomorrow. B.C. Rai, Vidhan Chandra Rai. Whatever Dr. Mohandas has mentioned, 2 virtuals a doctor should have. That is education and treatment. And the third one, what he has is a politics. That's why we got the B.C. Rai Award and B.C. Rai Death Day and birthday together in one section. So I'm very happy and proud that I got the neurosciences department in KIMS. I was working with Nizams, where I saw 2 legends, Dr. Mohandas and J.M.K. Moti were there at that time. And when he came, and I was blessed to come here and develop the entire department as of today. And not only that, most of the corporate hospitals, when more than 1 or 2 consultants are there, they will never be able to see eye to eye. That is the biggest problem in the corporate sector. But here they all work as a team. And development, and they never, I always keep telling I and we. I means illness, we means wellness. My department always, all the departments feels wellness, we, and give subspecialties. As Praveen was pointed out that any number of people comes, Mohandas never says that it is a competition for the department. It always develops few more people. Not only be existing here, there are other people who trained in our own organization. We have 12 hospitals. There are 6, 7 of them are working in our own organization. And that is even if you seek the type of neurophysicians and neurosurgeons, the number of epilepsy surgeries we do is the next to, this is the first one in the corporate sector, highest number after All India Institute of Medical Sciences, I think. I was told, in spite of so many consultants, so many of things, they hardly mention or write any unnecessary investigations. That is the one important thing which puts the organization into the top level. So many of the patients comes back and say, sir, you send these doctors, I have taken about 20 drugs, they removed 15 and they gave only 5, sir. Is it really a good doctor or what? He didn't even ask for any MRI, CT also. That is the way we build, and that's why we made it as an affordable and a quality care. And anything what we were talking about this ultrasonic, we are in the forefront of getting the good technology to help our consultants to utilize it and put it on efficiently on the patients with a cost constraint, without cost constraint to the quality care. And we are going to acquire about a focused ultrasound which can able to treat all the tremors that I have seen. That will be the second in the country. First, right now, I think it is in Coimbatore. They are charging around 25 lakhs per patient for treatment. But obviously, I have seen that on the table itself, the tremors has been totally subsided. Initially, we may be doing a little lesser cost for affordable patients, and you can all of you utilize. Today, we are about nearly 4,000 beds. In the next couple of years, we are expanding in Maharashtra and Bangalore in a big way. And next year, we are opening around 1,000 beds in the Bangalore city itself. And all these things, most of the times he was telling about, basically I'm a cardiac surgeon. And the reason why, even if you see most of the, they got some issue and then they divided into two and they built in Houston 2 vertical towers about 20 floors each, purely a cardiac surgery. That's how the stimulation comes when you have a challenge to each other. Similarly, you also seen in India, there in railway hospitals, Dr. KIMS and Dr. Girinath. Girinath is my boss. They were also worked together, and then they're all positively competing each other and build 2, even one in Apollo and Triple M, KIMS. Even the third one is in Venugopal and Stanley John. That's how the organizations emerge. When you have a healthy, competitive things that you keep it in mind, always looking into positive. That's what we are always keep saying to all of them, a challenge, and then you need to be able to focus the, face the challenge and then make it success. That's how we can able to build. And with the new things, I think our department, as I mentioned, Dr. Mohandas and his entire team, Subhash Kaul, Varalakshmi, Sita Jayalakshmi, Praveen, Jayshree, and all those people, and supported by the good neurosurgery team. Some of the people keeps on saying, patients and other doctors, sir, is it NIMS or is it KIMS? Because all of them come from NIMS only. The reason why we select is, the institution products are entirely different when compared to the privately build their growth. That's why it took most of them are from the institution, so that we'll be able to build that. Even though this costs about 20 crores, still we have put, without academics there is no medicine. So you can't provide a good quality care. That's why we will build wherever we go in all the organizations, we'll be able to have this academics. So once again, we are in the forefront to train, to teach, and to exchange ideas, exchange knowledge, and ultimately the patients will get the best out of it. I'm very, very fortunate to have my entire department with me. And not only that, they got the great opportunities. Great opportunities means you all know that Hyderabad is poaching other corporates with a blank checks. They will come. Blank checks about 3-4 years advance also. But still, our people are stood very rock solid behind me and then build this organization. I'm very much to all my department. Thank you very much, and also giving me this opportunity here.
Thank you, sir. Now I request Nalli Madam to talk about in the next presentation on Hirayama.
Thank you for reposing faith in me and giving me the second talk for today. I'm sure Professor Kaul must have heard this talk, and many of you all must have heard this talk. Thank you once again. So, very important diagnosis. My team at NIMHANS works on Hirayama disease. You can see them. Of course, Dr. Deepak Menon's photo is missing. And our surgeons, our pioneers in Hirayama disease, Dr. Dhananjay Bhatt and Nupur, my thanks and tribute. All three are resigned from, recently Alok has also resigned. So let's just go straight away to the timer, please. Now, why? Many of the time I'm getting references I just got last week, and many from Hyderabad and Andhra Pradesh, of course, because surgery we started at NIMHANS for the first time. So I get diagnosis monomelic MND. A 60-year-old man with the single limb involvement for 6 months, I get it as monomelic MND. A 17-year-old boy with classical Hirayama disease is referred as juvenile ALS, and the patient is on Riluzole with a poor prognosis. So it's so important that we do not mix up our diagnosis. We earnestly look into the patient carefully and make a diagnosis. And this is a very important disease for us to see, just like how CMS I told. So 1959, Hirayama described this clinical entity which affects a single upper limb. It's no more just a single upper limb. And we know that Madam Gauri Devi, my teacher and mentor, in 1984 coined the term monomelic hematrophy because Hirayama originally described this only in the upper limb and not in the lower limbs. But she termed as monomelic because the so-called wasted leg syndrome, Professor Kaul is here from Chandigarh, described as the wasted leg syndrome is possibly the lower limb monomelic or the Hirayama disease. So now we know more about this disease also. So 38 cases originally described. The first autopsy was a serendipitous finding. The patient died of accident, and then they found that there was a cervical cord which is compressed from C5 to T1. It was involved in C7, C8 level. And this was published in 2000. So they suggested a circulatory insufficiency of the lower cervical cord and called it as focal ischemic poliomyelopathy. So we know that it's even those days, when this first autopsy, it is possibly a compressive etiology. And in 2000, we know that the same group described on the MRI, which revealed a dynamic compression of the lower cervical cord due to the forward displacement of the cervical dural sac. So we published on this last series, which Madam from 1976 has been diagnosing these cases, and we gathered the cases and wrote up the clinical features. Now, we know that the mean age, keep in mind that the mean age of monomelic hematrophy is around 19 years or 20 years. Now, we just had recently a patient with onset at 12 years of age, onset at 12 years, but by the time he came, but overall the mean age remains at around 19 to 20, and familial forms are very well known. There's a progressive weakness and wasting and atrophy of the intrinsic muscles of the hand and forearm of a single upper limb classically described. There are autonomic symptoms like cold paresis, that is worsening of the motor symptoms on exposure to cold conditions, particularly patients who come from the colder parts of our country. And that could be there for 8 to 10 years, cold paresis, before the wasting and weakness appears. We've seen 2 or 3 cases coming from Assam with cold paresis for several years and then developing the motor symptoms. And generally it evolves over 2 to 5 years, and it says that it's a self-limiting disease. When all the damage is done, it becomes self-limiting. Patient develops a useless hand, and then it becomes self-limiting. So that's exactly what I tell, that it is not a disease which is very benign at all, few cases, but then the damage of moderate to severe disability happens by the time the patient comes to us. So I already told you what's cold paresis. Autonomic symptoms, unlike MND or other juvenile forms of anterior horn cell disease, they do have hyperhidrosis of the hands. Vague sensory symptoms, even 2 or 3 patients complained of Lermut's phenomena. That was very unusual. And we've shown that the abnormal sympathetic skin response can be there in these patients because they do have so much of autonomic dysfunction. And stiffness of one or both lower limbs, I'll show you about the extended form. Now the pathophysiology is that there is a tight dura which compresses the cord on flexion, and this leads to arterial or venous congestive myelopathy. And there is most of these patients, Professor Khadilkar is here, he has published on long neck in these patients. There is increased what we call as a range of motion of the neck. The dural shift is much more, but of course there's a developmental anomaly of the entire dura which is detached from the vertebral bodies. And there's unequal distribution or lack of posterior epidural ligaments between the posterior dura and ligamentum flavum. And there's a disproportionately long neck and increased range of motion. So these were our findings, that predominantly distal wasting and weakness. Of course, some had proximal muscle wasting and weakness. Brachioradialis, classically, I will show you, was spared in the majority of patients if you carefully look at it. Fasciculations occasionally. Mini polymyclone is very, very classical. And some of these vague sensory symptoms that I mentioned. And although it's an element syndrome, the deep tendon reflexes are usually brisk, including the upper limbs and the lower limbs. So just had last week one reference because upper limb reflexes were sluggish, possibly brachial plexopathy. Of course, that was a classical case of Hirayama disease. So MRI features, you classically see lower cord atrophy. I will go straight away to, and loss of attachment, which I will show you in the MRI, then it becomes much more. So as you can see here, very classically you have wasting and weakness of the intrinsic muscles of the hand. You can see this is the medial forearm which is wasted. The left upper limb is quite normal. You see the brachioradialis is quite preserved. You can see this is the oblique atrophy. When you see, this is very classical of Hirayama disease. They can come with the wrist drop. You can see this is a 23-year-old male and this is with a 3.5 years duration of illness. So sometimes I just show this so that in Hirayama disease, what we call, in classically in ALS, you have the split hand syndrome with the ape thumb deformity, with the APB being more affected than the hypothenar muscles. But in Hirayama disease, you have the hypothenar being involved, whereas the thenar is spared. And here we call it as the split hand syndrome. We publish this as reverse split hand syndrome, where the hypothenar is involved. So this ratio study, we did it and found that it's quite useful when you want to differentiate between ALS and Hirayama, but really that's not very difficult at the bedside. So we just did it to document it. So these are the classical Hirayama MRI picture. You can see the linear gliosis of the anterior horn cell. The cervical lordosis is lost over here. So you can see this owl eye appearance. This is the gliosis of the anterior horn cell. This is the dural detachment you can see here. And you can also call it as the eye of the snake appearance or the cobra eye appearance, as you can see here. So when you do inflection, so you have to do with contrast. So do a good flexion. So usually what they do is put the patient supine and try to ask them to lift the head above. Not very comfortable. We have a big sort of a L-shaped or triangular-shaped wedge, and they can keep the head, or a mud-filled sack, small one. But now what we are doing is we're putting the patient prone and asking them to hang the head at the end of the gantry table, and then you get a beautiful flexion. So it's just about 15-20 minutes. The patients do tolerate that. So that's what our radiologist did, and we saw that earlier we thought that the detachment is restricted to the cervical cord, but not so. The entire cord is detached. As you can see, the dura is detached. So you have here the epidural venous plexus. This is with the non-contrast, and you can see with the contrast here. This is a very nice snake eye appearance. You can see the flattened cervical cord. We call this as a reverse lordosis. This is actually the S form of deformity instead of the normal cervical lordosis. You can see the nice dural detachment and the flattened cord. So this is very classical. I'm going to keep on showing you this. And this you can see, this is the normal lordosis, which is lost, and this is the S type, or the reverse S. This we call it as the reverse lordosis. And this is the epidural venous congestion on flexion, and this is the crescent-shaped epidural enhancement. Please do contrast always. Just don't be satisfied with plain. And here you see a nice dural detachment in the patient. So these are the classical findings that you can see. Ouch, I'm so sorry. So it's just not unilateral. We described the bilateral one, and you can see that the mean age is the same. It's only that it could be asymmetrically or it could be symmetrically involving both, but the evolution is the same, or it could be a little more severe. And this is important to differentiate from the classical ALS picture. Of course, you can see juvenile ALS. We have to really look at the thing. You see, this is a patient of 26-year-old male and a 55-year-old male. You can see even at the end of 55 years, how beautifully the APB is spared. And this is the patient who had 30 years history of illness, and the hypothenar is much more involved, and it's bilateral. Look at the brachioradialis, which is so very well preserved, and the oblique atrophy, the wasting and weakness. So it's C7, C8, T1 distribution that you get. So this is a 26-year-old male, and this is a 55-year-old male. So we do not know the reason. Possibly the hypothenar group of muscles are most susceptible to venous and arterial congestive myelopathy or the atrophy. Again, the same findings, even if it is bilateral distal or unilateral, you have this epidural venous plexus and on flexion. The flexion should be good. As you can see, the flexion is not very good over here. Some of them it's painful. That's okay. That's why the prone position really gives a very good thing. So we had the proximal form. So the originally described was the single upper limb. So you do have the proximal form. Again, see the reverse lordosis over there. You can see that it's literally the cervical lordosis is lost, and in fact it is reverted. And the last picture also shows you this very well. So all of these findings, if you see in a Hirayama patient, you'll find. Clinically, you make a diagnosis, and then you have to see. So proximal forms you can get. So you can have the proximal bilateral, it can be unilateral. So again, the mean age is the same. So the clinical picture is the same, only the phenotype is little different. So identifying these entities is very important because these patients are labeled as FSHD or labeled as progressive muscular atrophy or labeled as juvenile ALS. So I think we should identify this case very, very carefully. So young individuals will benefit because now it's the surgical intervention is the treatment of choice. You can see this patient with proximal-distal severe wasting. Even with proximal-distal, the brachioradialis is relatively spared. We don't know why, and please, I'm sure somebody will ask me why, and I don't have an answer for that. And you can see the proximal form with the bilateral scapulo-winging. So we called it as a proximal-distal form and the proximal form of Hirayama disease. And you can see the MRI. Again, it is the same classical picture. So no harm in doing MRI when you suspect a case of Hirayama disease. A young man coming with wasting weakness, unilateral, a little brisk reflexes or even sluggish reflexes. No harm in getting a flexion MRI. Please do the flexion. That's very, very important with contrast. Otherwise, we tend to miss it. So this is another patient, the father and the son who had a classical Hirayama disease. You can see the proximal was much more weaker than the distal. Again, I've pointed out on the spared brachioradialis, which is so very well seen. And to keep showing you so that visually you can see the picture is the same, the epidural venous congestion. So this is another patient just with proximal muscle weakness. My resident made a diagnosis of FSHD. I said, but the reflexes are brisk. Why are we making a diagnosis of FSHD? And let's do an MRI. And lo and behold, you can see that this patient had Hirayama disease. And all of these patients whom I'm showing you have undergone surgery and doing very well. So we did have familial forms. You can see these two brothers. The elder brother, we took pictures from his home and he sent. You can see the brachioradialis so well preserved. He's 59 years old. And the brother is 45 years old, and you can see one had unilateral and the brother had bilateral, and with long duration of illness. Of course, these patients we did not operate. But if you have a patient with one upper limb involved and 10 years later the right upper limb is getting involved, we take them up for surgery so that at least the right upper limb we can save and we can preserve it. So I will tell you the guidelines how we have taken up. So the familial forms are not unusual. We have seen them, but a very small number. You can see they also have classical MRI picture. So this is the boy with proximal-distal form, whereas the father had only the distal form of the bilateral distal bimelic amyotrophy, and he was 58 years old. So we have seen this familial father-son. We don't know what is the dominant pattern. And these are the MRI findings in this patient who had distal weakness. And you can see the epidural venous engorgement. So that's with the familial form. I'm not going to go in much detail. So now let's see that the lower limb can also be involved. We know that it was described originally as a wasted leg syndrome. Now, why are we thinking that this is, yes, of course, Hirayama disease only, well described in 1984 with Madam Gauri Devi in her textbook. You can see that the right lower limb is wasted and weak, and patients progress and then they remain stable. Not much of a difference. So this patient came to us, and you can see he's a 24-year-old man who told his left upper limb, you can see, is much wasted, weak. And he also said that the left lower limb is weak. So one tends to make a diagnosis of ALS with brisk reflexes. But of course, upper limb, he had symptoms of cold paresis. And then when we did the MRI, you can see here, what I would like to show is that you see the dural detachment. It is not just restricted to the cervical. The dural detachment is going right way to the D2, D3. So when we do the flexion with the prone position, up to D10, D11, you can cover in that one coil. So most of the time now when we do that, we see that the dural detachment is extending to the almost entire cord. D10, D11 is up to where we can capture. So the detachment is quite extensive. So this possibly is a developmental anomaly that we are seeing in these patients with complete dural detachment. You can see another patient with extensive dural detachment over here. So you can see it's just going down up to the thoracic. It's just not in the cervical cord. So see the nice flexion that you can see when the patient is in the prone position. So the clinical part of it I've shown you. So this is the summary. So I'm going to the surgical component next. So it affects predominantly young males. Remember that the mean age of onset is around 19 to 20 years. and not older people. And of course, age of onset can be 12, 14 years also. So particularly with mini polymyoclonus, which is so classical, of course, I don't have time to show videos, so I'm not going to, others I would have loved to show videos of these patients. And predominantly a motor syndrome, recognizable autonomic symptoms, and important that don't ask the patient, wait, this will stop by itself, then the damage is very massive. So causes moderate to severe irreversible disability. Familial forms are well described. And it is now almost confirmed that it is a cervical compressive myelopathy with ischemic or venous congestive myelopathy and should be identified early and intervened. So I'm going to show you the extended form. So that was classical. Now we know that because this is a compressive myelopathy, the patient can also come with spastic paraparesis with bladder involvement after a stationary period. And we had 3 patients, it's already published in Neurology India, who had classical Hirayama disease, either unilateral, bilateral, or proximal-distal. You can see these were the 3 patients at 27, 41, and 57 years who came to us. And they had a stationary period of 15-20 years. And then the patients came to us with a progressive spastic paraparesis. And you can see this is the man with a classical Hirayama disease for 4 years, had a stationary period for 4 years, and then developed spastic paraparesis with bladder involvement. And there's another man with 15 years of stationary period came with low limb symptoms to us. Because the upper limb was so classically Hirayama. And then when we did the MRI, you see that the reverse lordosis keep telling you, and the cord is literally pinched. This is a younger man. And you can see the epidural venous congestion and the dural detachment. And on flexion, you can see the dural detachment and enhancement. So we have operated on these patients, and this paper is published in Neurology India on the extended form of Hirayama disease. So potentially surgically treatable these patients are. So now surgical intervention. Let me just start with what's already available in the literature. Ours is a current study which we published in World Neurology. Surgery is already published on the surgical outcome in Hirayama disease. And we included 136 cases. And of course, as you can see, the improvement was in 84%. Our surgeons were simply flabbergasted. And Dr. Dhananjay would say, surgery, 24 hours, patient says his cold paresis has disappeared and is able to move his fingers. So because the dynamic compression, you have just eliminated that. And surgeons were surprised, and even we were surprised. The patients were happy. And of course, at follow-up, now we have patients at follow-up at 9 years. 2015, we started our first surgery. And good follow-up. I have patients almost every week, 1 or 2 coming and saying that they're doing very well. They have a Hirayama group now, all of these patients, and exchanging. And some, I'll tell you the complications, of course. And you can see in published literature, some are reporting 100% improvement, 64% improvement, and all of them are anterior cervical decompression. So this is what we have already published in World Neurosurgery. So we've operated around 270 cases. Every week we have 2 patients of Hirayama disease now all over from the country. Of course, Professor Kaul is also here, who is referring patients of Hirayama disease for surgery at NIMHANS. It's a simple surgery, but I think the surgeon should be really experienced and they should know what they are doing. I'll show you a case. So we did a serial assessment with Fugel-Meyer, Jepsen-Taylor. We wanted to be sure that this surgery is really helping our patients. And we did a lot of systematic studies and then found out that these patients really did very well, and I can show you that. So how do the surgeons select the cases? Is a young individual with early stage of the illness. Disease should be in its progressive phase. Duration of illness is generally within 2 to 3 years. The new limb involvement after a stationary period. A second phase of progression in an originally affected limb. And progressive worsening in functional disability. And appearance of symptoms in the lower limbs or MRI, but of course MRI is the mandatory investigation which will allow us. So initially we did posterior decompression. It's very morbid, severe pain. Patients didn't like it. We did only for about 4 cases. Then 2-level anterior, our surgeon said 1 level is more than enough. And then initially bone graft, but then we have this artificial bone cage which is being applied. It's not very costly, around 25,000. So this is an 18-year-old boy with classical Hirayama disease, operated. You can see this is the classical MRI picture that the patient had. And this is what our surgeons do. They look at the bending angle. Look at the normal one, it's around 69 degrees. But whereas the patients, it's almost 91 degrees. So the range of motion is so large in these patients that the dural detachment also causes so much of compression. So you can see the fixation, anterior cervical decompression, very well fused. And actually you can see the bone cage also. They're very tiny lines that you can see. So you can see the pre-op and post-op. In fact, of course, they can't flex too much post-operatively, but still the epidural venous plexus is significantly reduced. And after 24 months, you can see well the surgical scar, and then the epidural venous plexus is reduced. So pre-op, post-op, many such I have. So we have done this Jepson-Taylor hand functions, handled dynamometry, and found that patients are improving very well. So here you can see pre-operatively, the patient couldn't even oppose. His opponents was weak, small muscles were weak, and post-operative, his grip became very well. Many of them are software engineers who are using their laptop. They cannot use their little finger, so they're so disgusted they can't use their laptop or they can't use their keyboard properly. But with this, you can really help them a lot, and you can see the improvement. Even this patient had a lot of significant weakness, and post-operatively he's improved very well, and all the patients, young men, are so happy. Some of them came and told, I have made a diagnosis of MND, I contemplated suicide, I thought I will die in 3 years. Patients were on Rilutor, 17-year-old boy comes on Rilutor, and it was all classical Hirayama disease. So I think before we give them a poor prognosis and a mislabeled diagnosis, of course we would have also had made mistakes, but we can be more and more careful in identifying. And you can see we have the last follow-up in 22. Of course, our patients keep coming. This was a systematic follow-up that we did almost of 3 years. And we found that almost 94, ranging from 84 to 94% patients subjectively said improvement, and objectively with Odom scale we found that that's what is done for spondylotic myelopathy. We use the Odom scale. In fact, we wrote letters. This was also during the COVID time. And you can see the surgical outcome was very good in our patients, almost 64%. See, if we can't show improvement, we can at least stop the progression. I always tell my patients, don't expect improvement, but we're trying to stop the progression. So even that's very happy, because the other limb and the lower limbs can be saved if it's going to progress to involve the other limbs. So they are very happy when they have improvement. So we are a little very conservative in telling them what the surgical outcome will be. So if they improve, they're absolutely excited, because they don't expect any improvement. They just want stabilization. So this was the HD questionnaire we did. Now what's important? Failed surgery. So just, I don't know if there are surgeons in this audience, because surgeons can be very aggressive. We don't want to just refer the cases. I still have my former students from Hyderabad or elsewhere. They're just sending cases to NIMHANS. We are flooded with Hirayama disease case after my talks. So of course our surgeons are doing all out, but there's a fight among surgeons saying Hirayama disease taking away a lot more of OT time of theirs. So we need to have a special OT now for Hirayama disease, because from Nepal they're coming, from Bangladesh they're coming. So we're really getting flooded with Hirayama disease, at least 5 to 6. Every Monday OPD, this Monday I had 4 Hirayama disease. So this is a 17-year-old boy who underwent surgery elsewhere. Now the patients are being directly referred to the surgeons, and they are very keen to put the knife as early as possible. So we need to be very cautious before we refer the case. So you can see this patient had multiple posterior laminectomy, and he was just left without even fixation. And within 3 months, he had only left upper limb. He came with a severe weakness of the right upper limb also. And you can see it's almost collapsing the cord over here, and it's pinched cord. So let's not just do damage than what the patient already has. We have to be careful. Let's not do harm if we can't do good for this patient. Then we had to do an anterior decompression, and our surgeons did a good job of fixing the spine at least. And now he's slowly improving, although the affected limb. But the new affected limb improved well, because that was a very new affection. So let's just be very careful. So post-operative complications, at the end of 8 years, we've hardly seen anything. But local pain can be there for a few weeks. Restricted neck movements, of course. Our surgeons are very particular. Dr. Nupur is very particular. He's now, devised, I wouldn't say the word, a yoga module for Hirayama disease, because now this is flexion-induced damage. He's doing yoga extension. He's very fond of yoga, Dr. Nupur, and he's giving them a module for about 3 months to do extension exercises, and just at least till the time that they wait for surgery. They wait for 3 to 6 months or 1 year for surgery. At that time, they do that. So he gives them this extension module yoga, and they do come back and say, and we give this cervical collar. We give the hard cervical collar during the day, and sometimes soft cervical collar during the night, because at night your neck can be in different positions. And we have young students who are very funny. They're lying on their bed, they're keeping the bed on the book on the floor and studying with so much of constant flexion. So they have funny ways of studying also, and they came with Hirayama disease. Maybe they had a predisposition and these triggered. Okay, and we had 2 cases who required a second surgery. Of course, I've shown all men. We have operated on, somebody will ask me if women are affected. Of course, we had 4 or 5 women. Just last week, I had another lady, and we've operated on 3 cases of women with Hirayama disease. So no serious complications. Maybe after 10 years, some subluxation may happen. We're not very sure. And these are the possible complications that can take place. Enhanced degeneration at the adjacent level because you have fixed 2 vertebral bodies over there. Decision to operate should be taken very carefully. Anterior approach is the best approach. And let's be very cautious. We may not tell the patients may not have improvement, but only arrest. If they have improvement, they are very, very happy about it. So basically, we would like to term this disease as a cervical flexion-induced myelopathy. It affects predominantly men of Asian origin. Of course, I'm happy to say that we had a patient referred from... Okay, done. This is the last slide. And yeah, just giving me warning. So from Queen's Square, London, but he was an Indian, and then he was sent to Nimmans for surgery. So we are very happy that our work has been recognized all over the world, and we are getting patients from Singapore. We had Indians, of course, Indian living over there with the Hirayama disease. So it's self-limiting, but let's remember that the damage is done, and moderate to severe irreversible disability. Familial forms are well known, so just don't leave them as familial ALS. So we'd like to call it as cervical compressive myelopathy with ischemic or venous congestive myelopathy or cervical flexion-induced myelopathy. Should be identified early and offer surgical intervention for these patients. And let the surgeons choose the level very carefully. They do the bending angle. And see, this is a routine spondylotic myelopathy surgery. But for Hirayama, the young people, we should not do more damage than what they have. So let's be very, very careful. Our surgeons have to be very thoughtful about what they are doing. And thank you for your attention and allowing me to share our experience, Professor Kaul and team, and thank you once again.
Thank you, Dr. Nalini. That was excellent exposition. I think it's a very fantastic experience which you had. I think it's a treatable condition which possibly was not diagnosed for a long time. Now I do have one question for you before I open it for others. Is that you also said it is familial sometimes or hereditary. Is it the neck angle which is important in that, or you did genetics in that also?
I think recently Madam Gauri Devi has showed some susceptible gene in Hirayama disease. We did even whole genome scanning in all of these families. Dr. Farooq from Delhi helped us with whole genome scanning, not genome sequencing. But we did whole genome sequencing. We looked at HLA. We really didn't find. Possibly the abnormality is in some dural tissue or elastic tissue. But we did genetics in quite a few of them. We didn't find anything.
Maybe just the neck.
Possibly it is just the developmental anomaly in the families, possibly.
Yeah. We are lucky to have Manas sir just at the nick of the time. So, yeah, just, sir, you're...
Yeah, yeah. Anyway, finish the case. I have a little different opinion on Hirayama. We do operate because Hirayama is it's not a compressive myelopathy. It is more of a because of excessive mobility of flexion and extension, the cord is stretched. And for each 0.1 millimeter of stretching, there is a significant reduction. There is an ischemia, and that is what is experimentally they have done. So the treatment here is fixation. There is no decompression here. Whether we do anterior fixation or posterior fixation, it depends on the degree of mobility the patient has. But doing a blanket statement of anterior only probably is not correct, because it has to be depend on the X. Whereas if you see your follow-up, it has gone from 96, 94 to 80. So with anterior fixation, because the patient will still have mobility later on. Doing a limited fixation, probably in the long term, patient will come back with worsening. So either it will be it should be multi-segment fixation, anterior or posterior. And here one has to maintain normally the cervical spine has little of lordosis. It's not kyphotic. So to maintain lordosis, posterior is better. So what we follow, Dr. Kaul, you don't have to refer to NIMHANS. Dr. Kaul, Dr. Subhash Kaul, please listen. Don't put a deaf ear. You don't have to send Hiraima to...
We are not sending.
Yeah. So because we also have a series of Hiraima cases, but we do posterior because that achieves the normal lordosis, and that has a better long-term results.
But that's left to my surgeons. But international literature currently, they say anterior fixation. If I showed you that table, so they also did originally posterior, but now they've just left with anterior cervical decompression with fixation. That's what the term is. I'm not a surgeon. That's what my surgeon. So if you see, the international studies are also anterior this thing. So whatever one, we did 4 cases, but the surgeon said that it's quite painful and more, the morbidity is more with posterior. So maybe, yeah. Decompress.
We leave the batchmates to argue.
Not required. Okay.
We leave the batchmates to argue later.
What is decompression is not required. It's only the fixation which is required. Yeah.
I think anyway. I think it's a fantastic talk. I think nice, Manas, having you here. I think we'll go for the next case. I think tea is still delayed.
You only keep it.
Yeah. There's a small.
Good morning to all the delegates and my dear teachers. This is a case of 60-year-old gentleman presented with history of postural and action tremors in both the upper limbs with increased severity on right side since 2 years. Later, he developed cramps in both the lower limbs, fingers, and involuntary muscle twitches in both the upper limbs since 8 months. 1 month later, he noticed gradual onset progressive distal weakness and thinning of right upper limb. There is no history of lower limb weakness, sensory, autonomic, bowel, bladder, cognitive, cranial nerve or cerebellar dysfunction. Past history, he had bronchiectasis and hyperthyroidism but currently not on any medication. On examination, there is visible wasting seen in the right interossei, all interossei, thenar and hypothenar muscles. Fasciculation seen in the bilateral biceps, right FDI and hypothenar muscles. Bilateral postural tremors are present, more predominantly seen on the right side. And on CNS examination, higher mental functions, cranial nerves are normal. Motor system tone is normal. Power, neck flexion and extension is normal. Trunk muscles are normal. And shoulder flexion on the right side, it is 4/5. And intrinsic muscles of the hand on the right side are very weak. Whereas on the left side, I could find mild weakness, plus 4/5. Reflexes all are preserved. And even in the wasted limb on the right side, the reflexes are preserved. Sensory system is normal, cerebellar system normal, gait normal, other system examination is normal. So case summary, a 60-year-old gentleman presented with history of insidious onset chronic progressive tremors in both the upper limbs, right more than left, since 2 years, cramps in lower limbs and upper limbs with fasciculations in both the upper limbs since 8 months, followed by right upper limb distal more than proximal weakness with wasting since 7 months, with mild distal weakness in the left upper limb on examination without any sensory autonomic bowel bladder dysfunction. There is no history of cognitive cranial nerve or cerebellar involvement. So it is an asymmetrical onset, chronic progressive pure motor, distal followed by proximal weakness of the upper limbs, right followed by left. So I would like to localize here to the anterior horn cell or to the peripheral nerve. Currently, presence of LMN as well as with LMN involvement on one right side with preserved reflexes considering motor neuron disease, and the other possibilities like pure motor CIDP or nodopathy and MMNCB. So here we have done CBP, RFT, LFT, these were normal, viral markers were negative, serum PTH, calcium, phosphorus is normal, NCS is normal. Needle EMG is suggestive of neurogenic process involved in the right C7, C8 and T1 myotomes with chronic reinnervation changes without any evidence of active denervation. There are no fibs or positive sharp waves. And MRI is normal. So we have sent for serum autoimmune neuropathy panel at Amruta, which showed neurofilin 186 and anti-MAG antibody is positive. So eventually patient was treated with rituximab 1 gram 2 weeks apart, was given in May. And after giving rituximab in the last 1 month, he had a progression of weakness in both the upper limbs and wasting noticed in the distal left and proximal right upper limb with increased fasciculations in both the upper limbs, back and on thighs. Also, he developed the proximal lower limb weakness also. So this is a summary where initially he presented with tremors, cramps, fasciculation syndrome, followed by right upper limb weakness, and with preserved DTRs. With positive antibodies, neurofilin 186 and anti-MAG, we have given rituximab, but later on he had progression of weakness in the upper limbs and proximal lower limbs, with significant wasting of upper limbs and florid fasciculation. So in this condition, should we consider him for the MND, or should we treat him for any refractory nodopathies, immune-mediated? What could be the approach? How do we treat such cases?
Basically, the question is this, madam. Therefore, we keep on seeing patients, upper limb involvement, there is a wasting, the reflexes are exaggerated, but EMG doesn't show FIPS, therefore. And now with this antibody being positivity, what should be the, what can be?
I missed a little bit. How old is he?
60-year-old, sir.
60.
Yes, sir.
And what's the duration of the illness?
Total 2 years to start with, sir. Yeah. Tremors.
Okay.
And cramps, fasciculations 8 months. Weakness in 7 months.
Right. I think this is one of those difficult situations where you can't make up your mind as to what is the diagnosis. Yes, and this is exactly where you would like to use every modality that you have. Like you used antibodies. I would also use an ultrasound. I would use an MR neurography. I would do CSF proteins to try and see serum immunofixation electrophoresis to try and see what other autoimmune evidence I can get. And at the end of it, if the autoimmune evidence is substantial, you use rituximab, then you would think of more as well, maybe occasionally cyclophosphamide or whichever. Having said that, a 60-year-old man with this sort of a situation is generally more likely to have an ALS.
Yes, sir.
And other things may be red herring. So I think a lot depends on what evidence we can gather at this point in time and how does the case behave in the coming few months. Yeah. Yeah. You know, just one comment. Since we only have one lab doing it in the country, I recently spoke to the person with the same concern. Look, are we very good clinicians or what is happening? So generally it seems that of the sample that they're getting, 25% or so are positive. So they have a lot of negative, but 25% is a lot of positive. So at this point in time, we don't know what is happening. Secondly, this is ELISA. This is not a cell-based assay. That's the second limitation.
No, just I want to say that we have been sending samples to Oxford for paranoid. I haven't still now got even a single positive report. Yeah, the cell-based, not even a single one. Everything has been negative. Not even a single one we have got. That's one. In this case, I mean, usually what case comes to us, I mean, what we try to do is, one thing is about the localizations. Is the anterior console involved or the nerve involved? As sir told, if you use other modalities to find whether nerve is involved, whether using ultrasound or a neurography or this much, to say that, I mean, that one point, because paranodopathy is presenting as a pure motor neuron disease is not established. It's not clearly known.
Yeah, we have done brachial plexus, which is normal.
Normal. So that is, so once you get that nerves are not thickened or this one is not there, that is a definite clue that localization is in the anterior console. Then the antibodies becomes less relevant in that scenario.
No, sometimes we see pure lower motor neuron syndromes, asymmetrical without upper motor neuron. That times some of us empirically treat them. What is your, Nalini, you want?
Very much agree with you. So now, of course, extensively we are doing neurographies, and if we find some thickened nerves. But if in a diabetic patient, already most of them have thickened nerves. Subclinical demyelination, remyelination, they have thickened nerves. So if it's overlapping with diabetes, at least if I've given a choice, I give them cyclophosphamide and not really go for expensive rituximab. But this particular case, I think it may be still ALS.
Just a related question, just to you, Nalini, because you are an MND expert. So how common is this pure lower motor neuron asymmetrical MND in the absence of upper motor neuron signs? How common it is? We used to think it's a rarity. So how common it is? Pure lower.
Not really rare. Maybe if I see 100 cases, about 15 of them will come to us. Eventually, they may have some wrist reflexes in the lower limbs, because upper limb is so wasted, they may never develop UMN signs. But of course, lower limbs may show wrist reflexes. Other clues we may get. But you can have a pure element syndrome, about 10 to 15% is well known. But at least, no, age range usually it's around the same, or maybe 5 years earlier than the classical ALS. Usually in the late 40s and early 50s. Now our mean age has increased from 47 to 55 because the lifespan has increased. So the mean age is actually going higher now.
Ma'am, last question, ma'am. First, we suspect a patient of MND, do a needle, the fibs are not there. Is there any role for repeating at about an interval, 6 months, when the disease evolves? Or one time EMG does not show?
You know, I always advocate no EMG. So now because you don't know where you're putting your needle. And the area covered by the needle is few micrometers, I think, and not like you can hold muscle, you can say. Do repeat ultrasound. Why you want fibs? Room for fasciculations.
Like we said a while ago, that it is setup driven and what expertise you have. Like this situation that you mentioned, I hardly ever come across because the electrophysiology department is very good. So it depends on how the whole setup is organized as to what situations you will face.
Okay.
I think with this,
Yeah, sir. Now we come to the close of this session. I would request Kaul sir to give a memento to Mohandas sir and Suryaprabha madam. Thank you, madam. Thank you, sir. Now we'll have a short tea break of 20 minutes, and then we'll start the one recorded section by Madhu, madam. Yeah. We have a recorded presentation by Dr. Madhu Madam. She is available on Zoom, but first we will have the recorded lecture. After that, we have a Q&A session. Dr. Madhu is Professor of Neurology at NIMHANS, and her forte are inherited and acquired neuropathies, mitochondrial disorders, neurogenetics, immune-mediated neurological diseases, GBS myasthenia, and sleep and clinical electrophysiology.
Good morning. Is my voice audible?
Yeah, madam, it's audible.
With your permission, I would like to just make one comment since I was listening to the previous session.
Yeah, sure, madam.
We have been doing neurofacin antibodies at NIMHANS for the last 1.5 years on a research project mode. And as somebody in the audience, I think it was Dr. Vishnu who mentioned that none of the patients are positive. So that has also been our experience, that none of the patients are positive, including the patients who are retested. Some patients came with reports that they were positive. We retested them and they turned out to be negative. So it probably, I'm a clinician, I'm not used to the lab work. So what I have been told by the lab colleagues is that it depends upon the technique. The stringent means the curve that is drawn after the OD curve that is drawn and the cutoff that is established by the lab. And of course, the clinical correlation that was discussed. Only 2 patients were positive for NF186 antibodies. None were positive for NF155. And I think NF186 nowadays doesn't have that much of a pathogenic role as compared to NF155.
Oh, okay. Thank you, madam. Yeah, now we'll be having the recorded presentation.
Opportunity to speak on autoimmune autonomic ganglionopathy. This is a recorded talk, but I am available online for discussion and clarification at the end of this session. Autoimmune autonomic ganglionopathy is an autoimmune disease affecting the autonomic ganglia, and it is caused by antibodies against the nicotinic acetylcholine receptors. It was previously known as acute pan-dysautonomia or autoimmune autonomic neuropathy, but the term ganglionopathy is preferred because the available data indicates that the primary pathophysiology lies within the autonomic ganglia rather than within the peripheral nerve fibers. This is a rare disorder and usually affects subjects in their 40s to 50s, and there is a female predominance as in majority of the other autoimmune disorders. However, there are cohorts from Japan who are described to be younger and more male predominant as compared to those from the Western countries. As the name suggests, a typical patient with autoimmune autonomic ganglionopathy manifests with diffuse autonomic failure resulting in widespread autonomic manifestations due to the involvement of the sympathetic, parasympathetic and enteric systems, while sparing the somatic nervous system, that is the motor and sensory dysfunction, are minimal or absent. Among the various autonomic manifestations, the orthostatic hypotension and gastrointestinal dysfunction are the most frequently present, being reported in about 80% and 74% respectively. Among these, orthostatic hypotension is common. It's the first symptom in majority of the patients, and they report lightheadedness, orthostatic intolerance or syncope. While enteric nervous system manifests with GI dysmotility, and both upper and lower GI symptoms may be present. Of these, constipation is the most common, while some have diarrhea, while others have alternating diarrhea and constipation. Apart from these, there can be a spectrum of manifestations, and these can occur in any combination. What is important to remember is that the initial symptoms of adult onset autoimmune autonomic ganglionopathy are often with orthostatic hypotension. However, in childhood, the initial manifestations are often related to gastrointestinal dysmotility. The other clinical features include those associated with parasympathetic failures such as dry eyes and dry mouth, sweating abnormalities, anhidrosis, urinary retention, sexual dysfunction, and impaired pupillary response to light and accommodation. These autonomic symptoms negatively impact the activities of daily living of the patient, and in particular, anhidrosis can cause heat retention and heat stroke, while orthostatic hypotension can compel a patient to prolonged bed rest. The onset may be acute or subacute, that is, the peak of autonomic failure is reached within 3 months, but sometimes a chronic progressive course resembling a degenerative illness can also occur. An antecedent viral illness causing enterocolitis or flu-like symptoms may also be present, though no specific or single infectious agent has been consistently identified. The onset may also be associated with recent immunization or minor surgical procedure. But the point here is that even if the onset is acute or subacute, the clinical course may be chronic. And after a particular point, it may be difficult to determine the mode of onset, whether it is acute or chronic. The course is usually monophasic with a slow spontaneous recovery. Though initially it was thought to have a good prognosis with complete recovery, it is now known that majority of the patients have incomplete recovery with persistent or residual autonomic deficits, and only 1 out of 3 patients really make a complete recovery. So the spectrum of autoimmune autonomic ganglionopathy is wide, and while it is known that the classical phenotype presents with a severe and widespread autonomic dysfunction, limited forms can also occur, such as these. And out of these, the postural orthostatic tachycardia syndrome, or POTS, is the most common. So against this background, let us look at the case of this 13-year-old girl who presented with an acute onset of gastrointestinal symptoms. This patient developed dengue, and after 15 days, she developed an acute onset of vomiting, abdominal pain, dysphagia, constipation, and intense burning paresthesias of the extremities. She had orthostatic intolerance with an inability to sit or stand even with support, and she became apathetic and irritable with reduced food intake and weight loss of nearly 9 kgs. Examination was not possible because of her irritable behavior, and here you can see the emaciated patient with a BMI of 11.7 kg. MRI of brain and spine and the CSF analysis were normal, and the key investigations revealed evidence for autonomic dysfunction in the form of neurogenic dysphagia, severe cardiac autonomic dysfunction, and orthostatic hypotension. Because of the acute onset and rapid progression, she was considered to have an immune-mediated disorder with predominant involvement of the autonomic nervous system with gastrointestinal and cardiac manifestations, and she was treated with steroids, plasmapheresis, and IVIG. And after close to 2 weeks of treatment, she improved sufficiently to undergo a formal neurological examination. You can see here that the patient is unsteady while standing. Tromberg's test could not be performed because she was markedly unsteady even with the eyes open. And when she walks, you can see that she has an unsteady gait, and she walks with the eyes glued to the ground. There was marked impairment of joint position sense in all the limbs. You can see the pseudoathetosis of the upper limbs when she closes the eyes, and mild loss of the truncal balance. And here you can see that the knee heel test is abnormal even with the visual clues. This patient improved further, and the paresthesia subsided almost completely, and she further improved enough to walk independently, though the impaired joint position sense was still persisting. So, although the autoimmune autonomic ganglionopathy is characterized by severe sympathetic and parasympathetic impairment, some overlap with the somatic dysfunction, that is, impaired motor and sensory function, is also recognized. And some authors propose these 3 distinct subgroups: one with pure autonomic neuropathy, other with autonomic plus sensory, and autonomic with sensory and motor impairment, and which is why this entity was at one point positioned at one end of the spectrum of GBS and in fact considered to be a GBS variant. Apart from the core autonomic features, the extra-autonomic features with involvement of other sites of neuroaxis, such as sensory disturbances in the form of paresthesias, dysesthesias without any objective sensory impairment, evidence for CNS involvement, coughing episodes, and endocrine dysfunction can also be present. These extra-autonomic manifestations are more common in children, and particularly encephalopathy is more common in children. And in fact, there is a case report of childhood onset presenting as an acute encephalitic syndrome. On the other hand, the systemic autoimmune disorders and tumors are much common in adults as compared to children. Autoimmune autonomic ganglionopathy is an immune-mediated disorder, and antibodies specifically target the ganglionic AChR, and this is detectable in about 50% of the patients. The initial clues for an autoimmune process came from the Observations regarding the clinical course, that is an acute onset following an antecedent infection, followed by spontaneous recovery or with plasmapheresis or IVIG. And this clinical course has a close resemblance and is analogous with that of GBS, which itself is an immune-mediated disorder. Further definitive proof required the demonstration and development of animal models, that is the experimental autoimmune autonomic ganglionopathy. So let us see the experimental evidences in detail. But before that, let us just take a brief look at the anatomy and physiology of the acetylcholine receptor. We know that there are two main types of acetylcholine receptor, that is the muscarinic and the nicotinic receptor. The nicotinic AChR further is the muscle type and the neuronal type. The muscle type, which is present in the neuromuscular junction and is relevant for myasthenia gravis, and the neuronal type, which is present within the central nervous system and the autonomic ganglia, which we are interested in. So structurally, these are pentameric structures, and the one that is present in the autonomic ganglia specifically has got 2 alpha-3 and 3 beta-4 subunits. So the ganglionic AChR that mediates fast synaptic transmission in all the autonomic ganglia is homologous but genetically and immunologically distinct from the AChR that is present at the neuromuscular junction. The autonomic nervous system has a unique anatomical structure. So it is composed of groups of neurons or ganglia with extensive synaptic connections that lie the peripheral autonomic ganglia is disturbed. Then defective ganglionic transmission will lead to diffuse autonomic failure, and this is central to the pathogenesis of autoimmune autonomic ganglionopathy. Here is the ultrastructure of the ganglionic synapse in a rabbit. You can see that the actual synapse is a short area of close opposition of the nerve terminal and the dendritic membranes, and the acetylcholine containing vesicles are present in close relationship to the synapse. So this is quite similar to the neuromuscular junction synapse, except that the muscle is folded into numerous folds. So although the muscle and ganglionic AChR are very similar, as I said earlier, they are genetically and immunologically distinct, and there is little cross-reactivity between these antibodies. So patients with autoimmune autonomic ganglionopathy typically do not develop the weakness or other clinical features of myasthenia. And similarly, patients with myasthenia who have antibodies against the neuromuscular junction do not develop prominent autonomic dysfunction. Absence of ganglionic AChR in transgenic mice is associated with severe autonomic failure. Here you can compare the normal with the transgenic mouse at 7 weeks of age. You can see that the transgenic mouse is much smaller and the eyes are closed. If you take a closer look, you can see that the globe of the eye is much smaller. The pupils are widely dilated and unresponsive to light. So the closed palpebral fissure may be related to paralysis of the muscles of eyelid opening, the small size of the eye, or some other developmental abnormality. While mydriasis and absence pupillary light response suggest that there is an impaired ciliary body function, and this is consistent with an impaired parasympathetic function. Further, you can see the bladder from a normal mouse in the center and compare it with the bladder from the transgenic mice. You can see that the transgenic mice have abnormal and extreme bladder distension, and these mice had chronic bubbling micturition, frequent bladder infection, and this is a bladder which has been partially cut to demonstrate the dense stone formation filling the bladder. So all of these findings in the transgenic mice indicate that the ganglionic AChR are essential for the normal functioning of the autonomic nervous system. So in related experiments related to active immunization as well as passive transfer of antibodies to the experimental animals also resulted in evidence of ocular dysautonomia in the form of sustained ptosis, pupillary dilation because of sympathetic denervation of the levator palpebrae superioris and the denervation of the pupillary constrictor muscles respectively. These animals develop profound GI symptoms in the form of dilated bowel loops resulting in intestinal pseudo-obstruction as seen here and here, as well as marked distension of the bladder. The barium, the video fluoroscopy to image the barium transit through the gut also shows a delayed transit through the stomach and the duodenum. This indicates that there is a severe gastroparesis in the experimental models of autoimmune autonomic ganglionopathy. Further, in vitro studies also demonstrated the inhibitory effects of these antibodies. The cultured human neuroblastoma cells were exposed to the sera from patients with autoimmune autonomic ganglionopathy, and you can see that the AChR current progressively reduced from baseline and at 20 minutes and 50 minutes after the application of the sera, whereas the sera from the normal control subjects did not have any effect on the AChR current. And this graph shows that the magnitude of the current reduction correlated with the antibody titers. So all of these experimental findings indicate that the ganglionic AChR antibodies in patients with autoimmune titers had more severe disease. These patients usually develop disabling symptoms over a few weeks itself. They improve spontaneously or with treatment, but usually have an incomplete recovery. On the other hand, patients with lower antibody titers had a more milder illness with a more chronic insidious course and limited form of autonomic failure. But this has not been consistently recorded in all the studies. Now, about half the patients of autoimmune autonomic ganglionopathy are seronegative for the ganglioside AChR antibodies, and some authors consider these patients to be a distinct subset with prominent sympathetic failure and sensory symptoms, who manifest with acute to subacute onset of orthostatic hypotension and gastrointestinal symptoms, together with prominent sensory deficits and severe neuropathic pain. This pattern of autonomic failure was different from that of the seropositive autoimmune autonomic ganglionopathy. Here, there was a length-dependent sensory symptoms and QSAR deficits, which suggested that the pathology was in the peripheral nerves rather than in the autonomic ganglia. Some of these patients responded well to steroids rather than to plasmapheresis or IVIG. So this raised the question as to whether this group represents a cell-mediated immune disorder rather than an antibody-mediated process. Coming to laboratory testing, the first step is to document the autonomic dysfunction objectively in order to know the severity and for follow-up. These are the various scales and various tests that are used to document the involvement of the sympathetic and the parasympathetic arms of the autonomic nervous system. Among these, the most unique is the quantitative pupillometry, which reveals the pupillary fatigue. This refers to premature pupillary redilation in response to a prolonged light stimulus. So here are the graphs of pupillometry recorded from the right eye indicated in the orange line and the left eye indicated in the black line. Light stimuli were given for 2 seconds and the arrows indicate the time of onset of the pupillary dilation. In the normal healthy controls, the pupillary redilation occurred after the cessation of the 2-second light stimulus, whereas in patients with autoimmune autonomic ganglionopathy, the dilation of the pupils occurred even before the cessation of the light stimulus, as you can see here. So it was monocular in some patients and binocular in other patients. So in all patients, there was at least one eye with premature pupillary redilation. This is a unique feature of autoimmune autonomic ganglionopathy, and this presents a proof of impaired synaptic transmission in the autonomic ganglia, much similar to the impaired synaptic transmission in the neuromuscular junction and muscle fatigue of myasthenia gravis. Now, the cardiac sympathetic function can also be non-invasively recorded by MIBG. And here you can see that the cardiac uptake in the heart is markedly reduced, both in the early images as well as in the late scans. And this uptake improves after treatment with the immunotherapy. Coming to other studies, nerve conduction studies and EMG are typically normal, though some evidence of postganglionic nerve fiber involvement may be present in the sural nerve biopsy and in the skin biopsy. The skin biopsy shows marked loss of epidermal nerve fibers and a very poor subepidermal neural plexus. The pseudomotor innervation also appears to be poor and deranged compared to normal. And not only that, the density of the Meissner's corpuscles is also reduced with evident morphological abnormalities of the surviving receptors. So these skin biopsy findings are consistent with severe sensory and autonomic cutaneous denervation, and this postganglionic autonomic change could be related to prolonged and severely impaired synaptic transmission. Other tests like CSF analysis reveal mildly elevated protein without pleocytosis similar to that in GBS. But in addition, investigation should also include those that are relevant for extra-autonomic manifestations based on the symptoms. This should include screening for other autoimmune disorders as well as systemic malignancies. Different techniques have been developed to identify the antibodies to the ganglionic AChR, and they detect antibodies that specifically bind the alpha-3 subunits. Those other targets such as beta-4 and alpha-7 are also under investigation. Patients with autoimmune autonomic ganglionopathy often have very high titers, and levels above 0.2 nanomole per liter are considered to be fairly specific. And severe disease, in patients with severe disease, the titers are often more than 1 nanomole per liter. The lower antibody titers are often found in patients with mild or limited forms of autoimmune autonomic ganglionopathy, such as these. And other antibodies such as these are also under investigation for anhidrosis, autoimmune GI dysmotility, and the POTS syndrome. The treatment of this disorder can be discussed under two broad headings. Symptomatic treatment, which targets the symptoms, and this is similar to that for any other autonomic disorder, and a combination of multiple treatment may be required for the various symptoms on a case-to-case basis. The next or the most important step is to target the abnormal immune activation. But the data regarding the response to immunomodulatory therapies is limited. Whatever it is, the first-line therapy comprises of steroids, intravenous immunoglobulins, and plasmapheresis. The most severely affected patients may not respond to one first-line therapy, so they may require a combination of first-line therapies, followed by treatment with immunosuppressants such as azathioprine, mycophenolate, and rituximab in order to maintain the improvement. At present, it is unclear which immunotherapy combination or which order of the first-line therapy should be given for treating this disorder. But interestingly, in the light of the pathophysiological similarities with myasthenia gravis, these authors have proposed that patients with autoimmune autonomic ganglionopathy may benefit from treatment with cholinesterase inhibitors because they enhance the transmission across the synapse and improve the safety factor. In fact, pyridostigmine has been shown to improve the orthostatic hypotension without aggravating the supine hypertension, as well as the orthostatic intolerance that is associated with POTS. It also improves salivation and GI motility, though this did not bring about a dramatic clinical benefit. What we see more commonly in our clinical practice are patients like this. Here is a 12-year-old boy who presented with acute areflexic ascending paralysis requiring mechanical ventilation from the 4th day of illness. You can see that he has ptosis as well as weakness of the facial muscles, and here the extraocular movements are also restricted. So one important deity would be myasthenia, but you see the patient had areflexia, a demyelinating electrophysiology, lack of decremental response, and the neostigmine test was also negative. So this patient was diagnosed to have critically ill GBS. Story doesn't end here. During the hospital stay, in addition to the severe motor deficits, he developed the wildly swinging pulse rates and blood pressure and temperature as shown in this chart. The CT and MRI of the brain were initially normal, but he developed 2 episodes of GTCS in hospital, following which he lost the visual fixation. As you can see, the patient was already quadriplegic with restricted eye movements, and now the patient had impaired vision, so he went into a kind of a locked-in state. And the CT scan, a repeat CT scan, showed hypodensities within the parietal and occipital region, suggestive of PRES, the posterior reversible encephalopathy syndrome. So this patient improved with plasmapheresis and has been on follow-up for 6 years. There is no recurrence of seizures, no recurrence of hypertension, but he has residual weakness of the distal extremities, and the patient was finally diagnosed with a critically ill GBS. This means GBS. Here is another 10-year-old girl who presented with descending weakness in the form of dysarthria, dysphagia, and nasal regurgitation, followed by difficulty in walking. An examination the 4th week of illness showed bifacial weakness, palatal weakness, hypotonia, areflexia, and she eventually developed respiratory difficulty. Antecedent history was significant for fever and sore throat. Again, in this patient also, there was evidence of severe dysautonomy in the form of markedly fluctuating blood pressure, pulse, and temperature, and the ECG also showed ectopics. The nerve conduction study showed a demyelinating neuropathy as evidenced by increased distal latencies and slowed conduction velocities. And here you can see that the patient has a biphasic clinical course with initial occurrence of bulbar symptoms and cranial nerve palsies followed by quadriparesis, a pattern that is typical for diphtheretic neuropathy. It is important to recognize this because of the implications for treatment and vaccination. Here is another case scenario, a patient of myasthenia who discontinued treatment and came in crisis. He received the standard recommended treatment for myasthenia with ICU care, mechanical ventilation, plasmapheresis, and he didn't improve. Rather, he developed an encephalopathy with picking behavior, increased oral and tracheal secretions, features of cardiac dysautonomia, and also there was quivering muscle movement in the limbs and the trunk. To cut the long story short, he was sequentially diagnosed to have cholinergic crisis, hypoxic brain injury because of the encephalopathy, etc., before the diagnosis of Morvan syndrome was considered, and this was confirmed by the Caspr2 antibody positivity. So this, of course, is a rare case scenario, but as you can see, the Caspr2 antibody is more readily available than the ganglionic AChR antibodies, at least at present, in order to prove the diagnosis. Now here are two brothers who presented with 1 decade of dysautonomia and episodic encephalopathy and diffuse leptomeningeal enhancement in the brain. You see that the abdominal fat pad as well as the nerve biopsy shows the amorphous amyloid deficit. So this family had a familial amyloid polyneuropathy with leptomeningeal enhancement, and this diagnosis was established by genetic studies that demonstrated a transthyretin mutation. This means that autonomic failure have various differential diagnoses ranging from diabetes mellitus, inherited disorders to autoimmune disorders such as the most common GBS to paraneoplastic disorders and the systemic autoimmune disorders. And these disorders are much more common than the typical autoimmune autonomic ganglionopathy, and you need to keep these in mind while evaluating a patient. So when a patient presents with autonomic dysfunction, it is important to critically evaluate the patient clinically for the pattern of involvement. That is to look for additional sites of neuroaxis involvement such as the peripheral nerves, the central nervous system, and the neuromuscular junction, as well as sites of other system involvement, while simultaneously performing the electrophysiological and other autonomic function tests for objective quantification of the deficits, antibody testing not only for the ganglionic AChR but also for those relevant for the other systemic autoimmune disorders and systemic malignancies, followed by the appropriate treatment and follow-up for the clinical response. So to summarize, here is a simplified schematic diagram showing the anatomy of the peripheral autonomic nervous system. The autonomic ganglia receive input from the brainstem and the spinal cord, and the fast ganglionic synaptic transmission is mediated by the acetylcholine acting on the neuronal acetylcholine receptors, which are the primary targets in autoimmune autonomic ganglionopathy. This is a distinct clinical entity with a broad spectrum of clinical manifestations in the form of widespread autonomic dysfunction, with orthostatic hypotension and GI dysmotility being very prominent. They can occur with or without concomitant central nervous system, sensory, and other autoimmune disorders, as well as a paraneoplastic manifestation. The treatment comprises of symptomatic and immunotherapies, but further studies are required to clarify which immunotherapy combination or which order of immunotherapies is the best for treating these autonomic and extra-autonomic manifestations of this disorder. Thank you.
Thank you, Madam. Madam is available on Zoom. Therefore, any questions or clarifications that we can ask.
Thank you. Thank you, Madhu. I think that was a very informative lecture. I just wanted to know, are these antibodies, these ACH antibodies, available anywhere in our country if we want to do the antibodies?
The ganglionic AChR antibodies are not available.
You are not audible. You are not audible.
The ganglionic AChR antibodies are not available, which is specific for this condition.
Yeah.
Commonly, the thought is that many of the fibromyalgia cases, what we are thinking, or the, in fact, we had a patient after the heart transplant, he came with severe neck pain to the extent that he was evaluated by first orthopedician and neurosurgeon. Then somehow they came to us. Then when I asked about it, it was total postural. Therefore, most of he had a coat hanger headache, and that was it. Therefore, on abdominal binders and increasing the fluid intake, it subsided. It was better. Therefore, apart from this autonomic, are we missing a lot of routine autonomic neuropathy in the OPD, madam?
That is true. because there is a paper which may be of interest. They tested the ganglionic AChR antibodies in patients who presented with, within quotes, functional disorder or conversion disorder. So what was special about these patients was that they had features of orthostatic intolerance, though the orthostatic hypotension or POTS could not be established, I think, in that group. They had GI symptoms and orthostatic intolerance, and in them, 27% had ganglionic AChR antibodies. So it is possible that some of these patients are being labeled as functional disorders or conversion disorders. If you look at the autoimmune autonomic dysfunction chapter in Bradley, there is a sentence that many of the functional disorders like Crohn's disease were earlier labeled as psychiatric disorders, and patients used to be referred to psychiatrists before the exact pathology and the etiopathogenesis could be established. So it is possible that future, with increasing knowledge, we'll have a better explanation and scientific basis for these patients.
No, we see many times patients who, particularly ladies, but sometimes men also, who are having borderline low blood pressure, aches and pains all over the body, syncopal attacks, abdominal discomfort. And as you rightly said, some of them may be having these ACH antibodies. Usually we send them with some antidepressant, but now the treatment will become very expensive. We have to give them IVIG or rituximab.
Yeah, now case presentation.
Thank you, Madhu. Thanks a lot.
Thank you.
Yeah, madam is online.
So this is an interesting case which we have seen in our OPD. A 63-year-old gentleman who is known diabetic presented with history of seizures for the past 3 months. Semiology of seizure described was jerking of the limbs and body with slurring of speech on standing within 1 minute, followed by head drop. He falls down with uprolling of eyes and slow head and eye deviation to the right side associated with urinary incontinence lasting for 5 minutes without any postictal confusion. Patient recovers immediately on lying supine. He was on 3 anti-seizure medications when he has come to us. On examination, he had hyporeflexia both upper limbs and areflexia in the lower limbs with decreased vibration sensation on the toes. JPS is normal. Rombergs could not be tested. So here is a video. Yes, I could not fast forward. It's not showing bar.
Yeah, you may be doing.
I think they are. So on immediately making him, this is a tilt test, when he was made from supine to upright posture. Here we can see slowly initially he was responding and slowly his limb gets jerking and with uprolling of eyes and slowly head and eye deviation to right side, followed by confusional state, and he could not respond. So this was his state. And immediately he could fell down. So his BP in supine position was 130 by 80 mmHg, and in sitting it was not recordable. And nerve conduction studies showed axonal sensory motor neuropathy. HbA1c is 5.6, well controlled. We have done 24-hour urinary norepinephrine and metanephrine, which was normal. Whole body PET scan was done normal, and serum paraneoplastic panel is normal. Video EEG correlation, as we can see, there are only myogenic artifacts and there is no epileptiform activity in the background. And when he gets the attack, there is bradycardia with diffuse slowing, complete diffuse slowing, we can see here. So he was managed with abdominal binders, above knee stockings. Diagnosis initially we have thought as immune mediated orthostatic hypotension. So we have managed him with IV methylprednisolone for pulse therapy, 1 gram high dose for 3 days, followed which we have managed with abdominal binders, above knee stockings, and high salt diet, hydration, midodrine, fludrocortisone. And after 1 month in the OPD, he could at least walk normally and he could do his daily activities. He could go to washroom and do the daily routine activities. He was independent for that. Thank you. It's like immune mediated orthostatic. Here he came to us with an MRI brain done outside, sir. It was normal.
If it was that case, you wouldn't have improved after a month. Yes, I'm not saying that. When you see such postural thing, one of the DDs is there.
Yes, sir.
In some patients with multiple system atrophy, they may start with this abnormality. We have to follow up.
Thank you, sir.
Yeah. Thank you, Madhu Madam, for joining for this session. Now we are having a second session. Yeah. Madam? Just checking, ma'am. Hello, madam. Yeah. Your comments, please, ma'am.
Yeah, that was a very interesting case, very well presented. I would like to know whether the patient had any other dysautonomia features or only pure orthostatic hypotension was present.
It seems only pure orthostatic hypotension.
Nice, well presented.
Now we have a second session. I would request Varalakshmi Madam and Srirangalaxmi Madam to please chair the session. And the talk is by Khadilkar sir.
Good afternoon, everyone. Now we are moving to another very interesting topic, and it is being presented by none other than Dr. Satish Khadilkar, who is an expert and has written so many articles in national and international journals. He is Dean and Professor and Head of the Department of Neurology in Bombay Hospital, Mumbai. And he's a Professor Emeritus in Grant Medical College. And Sir sir, please move on to presenting this topic. And we are enthusiastic in listening from you, because really we have moved from routine neuropathies. We have been long hearing to the routine neuropathies, acute GB, chronic neuropathies, and recurrent GB with antibody positive, antibody negative. I think you have grouped them in one particular entity which has got the great name, and how to treat and how to go about in managing these cases. Please give your...
Thank you. Good morning, everyone. Also must thank the organizers for asking me to be here. And Praveen particularly has been very, very kind in communicating. Right. So to introduce the topic, let me just take you through in a minute on how the field of neuropathies is developed. You know, first there were only clinicians. So distal weakness, distal sensory loss, and nerve dysfunction. So we were only clinically dividing them into distal, distal proximal, sensory motor, what have we. Then came the electrophysiology chaps. And they said, okay, we can divide them into demyelinating and axonal, because axonal has these problems, demyelinating has these findings. So we went from clinical to clinical and electrophysiological, where it got very nicely stuck in our minds that neuropathies are of two types, demyelinating or axonal, and sometimes mixed. So we worked like that for a while. Then the pathology chaps, they showed that some of them were inflammatory, some of them had this onion bulb, some of them had paraprotein depositions. So more understanding of myelinopathies and axonopathies. And now have come the serology chaps, who say that there are ganglioside antibodies, there are different types of IgG4 antibodies, and the electron microscopists who have studied the node of NVA and the paranodal structures. So that's how we arrive in the evolution on the nodoparanodopathies. Now, what's the real point to note? Now, nodal structures takes off the myelin from the axon. So we get a slightly different concept that myelinopathy and axonopathy are not two watertight and separate entities. They come together at the node of Ranvier because myelin gets disrupted, and you get a myelinopathy when the problem is actually at the axon-myelin junction. Right, so what's the concept? So basically, a common underlying pathogenic dysfunction. This is where I think from the electrophysiologist's differentiation of demyelinating and axonal, we have come back to a common underlying pathogenic dysfunction at the nodal region, resulting in a pathophysiological continuum from reversible conduction failure to axonal degeneration. So this concept is now put together a continuum of reversible neuropathies to irreversible axonal degeneration. And I think for those of you who want to refer to two papers, I'll refer. One is Ancini, Antonio Ancini. There are two papers by Ancini 10 years apart. And I think if you read those two, the first one on this list, they really tell you the complete evolution of this concept. And the second serious worker in the field is Janev Femi. And then there's a third group, Japanese group, Kuwabara and colleagues. So immune-mediated. They are also demyelinating. Why are they moving out of the CIDP spectrum? Cell-mediated response, and you will see cells in the myelin. And therefore, it is completely different from a nodopathy, which is a cytokine or interleukin-mediated response. And therefore, people currently believe that there are two separate pathophysiological processes. And therefore, they're moving out of, all the ones that have antibodies are slowly moving out of CIDP. But that worries me a little. This is like every subsection moving out of Indian Academy of Neurology. So finally, what will be left as CIDP? In a way, they're all CIDPs. Another disadvantage of moving them out is each entity is seen in a few numbers. So how will you design clinical trials? How will you show what is helpful? So it's much better to put them as CIDPs. Right. So currently, as we understand, the nodopathy has following features. It is characterized by, as I told you, a pathophysiological continuum from transitory conduction block to a complete axonal degeneration. The conduction block is due to paranodal myelin detachment. The myelin has come off. Node lengthening and dysfunction and disruption of various channels, altered homeostasis, and then axolemal changes. Such a conduction block may be promptly reversible without the development of excessive temporal dysfunction. So from the electrophysiological point of view, it is CB without TD. Most of the CIDPs, you will see CB and TD, conduction block and temporal dysfunction. Right. Now this is one such patient where you see on day 1, there is a conduction block. Patient's clinical presentation was GB syndrome. And on day 7, you see very good recovery. Now, I'm sure all of us from time to time have been surprised at how well some GBS patients have recovered. And now perhaps we know the explanation for it. And this cartoon shows you that classic AIDP, Aman with axonal degeneration, and Aman with RCF and AMSIN, which is a spectrum. Right. So next few slides are going to be on some patients that we collected with antibodies. Now, some antibodies are done at Amrita, some antibodies are done at Oxford. So some are cell-based, some are this. So in that sense, the whole collection that I'm showing today has different things. Right. So basically, 21 patients I put together. Also, the patient, the one that you showed a while ago, where it's so difficult to know what it is, these ones I have not put together in this. I don't know what they are. So the outliers and the ones where we don't know. This presentation I'm doing so that you who are early in neurology get the types of diseases where you should look for nodopathies. Right. So see, these are the clinical presentations in which one would suspect. One is a GBS, and I'll tell you what sort of GBS. A CIDP starts acutely and becomes CIDP. Standard CIDP-like presentation, and other presentations. And this pie diagram shows you that antibodies can be present single or in combination. So it's a good practice to send all. Right. So these are the clinical presentations in which you will get the antibodies. So first we'll say GBS. And you know that within the rubric of GBS, you have classic demyelinating, Aman, AMSAN, Aman with reversible conduction failure, and Aman with conduction block neuropathy. That's a newer term in this spectrum. Now you see, when this is a real example, in 2000, a patient came with GBS and was admitted under my care in Bombay Hospital. And he was very severe. He went on ventilator on first day, and IVIG was used. He didn't get better. At that point in time, we were stopping there. You used IVIG, now you just nurse and the patient may get better. Since he was a important patient, we sought help from everyone, including outside India. And everyone said the same thing, that you have to wait. At the most, Austin Sumner suggested that after 6 weeks, you may repeat a course of IVIG, which at that point in time was not a done thing. So we waited for a long time. This patient really took a very long time to improve. Now, a very similar situation coming today, how this knowledge is changing. So, what are the 2 or 3 features of GBS which prompt you to say that this could be a nodopathy? One is a very severe disease. Within 24 hours going down and out. Rapid deterioration. Fluctuating course. You give IVIG, they get better, again they go down. Or a recurrent disease. Now, since I work in a tertiary referral center, it's very difficult for me to know epidemiology like any one of us working in tertiary center. But last 2 years, I have seen recurrent GBS more often than what I have seen before. I don't know what it means. And pain. GBS patients, have tingling and numbness. But when a patient has a lot of pain, that's another indicator. So severe disease, rapid deterioration, fluctuating course, recurrent disease, and pain within the AIDP umbrella are features when you will suspect. So this is one such patient who was grade 0 in 24 hours. This is him 2 months into the illness. And he received various medications. I'll show you which medications. And he slowly improved. And then he's really improved. It's taken him 3.5 months. Second clinical group is ACIDP. Starts as acute GBS-like presentation and then goes on to become a CIDP. And here, I think like was mentioned earlier in the morning, tremor, severe sensory ataxia, and severe neuropathic pain are the 3 clinical pointers towards the fact that it could be a neuropathy. Now, this is one such patient with 186 positivity who is a very young boy, 6 years old when he started. First 3 attack, acute quadriparesis like GBS. Improved with IVIG, once with IV MPS. And at worst, this is as much as he would be able to do. The 4th attack was ataxia, tremor, and myoclonus. He had severe pain. This is a point where we moved on to rituximab. His plexi were thickened, and oh God, this video again is. But he had tremendous ataxia and myoclonus. So he had 2 clinical phenotypes going on. And after he received rituximab, he hasn't, from end of 21 till now, he hasn't had any recurrence. And this is the video he sent last week. So I think it's fabulous. I don't think before the knowledge of these antibodies, I would have used rituximab on this patient. I would have at the most been using IVIG again and again. And this we will skip. It's again a similar patient who improved. Then comes the CIDP. What are the characteristics that tell you that this CIDP could be a nodopathy? Recurrence, resistance to treatment, severe sensory ataxia, severe tremors, again pain, and cranial neuropathy. So all these presentations up to a point are painful neuropathies. Besides the GBS, ACIDP, CIDP, there are central and peripheral demyelination. Now this is where the whole thing gets a little broader and a little as yet ill understood. Like a small proportion of them have central and peripheral demyelination. Some have only sensory ataxia, and occasionally they have mononeuritis multiplex, as was seen in this group. Now see, this is a lady who came with a CIDP presentation, but also had a central lesion. Now, oh God. She was very bad. And slowly she improved. And this is her about 3 weeks ago. She's also on rituximab. She has a central and peripheral demyelination. Right. This is where there seems to be a little crossover between MOG antibodies and neurofacin antibodies, or ganglioside antibodies, or IgG antibodies. I have studied only 2 patients with this up till now, but literature is full of these case reports. Right. So, when do you suspect a nodoparanodopathy? Acute to subacute onset, predominantly distal motor neuropathy with rapid progression, severe nadir disability, sensory ataxia, tremor, neuropathic pain, prominent cranial neuropathy. Now, in associated diseases, nephrotic syndrome. I mean, if you have somebody who has a neuropathy and a nephrotic syndrome coming together, you can almost be certain that that's going to be one of these neuropathies or IgG paraprotein lymphoproliferative diseases. What investigations do you resort to? Electrophysiology. But you need a good electrophysiology doctor with you to show you various conduction failures, to show you types of conduction failures, to show how they recover. And you also need to do them maybe every weekly or every fortnightly to see what is happening. Radiology can show you plexus enlargement, as I showed you in one patient. So serial electrophysiological studies, MR neurography, antibody testing in the venous blood. Now we'll touch upon a few points on treatment. I have still 9 minutes. See, all of us from time to time have wondered whether GBS responds, some GBS respond to steroids. Yes? I mean, patients who did not afford IVIG, patients who can't undergo plex. Every neurologist from time to time has used methylprednisolone. And sometimes you're surprised to see, oh, there is something happening here. But the literature says, no, you can't use. So you just say, okay, somehow this got better. But some of them could be nodopathies. The GBS presentation of nodopathies. Because see here, the first treatments used were corticosteroids, IVIG, plasma exchange. And to each one, there is a response of these the group of 21 patients. And the maximum response is to corticosteroids. So I think this clinician's feeling that was there gets substantiated now with a little more understanding of the pathophysiology of these processes. So I think if a GBS today comes to me in a center where a patient can't afford, I do not have access, and there are these markers, I would use corticosteroid. And I would not feel ashamed about having used methylprednisolone because a proportion of them do improve. But most of them require more than one type of immunosuppressant. So you can see in that pie chart, most require 3, and the maximum required has been 6. Those who rituximab was used as a third agent in this, in our setting. There are papers to show that it can be used earlier, but results are mixed. And the INCAT improvement means INCAT goes down, and IROD's improvement means IROD score goes up. So as both these diagrams show, with rituximab, the 50% of the resistant patients improve. And generally 50% of the patients in the group went to the third line treatment. So a very broad algorithm can be looked at. Of course, this has to be heavily tailored to a patient that you're going to see. When you suspect a nodo or paranodopathy based on the clinical features or clinical and electrophysiological features and antibodies, first you send a test for antibodies. Depending on the presentation, one can use corticosteroid, IVIG, or Plex. Refractory. Now, here we have put this algorithm shows Plex as refractory. That's more because IVIG is so much easier to give, but any one of them. And no response for 8 weeks, one could consider rituximab. If a patient is very severe, you can directly go to rituximab. This is based on some literature, but I'm not sure how good the studies on early rituximab are. So to recap, what we have understood in this new set of neuropathies is that the final common pathway is the disruption or dysfunction of the excitable axolema at the nodal junction. It's a pathophysiological continuum from reversible conduction failure to conduction block to axonal degeneration. There's a term called axonal conduction block that's also postulated by Shin-O. And conduction block is a result in these conditions of paranodal myelin detachment, and then the other things that follow the paranodal myelin detachment. The conduction block may be very quickly reversible without the development of temporal dysfunction, or may progress to axonal degeneration. To this effect, very early on, when axonal GBS was still not come into the literature, Professor Katrak had made a clinical note that some patients of GBS waste away very quickly, whereas most don't. So at that point in time, I was lecturer in the Grant Medical College, so he and me, we were doing some kind of a review of these cases, and I used to see the so-called axonal. Axonal had not come. Patients who had wasted, whose electrophysiology that time was thought to be proximal neuro, what Dr. Mrs. Wadia called it, proximal neuroaxonal degeneration, some kind of proximal axonal problem. So we're tracking these patients. And being a medical college, there were dozens of them. So about 60, 70 patients we studied to realize that those who were power grade 3, 4, 5 behaved just like the demyelinating ones. They improved very nicely. Those who were 1 and 2 did not recover very well. Now, we did not use steroids at that time on them, and we didn't have Plex or IVIG in the Grant Medical College. So axonal means bad prognosis doesn't hold true anymore. That's another point. That's another take-home message. Axonal can improve. Axonal can improve by itself or on steroids. And you need serial electrophysiological studies to really understand whether this patient is going to improve. Patients with atypical presentations of GBS or CIDP should undergo early testing of the antibodies. Good response to steroids, as we mentioned, Plex and rituximab. Right. Now, with this early use, I'm using this carefully. I don't know early means how early here. And newer therapies may emerge. There are 6 or 7 papers on various monoclonal antibodies in nodopathies, but they're too small or case reports. Right, so there are 2 minutes more. Thank you very much.
Thank you for a lucid and informative session, sir. One question from my this thing. If there is one scenario where a GB syndrome, supposed to be clinically GB syndrome or acute onset CIDP, suppose if the patient is already very sick on a ventilator, can we consider to give rituximab instead of, after sending the antibodies, can we consider to give early rituximab in such cases?
The clinicians and the families' apprehension would come into picture that the patient is so bad and not improving, and how much can I go up to? I don't know how quickly rituximab starts acting in a nodopathy. So I have not been giving very quickly, but I discuss it with every family that this looks like this and maybe at some point in time. But I don't think I've used it in first week or as early as that.
Because there is some patients where there is a cost effectiveness. If we discuss about IVIG, many people go back or Plex also
Yeah.
for that matter. So maybe if you're, after listening to your lecture, still corticosteroids have a role. So
Yes.
maybe we can start corticosteroid, just asking you with a
Yes, I think
open-
GBS with these caveats,
Yeah.
there is a definite point in looking at corticosteroid if there is no major contraindication staring at you. Yeah. Now, what percentage of our patients are these, we don't know. Like was pointed out, we do not have a cell-based assay regularly available. We're working on an ELISA. We don't test every patient. So you don't know what percentage it is. But we all know that these are antibody diseases. It may be another antibody. The whole lot of GBS and CIDP finally will be antibody diseases. Yeah, but steroid and Plex seem to be better. Though IVIG also has a success rate of some 20 or something similar to that. But more motor the syndrome, this is again a clinician's statement, more motor the syndrome, more likely IVIG will work. More sensory the syndrome, more likely steroid. But please don't quote me on this. I have no study on this. Like multifocal motor neuropathy. Only IVIG will work, and steroids may actually take it down. Where you see MAD-SAM will do beautifully on this. Of course, antibodies are different, but that's a very broad and a general statement. Yeah. Autonomic dysfunction has been described. Yeah, even autonomic has been described as part of the syndrome in some studies. Also, there are papers to show that Casper and LGI may be abnormal, and people may actually have a combination of hyperexcitable peripheral nerve syndrome and a nodopathy like CIDP. We have also all seen some CIDPs that fasciculate. So it must be a whole syndrome.
Satish, in NIMHANS, they don't do IVIG in any GB. They directly go to Plex. It's a tradition in NIMHANS right from beginning. So people who are trained from NIMHANS use only Plex. And I think that seems to be a good thing after hearing your lecture, to begin with Plex, and if it doesn't work, then go to rituximab. To totally bypass IVIG.
In fact, giving Plex earlier, if your nephrology colleagues you are comfortable with them, is in another way also a better idea. That after having given Plex, if nothing is working, you can use IVIG. If you've done the reverse, then you are probably waiting, or at least technically you are removing that IVIG before giving Plex. So yes.
Sir, in GB syndrome patient who is on IVIG develops autonomic disturbances, can steroids help?
I don't know.
Because
Well,
how to manage those patients?
At this point, I think it is very case-based. But the jinx that steroid just can't be used, you're being non-scientific by not using them. By using them, it doesn't seem that true. At least in some settings, yeah.
Because we work in a poor government hospital where patients can't afford. IVIG is supplied with the government sometimes.
Yeah.
We give steroids. Autonomic function sometimes stabilizes.
You find things.
Yes.
I think some of us know that Dr. Kameshwar Prasad has been year after year saying that the studies that show that steroids are not useful are technically flawed. And he picks out the flaws in the statistics. So maybe he's right.
And one more question, sir. In CIDP patients, after giving IVIG, how long we have to wait to give a second course, suppose they don't improve?
In CIDP? Usually, again, a general statement I'm making, usually in 15 days' time after having used the medicine, you start seeing something which is positive and then goes on building for a while. And the next course, people come to know, okay, I will need the next one. Like there are patients on follow-up where IVIG is being funded by agencies, where they come and say, after generally 2.5 months, 3.5 months, that, okay, now is the time for me to take the next dose. So I think it's that range. 2 to 3 months. And there was a patient of MMN on whom I gave it for almost 5.5 years, where first he was requiring it 6 weeks. Then the thing went on increasing, and last 1 year we have stopped it. So patients also come to know when the response is coming down. But within a few weeks, I don't think in the first week or two, most don't start seeing anything, though some do on the second, third dose also.
So nowadays, subcutaneous IVIG is getting more popularity in the journals. Yeah. What about your experience?
I have no experience with it. There are 1 or 2 patients who are taking it, but primarily I'm not tracking them.
Yeah, so 2 things. One, steroids is doomed primarily because we didn't do any randomized controlled trial when we could have done it. Now no ethics committee will give an approval for doing anything, so that's one thing. Second thing is, for rituximab, there is an ongoing trial in AIMS, it's a DST-funded project where we're giving rituximab as immediately after IVIG. This one, along with a control arm where you give only IVIG in AIDP. So we tried for something to give rituximab versus IVIG, but ethics won't approve. So at least to show that if we can effective, if that shows some effectiveness, the next step is to go to head-to-head with an IVIG with a rituximab versus for the next trial. At least we can go to the ethics committee and ask for a trial, because trials have been happening with eculizumab on GAV. Then why not? If it is an antibody-mediated disease, it might work.
Also, in general, I think the boogie of side effects with rituximab is getting less and less. We all feel more confident about handling rituximab. That's another factor.
Sir, I have one hypothesis. These nodopathies are all IgG4 diseases.
Yes.
So, for example, if you see a GBS, polyradicular neuropathy, acute phase, probably people means if you do IgG4 antibodies, if the titers are high, IgG4 getting is very easy. If they are high, then maybe we can straight away try rituximab. That is my hypothesis. That's why probably they may have responded to steroids or PLEX. IVIG may not actually neutralize the IgG4 antibodies. I feel so. What is your
point?
No, I am hypothesizing, madam. Actually, the same question I asked in one virtual conference also, but that time the literature, but same thing I am feeling. Because it is so easy to get IgG4.
I think this study will also be easy to do. On those whom we are sending, we'll send this as well. Yeah.
Yep,
Thank you.
Other questions we'll do in the lunch break. Sorry.
Thank you, sir.
Now I request Vishnu sir to present. Dr. Vishnu sir is from AIMS, and his specialization in the neuromuscular junctions disorders, and he has multiple papers in that. Sorry. I would request Vishnu sir to present the presentation.
Okay. Thanks, the organizers, for calling me. So, my first disclosure is I'm not a geneticist. I'm a pure clinician. You should think of an example is a neurologist teaching statistics and not a statistician teaching statistics. So, if you have listened to statisticians teaching statistics or neurologists teaching statistics, we can decide which one is better. But my knowledge may not be complete in every aspect. So if you have doubts, Dr. Kadilkar is there. We can ask him also. So and have consent for photographs taken in this. So my objective is, it's a big talk. You can divide it into each of these things can be given in for hours as how these tests have been used. I'll try and cover the basic terminology because without knowing that, it is very difficult to understand these tests. The commonly used genetic tests and how it is important and how to order and interpret. I don't think due to the time constraint, we will reach up to the interpretation. Let's see. So I'll show you a brief case scenario. So I'll run through it due to lack of time. 36-year-old with proximal weakness in upper limb and lower limb for 5 years, slowly progressive, no sensory. DTRs are hyporeflexia. CK is showing around mildly elevated 1200. EMG was done outside, just showing myopathic. So somebody did a biopsy. He found dystrophin was reduced. It was reported as a dystrophy and Becker muscular, as a typo there. It was reported outside as a Becker muscular dystrophy. Somebody did a DMD MLPA. It was negative. Then went to whole exome sequencing, again negative. So what do you think? Somebody missed anything? Is an undiagnosed LGMD or... But before that, when we reviewed the case, it came to another faculty in our department, so he reviewed, he thought that distal upper limb weakness was there, polyminy myoclonus was there, fasciculation was there. What do you think? SMA, or somebody was thinking SMA. So somebody did an SMA MLPA, it was negative. Somebody did an MRI brain, found mild cerebellar atrophy was there, so thought there was an amyotrophic presentation of a scar or something, did a scar panel, it was negative. And then, what do you do next? So you review the patient again, see the patient again, remove the shirt, everything, and examine the patient again. There's a facial, there's facial weakness, fungus, tongue and fasciculations, gynecomastia. It's not a difficult diagnosis to make. So if you have examined the clinical examination, so my point here was, this is another patient supervision with the classical. If you remove the diagnosis on your face, so if you're not, you will go into on and on because these cases present with high CK, some amount of sensory involvement, so you will be going around and around without a diagnosis. So if my point is, phenotype is as important as a genotype. Your geneticists can't make much head and tail out of it if you don't give a good clinical information about the case. That's the one learning point that you take from my talk from here is, the clinical examination is the most important thing in a genetic. No, I'll come to that. It will not. Whole exome won't pick up. Whole genome will likely to pick up in the near future at least. So once the clinical examination, history examination is there, one of the most important thing is the family history. I don't think in this audience I need to say about the importance of a family history, whether it's autosomal dominant, recessive, X-linked, maternal inheritance, or mitochondrial. This will definitely affect how you interpret the genetic testing or how you are going to look for the genetic testing or not. So we'll primarily discuss here about the monogenic disease, Mendelian inheritance disease. We will not discuss the multifactorial diseases, the susceptibility genes, those involved. We will not discuss. We'll look at the high penetrant monogenic disorders. So what is genetic testing? So involve any type of medical test that laboratory methods used involving the genes, chromosomes. Sometimes some enzymatic assay is usually told as a genetic. It's not. It doesn't involve on the assays are not genetic testing. It's all the genes and the chromosomes. What are the benefits? Why you want to do a genetic testing? Some people say the why you want. There is no treatment for this. Why you want to do a genetic testing? So once a definitive diagnosis literally saves a lot of money for the patient. So you get, usually a patient comes to AIMS, will have at least 5 NCS EMG with them done in 5 different places. You would have spent at least some 50,000, 60,000 for at least an electrophysiology at least. Our unnecessary and invasive tests like muscle and nerve biopsies may not be required. Our unnecessary treatments like immunotherapies, improved access to clinical trials, which is upcoming for many genetic disorders, they predict the prognosis, monitoring for complications and comorbidities, enabling patient recruitment to the clinical trials and gene therapies, and family planning and testing of at-risk family members. All this can be planned with a proper genetic testing. And one thing you should remember is genetic testing in a clinical setting and in a clinical lab, in an accredited lab, and in a research setting. So, for example, if a patient comes to us and we do in a research project or something, it's an entirely different thing. So, in a clinical lab, reports only those variants of testing which has been fully, they're 100% sure, they have been well reported, those variants only will be reported. So, we may not get all the so-called variants of unknown significance, everything may not be reported. They are not compelled to report also for all the report which they think may not have a great clinical utility at that point of time. So this chart is very important to understand how how do you interpret genetic testing. First is what is a gene? Gene is a contiguous. Okay, so we have so the haplotype is a group of alleles on the same chromosome close enough to it's not a problem for me. I think it's a problem for the audience mainly. I think. haplotypes is the group of alleles on the chromosomes. It's close enough to be inherited together. So we'll know how the genetic inheritance patterns and all is, we can know by that. Most important thing is the homozygous and the heterozygous. So when you get a genetics report, you will see this is a homozygous mutation and the heterozygous mutation, which we all. Yeah. So we all see the homozygous and the heterozygous. So homozygous is the same mutation is present in both the alleles. Heterozygous is only one is present, the other is normal allele. So this is important because when we see the genetic reports comes, that is important. We'll come to that later. Now, what is a variant? Variant is the new term for what we used to previously called as a mutation. Now we don't use the word mutation and mutant because the time, I think probably after the X-Men movies and all, people don't want to call somebody as a mutant or something. I mean, it's not. It's written on literature that's one of the reasons why variant term came to mean, and the mutation previously used to call as point mutations and missense mutations, everything. Now the variant came picture on is what they want to face off the word variant itself. So this is the exon and intron. We all know exon is the one which codes for the mRNA and then the proteins. The introns are the one intermediate things. Previously, we thought that 1 to 2% of the whole genome is the exon. That's what we do in the exome sequencing. We sequence the exons. The rest of the introns were not useful. But more and more literature is coming that introns, a lot of things are happening in the introns, a lot of regulatory things are there in introns. It's not completely useful. A lot of diseases are picked up in the introns also. So when you have a change in the nucleotide, so it could be synonymous or a non-synonymous. That means you change in one nucleotide, the protein is, the amino acid is not changing, then it's called a synonymous. If its amino acid is changing, it's called non-synonymous. From there onwards, the entire shift is shifting, it's called the frame shift. If it is not shifting, only a few amino acids are changing, the rest remains the same, it's called the non-frame shift. And if it is a stop the amino acid, from there it's called the stop codon. So insertion deletions are there when you have an insertion or deletion of bases in the region. If it is more than 50, then you call it as a structural variants. That's important because most of the structural variants are missed in the whole exome sequencing. We need other technology, some of the bigger technologies to identify them, some of them. And the loss of function variants are important because they are the one which we are usually one of the criteria for making it as a pathogenic or not a likely pathogenic variants because they cause a severe reduction or completely absent protein product. So the phenotype, we all know, that's the clinical presentation, clinical picture of the patient, including everything, examination, radiologically, biochemically. That's what you feed to the geneticist as what is the phenotype of the patient. There's something called as locus or a genetic heterogeneity. That means multiple genes can cause the same disease. Or the phenotypic heterogeneity, or the same gene can cause two different diseases like laminin coccus, embryodrophis, and on the LGMD. Or the phenotypic overlap, so like myotonic dystrophy type 1 and 2 kind of overlap of diseases, and two other conditions, two other terms called as the penetrance and expressivity, which is usually confused between two. What is the difference between a penetrance and expressivity? Penetrance means if you have the disease, if you have the variant, what proportion of patients or percentage of patients will actually develop the disease, whatever be the severity, at least some part of disease part of the disease will be developed. For example, Huntington's, which I explained, 100% you get a penetrance. C9 or of 72, you may not have that much penetrance. Everyone won't develop the disease. Expressivity means you develop the disease, but the severity is different in different patient population. Classical example is FSHD. The same family, multiple have the same number of repeats but have different phenotype. One will have mild facial, one have severe weakness. Expressivity is different. Then mosaicism means different. You have a genetically distinct alleles in the same body. So it depends upon the mutation, the somatic mutation or the germline mutation. Now, about the de novo variant is something that just happened onto the patient, which is called sporadic. To call it something de novo, you need to know whether the parents' genetic variant is there when the parents is there or not. Sometimes we think of it as de novo, maybe parents having a reduced penetrance. Anticipation, we all know the next generation, especially in triplet repeat disorders, it anticipates. The severe generation the repeats become more higher and severe in the next generation. This phenotype, I will skip this. The variant, which you all know, but the important thing is how it is a variant identified. You identify with a reference genome. There is an international reference genome. Now the 38th version is now currently going on. The problem with that is it is mainly a Caucasian Western population genetic data. I mean, 80% of that is vacation population. Our Indian, for example, Indian population variants are very underrepresented in the reference genome. So a lot of now, based on the government's recent initiative of the 1000 Genome Project, now more and more Indian genetic data is coming into the literature. Otherwise, we were very underreported and underrepresented in the reference that has implications that cause genetic diseases, which is beyond the scope of this. And the reference genome is, only thing is that there's another reference genome coming up, which is like to include more people. The first reference genome was by 20 anonymous volunteers in USA, which created that, but still it has gaps. It has some unreliable coverage, some area, reflects a very narrow ancestry, which I told before. The variants are commonly, but this copy number variation can be level at the exome level or at the genome level. Exome levels, whole genome level cannot be picked up in the exome sequencing, but the current exome sequencing technology, bioinformatic pipelines are better that they can pick up the exonic CNVs. Now, this is one concept which I want you to know, because you are going to see reports like this. I think you have already seen many reports from morning onwards, like reports like this, like compound heterozygous, one likely pathogenic and one uncertain significance. So what happens to this compound heterozygous? We all know that we get from the parents each one, 2 mutation, one goes into the parents, or you get one from the parent, one from the father and mother, and have 2. So you get a compound heterozygous, 2 variants are located at 2 different locations, but both important to see that these are cis or trans. If you don't identify that cis or trans, then it is very difficult. If cis means if both the variants are coming from the same allele in the chromosomes, in the same chromosome, then it can't be pathogenic because the other chromosome is normal. So just because you get a compound heterozygous mutation like this, you cannot completely say that this is pathogenic. You have to prove it by segregation, doing in the parents and see that both the alleles, one has come from the father, one has come from the mother, and prove it. The bioinformatic pipelines now can reasonably tell if these two variants are lying close together. If you look at the original BAM file, the raw data, they can also reasonably tell that these are coming from 2. They can do some amount of phasing. But if you want to be really sure, if you want to do it on, that is this alone, because we review papers and case reports, this comes late. My first standard statement is you do segregation and prove it. You have not proved the case even till now in this one. So next is a diagenic inheritance. Diagenic inheritance, that means you have to have 2 different mutations to develop the disease. 2 different diseases. Anybody can give an example of a classical diagenic disease? Okay, it's an FSHD2. It's a DUX4 and SMCHD1. DUX4 alone will cause an FSHD1. That means less than 7 or 8 repeat units. But anything because other than DUX4 alone cannot cause FSHD2. FSHD2 to cause, there has to be another mutation. SMCHD1 mutation alone also cannot cause FSHD2. Both has to be present, then only you can develop it. That's called diagenic inheritance. The differentials are a double trouble. Double trouble means you have a 2 different monogenic disorder. So we have a patient, last time we had a patient who was diagnosed as a sarcoglycanopathy. It was a compound heterozygous mutation. Phasing was done. It was coming from both the parents. Or clinically, the CK was around 5,000. So clinically, it looks like a sarcoglycanopathy. Patient was referred to us for FSD testing because he was unusually severe facial weakness was there. So the problem was then nobody bothered to check the mother. Mother had significant facial weakness and scapular winging. Then asked about the grandmother. Grandmother had gone to NIMANS in 1990 and she had one OPD ticket which said FSHD and that more. Then we tested. The mother and the child both are FSHD positive. So it is a double trouble. It has both. He has got a sarcoglycanopathy and an FSHD both. So second thing is that's called a double trouble, got a dual disease in the same person. This is coming because we have more access to testing. Previously this used to be never diagnosed because we don't have access to testing. We don't diagnose these things. Next is a genetic and diagenic inheritance. Usually, if it is the same gene, same thing, if it is coming in the same level, you get a cis, it will mimic like an autosomal dominant. If it is in 2 different, it will look like an autosomal recessive disease. Now coming to the genetic modifiers, a classical example is an SMN2 in a spinal muscular atrophy. The problem is in SMN1, but SMN2 copy number will definitely affect the severity of the disease. There are a lot of other genes, but that alone will not cause the disease. So unless like a double trouble or something, it will only affect the severity, age, severe, and penetration of the disease. The last thing before this is the pseudogenes. Pseudogenes there are a lot of pseudogenes, non-coding region of the gene involving more than 20,000 pseudogenes are supposed to be there. The problem with the pseudogene is like this. The SOD1. SOD1 is a pathogenic. The lab will report it as a SOD is a pseudogene, so we are not 100% sure. You use another method. Why this is important means SOD2 is one of the most common mutation found in undiagnosed CM2 around the world. from the UK consortium, so to, because this was always missed in the bioinformatics pipeline till recently, because it was always thought of as a pseudogene, because there are two genes, the SOD one and the pseudogene is also there. It is whole bioinformatics pipeline. It is difficult to find out whether it is in the pseudogene or the gene or the real gene involved. So that is important to know. And the mosaicism depends upon the mutation happening in the germ cells. So only the patients will have, the parents will be normal, the patients will be having it, or the somatic cells which are having the mutation, the body cells have multiple cells. Lastly, the population allele frequency, you will see in the report, genetic reports, the minor allele frequency is there. So for the autosomal recessive, it is kept as less than 1 in 100. For autosomal dominant, it is less than 1 in 1,000. This is a rough estimate, but sometimes it will cause problems. For example, our common variants like GNE, Calpain, if it goes to a patient goes to UK and their genetic pipeline, the common Calpain variants and GNE variants are missed because it is so common in South Asian population. Their thing it will think as a normal variant unless you know it. So that frequency to understand, to know that these variants are important. Otherwise, your testing will come out as negative. Now, with this background knowledge of some amount of genetic terms, so what are the types of genetic testing that you have? One is a single site. This term is not usually used. Single site means you have a family member who is known Calpain or known testing, known variant, you know it. An affected brother is there, you just have to test that variant alone. So that is the single site testing. Single gene testing is you want to test one gene, you are highly suspect you related DMD or SMA, you know the your clinical suspicion is that. That's a single gene testing. Cytogenetic testing is morely for chromosomal abnormalities. Will not touch that, is mainly for children with development abnormalities, intellectual disabilities. In neuromuscular, we don't do much of a cytogenetic testing. Then comes the next generation testing. Next generation testing or the NGS, the term itself has a problem because there is the problem with next generation is you can't use anything more than that. Everything is next, right? What is the term? What if something new comes? What will you label it as? So it's so all the testing, the genetic panel testing, the whole exome, clinical exome, whole genome, everything is called as the next generation sequencing. Everything uses the same technologies. I'll skip that. So these are the testing that we commonly used it. So we'll come to that. So it's a summary of what are the testing that we use. So important that dystrophinopathies, SMAs, you try and use MLBA, and if you have a point mutation, you use NGS, and you got most of the LGMD, CMS, distal myopathies, channelopathies, all this you currently use NGS technology. CMT and hereditary neuropathy, you use usually CMT1A, demyelinating, you try and do MLPA first, then if you don't get you, then you go to the NGS. Important thing is for myotonic dystrophy, all the repeat disorders, oculopharyngeal muscular dystrophy, Kennedy's disease, or ALS, C9 or 72 will not be picked up in the current whole exome sequencing. There's no point in doing whole exome. You have to do an independent. So most of the current technology that you used is repeat prime PCR. If you want to know the exact thing, you have to do Southern blot. Southern blot is a very cumbersome procedure, which is come to the next FSHD, which we are doing Southern blotting, which is testing is very difficult. The whole thing takes 2 weeks time. If you make one mistake, you have to do it all over again. So that is why most of the people have moved on with the Southern blotting. Otherwise, newer technologies like optical genome mapping, long-read sequencing, it has got significantly. The problem is the cost. The optical genome mapping costs close to 1 lakh per sample. So this diagram will explain to you what is happening in the most of the tests. For example, whole genome, the whole exons, which is here in the blue box, and the purple line is the introns. Everything, including mitochondria, everything is tested in the whole genome. Then comes to the whole exome sequencing. All the exons and the little bit, some 10, 20 base pairs adjacent to the slicing regions are tested. It's called whole exome sequencing. Then you got the whole genome sequencing, only a variants are tested, or they call it gene panel testing. You got a whole genome of variants. So only a few panels, so we call it the clinical exome that you can tell us. Then as a gene panel, only a panel of genes are being tested. On a single gene, only the single gene is tested. The important thing to understand here is, whatever you do a whole exome or whole genome, nobody is going looking at every gene in this one. That's a misconception. You are applying, even in a whole exome, when you get a report, why they are asking for your clinical features or the HPO terms, everything. They are applying a panel on the exome data. If you are thinking of an LGMD, they'll apply an LGMD panel onto the whole exome data. They're not looking at every gene that your body has, or even the whole genome. It will open up a Pandora's box, and it is never ending. You will get some 10 million variants in your patient. Nobody has the time or think to look at each variant that is available. So only good thing about this is, if your clinical examination changes, your finding changes, you can go back to the raw data at any point, 10 years down the line, 20 years down the line, look at it. You apply a new virtual panel, a new gene has been discovered, you can go back and see into the data if it is there or not. So single gene sequencing, as I told, this is for use for, you can use identify most mutations in that coding sequence of the gene, which you can use, usually used for CMT, SMA, or these conditions which I mentioned. Advantage is rapid, if you know cost effective, fewer variants, no VUS because you're looking only at one gene. But difficult to do NGS. Some NGS you are difficult to do, like GC-rich areas or pseudogenes, you can use it for. Limitation is, obviously, if your clinical diagnosis is wrong, the testing will not find out anything. It will still require MLPA for the exon level deletion or duplications. Second test is a multiplex MLPA, multiplex ligation probe analysis. You can multiple probe, you can simultaneously test multiple exons and can be tested. Not going into the technique. Advantages, exon level CNV detection can be done. It is fast, cost effective. It has got a good resolution and accuracy. If you can, there are techniques to include single nucleate variant also, it can be taken, or methylation also into the MLPA. Then you can improve the MLPA technique also, which is less labor intensive than the other conventional karyotyping or FISH testing. Problem is you don't have MLPA for every gene. You have SMA, DMD, few genes only have the MLPA. You don't have everything. So may not detect mosaicism, balanced translocations, does not detect SNV. Single mutations may not be detected. PCR, the triple prime PCR, the testing for myotonic dystrophy, Friedreich's ataxia, Kennedy's, or the scars, everything has been tested. So you don't use whole exome or testing for these conditions. Southern blotting, I'm not going into that. It's a very easy test. So we are doing it. We have the first genetic data of FSHD. So a lot of patients, this guideline paper is good to look at all the testing modality available for FSHD. So if you want to test FSHDs, you send it to us. We can do it for free as a part of a research project. With cytogenetic testing, we're not doing anything. We will not discuss much more than karyotyping FISH and the chromosomal microarray to do because we don't usually use in our neuromuscular disorders. Coming to the panel is something which I also told you can include around any number from 2 genes to 1,000 genes. So there are 2 types of panels, that targeted panel sequencing that is showed. You can select the panel and make it into a panel. Technology is the same for the next generation sequencing. The other panel is a virtual panel that you apply onto a whole exome sequencing or a whole genome sequencing thing. So why you want to choose a gene panel? It's time is up, so I will just see one. There's a lot of, this diagram will show you some amount of difference between the whole exome and the whole genome. So the whole exome, you see, because the depth or coverage, that is number of times that you sequence the gene, the depth is more in a whole exome sequencing, but in whole genome sequencing, you get an average depth along throughout. So sometimes, even in the whole exome, some areas are not covered. The whole genome might cover in those areas. And the introns are not covered. The introns will be covered in this. So I will just go to, because everything, So how do I order a genetic testing? So first thing is carefully consider the testing options and discuss the testing with the patient to ensure that what you're going to do. Always take a consent, which I think at least part of the clinical practice for genetic testing, most places don't take consent. I think you should take consent. Look at the insurance policies like Ayushman Bharat and state insurance. Some of them are covering most of the genetic testing. And the sample to be used, for example, if you need different samples, for example, for southern blotting, you need a high molecular weight DNA, not the normal DNA that we do. We need to make agarose plugs and all. So it's a different thing. So even RNA testing, you had different tubes to be used. So which testing, which lab, you have to talk to your geneticist before sending this testing. And then finally, look at the variants that are coming out. So HPO terms is a term which, I don't know, when you send a sample to a private lab, you will get a reply that kindly provide clinical features of this patient. What they are looking for is these HPO terms. What are the major, HPO terms is something which tries to summarize a clinician's final clinical phenotype of the patient. You use the key word to the patient. That sometimes your panel is wrong, your diagnosis is wrong, but your HPO term was there. That is the reason why the bioinformatics pipeline has picked up that variant. That is also there. So there are examples for that. So I will go. There are variant interpretations are there. So there are different variant. Variant interpretation itself is a separate talk. But what you are trying to find is trying to find a variant of very strong, likely pathogenic or a pathogenic variant. There are some benign variants also. This is the ACMG criteria that we use it for variant calling or variant interpretation. It is an ACMG criteria. You should look at it. Why this criteria you see it because when you have examples, when you hear examples, you see at the end they'll put it up as PP3, PM2, PP3. This is based on what is there in this ACMG criteria. If you know this criteria, most of the time what the lab reports may not be right. Okay? Because lab doesn't have all the clinical information. They have information only what your resident has written on the form. That is based on that only they are reporting it. So if you know this criteria, you can upgrade that variant. Most of this variant VUS, what they reported as VUS, we can make it likely pathogenic. Sometimes what they reported as likely pathogenic may not be likely pathogenic also. The vice versa also comes. So I put it up some examples which we can't do it, but. So this is what is something of the case which I told you about the sarcoglycanopathy. So this facing you have to do. He had a compound heterozygous, you do it on both father and mother and say that one variant comes from the father, one variant comes from the mother. So this will show. So this is the algorithm which we usually follow in what hepatitis test. So go back to the basics and do the history and examination again. And in epilepsy that you asked, no, in refractory epilepsy, is it an epilepsy or not? You think again, is it a genetic mode, a neuromuscular disorder or not? And was an appropriate test being used? For example, if you do a whole exome in an FSHD or myotonic dystrophy, you may not pick it up. Did the gene panel have the correct gene that you're looking for? Did they do it or not? If not, still negative, you reanalyze the raw data, apply appropriate visual panels and see. You look at the depth of the coverage that they're given. Is there a gene which is difficult to sequence in that region? Is there any variant which is the common seen in our population which has been missed by their bioinformatic pipeline? If not, then you do an MDT meeting. That means a meeting with the geneticist and the clinician and sit and see. That discussion, if you have a geneticist in your this one, it will make a lot of difference. Before going further, next step before going into the whole genome, asking patient to spend 1 lakh rupees, ask whether the patient wants to do further testing or not. You have done a basic investigation, available testing, if you want to do it or not. Then if you look at, is there any promising single hits or VUS or a strong clinical phenotype, you're supporting investigation is supporting, you can do a trio whole exome or the whole genome. Different techniques are there available. If you're not there, reanalyze after a few years, because new genes would have discovered on this one. Again, if you have the raw data with us, we can reanalyze and find. There are some incidental findings, some have picked it up. So we usually don't report incidental findings in our project. So we ask the patient when we take the sample itself whether you want to get the incidental findings reported or not. If the patient says yes, then only we'll be reporting it. I'm not going into this. So this is what Kadilkar sir was saying before. Previously, it was clinical examination, clinical biochemical test, muscle biopsy, and single gene testing. Now it has changed a lot of things. So it is clinical examination, you do a single gene and your whole exome something. Then if it comes, then you do a reverse. Sometimes you do a reverse phenotyping, go back and examine the patient again, find anything you find. And we are lucky enough compared to any other system in our body, for functional validation, we have muscle and nerve easily accessible. So this is something which we can do. Thank you.
Thank you. You said you are not a geneticist, but you spoke like that only. Very tough. Any questions?
Sometimes when we had a case like mitochondrial cytomyopathy with 2 brothers, and EMG definitely showed, but the genetic testing revealed negative. I mean, I've sent to 2 labs. Does this happen at any time, or is it?
Yeah, even if, for example, if you look at LHON, our strike rate of the common 3 mutations is hardly 20%. 80% of the time, the 3 common variants in Western population where they've seen 80%, we see hardly 20%. There may be something in new gene or new variant which has not been picked it up. And mitochondrial has so much of phenotypic variation, and sometimes you have to do a muscle, the tissue DNA genetics and find out. Blood may not pick it up. That mutation may not be there in the blood cells. You have to do a muscle tissue and do from the muscle tissue. You have to do
muscle tissue showed.
No, the DNA from the muscle tissue is taken and doing the sequencing and see.
Okay. Then what is how much do we depend on this genetic testing?
So for example, if you look at the best of the centers, even the Newcastle, for the LGMD, their success rate is only 60%. For every doing whole exome, whole genome, everything done, they have solved only 60% of the cases. 30 to 40% of cases are still unsolved. But that is in their 60, for ours, for example, in AIMS, we have recently analyzed our 1,000 probands in our project. So we solved up to close to 76% because we had some low-hanging fruits of a lot of BMDs and this one, which is easy to solve. In a tertiary referral center like Newcastle, BMDs and all don't reach there. They reach cases which are not diagnosed elsewhere and reach it. Even then, they have solved 60%. The rest 40% not known because new genes and every year our LGMD list is increasing, our CMT list is increasing. So new genes are discovered. So one good thing about whole exome and whole genome is our genes are not going to change. So once you have analyzed and have a raw data, at any point of time you can reanalyze and see what new things have come up. So that's
actually we had one more example. Radiologically, this is an early, lady with 40 years, cognitive decline, rapid cognitive decline, and radiologically it was reported as leukodystrophy. When we send the genetic analysis, I think my department people know, they have reported it as Alzheimer's with MND.
Okay,
I don't know how to.
So there are 2-3 things why we couldn't discuss. My residents' next seminar is what to do when the whole exome testing comes negative. So this is
it's not only negative; it's damaging.
Yeah, so that's why we are looking at only the report which has been reported as a pathogenic. We have to look at it in the whole. That is why you have to first thing is to look at there are variants to what we do is first thing is we reanalyze the data. If you can't reanalyze the data also, you look at the variant. There are bioinformatic online pipeline. You put the variant into it and see whether it is actually pathogenic or not pathogenic. For a hypothetical, we assume that this variant was pathogenic for an Alzheimer's disease, but the patient's clinical phenotype is not matching. It's entirely different. Then it is not pathogenic. So that what they have reported is that variant is pathogenic. That variant is pathogenic need not because that need not for example, if I do a genetic testing in me, they might find some pathogenic variant in some gene somewhere. That doesn't mean that I will have the disease. So your phenotype should match. So that's the primary reason why they are applying a virtual panel onto it. Why the whole genome is there? They can look at all the genes and report all the variants to you. But then this will open up this Pandora's box. They'll report one pathogenic gene, on a malignancy cancer gene. Then what will you do with that? So in this case, we like to see the clinical picture is matching. If the clinical phenotype is absolutely not matching, then we cannot consider that variant as a pathogenic variant. Because that classification that I showed you, there is a variant. There's a point for the clinical phenotype matching also.
For Lakshmi, can I ask a question?
Last questions.
Yeah, but my question is A and B. There is a...
Okay, sir.
No, you see, when you know about, when your phenotype is sure, for instance, Duchenne's dystrophy, then you can go even for a single gene.
Yeah.
But in whole lot of times in neurology, we are not sure. Some person with ataxia, with some dementia and all. In that situation, is it advisable to send whole exome sequence or whole genome sequence as a routine, where we are not sure?
So if Ambani comes to me and Ambani comes to me that he wants, or some of his staff, he will sponsor the whole thing. What do you want to do? I'll do a trio whole genome sequencing. Both the parents and the child trio whole genome sequencing, which is likely to pick up most of the things which next generation sequencing can pick up. At present, if you want to do more, I would say a long read whole genome, not a short read. The conventional whole, I didn't go to that. What you are doing, we are doing in a clinical setup for a lab, you see whole genome sequencing is something called as short read whole genome sequencing. There is something called as a long read whole genome sequencing. So if you want to an analogy, if you give example is you take a book and tear each letter of it, book the whole thing and try and mix together, you recreate that book. That is what next generation sequencing is. That's a short read sequencing. In whole read sequencing, you tear it by page by page and then try and sequence it together. That will be, you are likely to miss things lesser in a long read.
That's for Ambani. What about non-Ambani?
If you are not, then you start with the whole exome sequencing. So it depends upon what, for example, you are reasonably sure that this is one of the LGMDs. You have a limb girdle pattern, a CK of around 6,000. You're not sure, you don't have a calf atrophy. This typical dysferlin pattern is not there. One of the LGMDs are there. If you are short of money, you can even do a gene panel also. Because the gene muscular dystrophy, what is the advantage of gene panels over a whole exome? Gene panels have got a much better depth. That means depth means more times they sequence the same gene. So they are likely to pick up more compared to a whole exome. But problem with gene panel is gene panel only look at the genes in the panel. If there is a gene outside the panel, they are not going to look at it. Or if it is an embryonic, the slide on the borderline with one of the slice mutation, they may also miss it out.
So this whole exome sequencing, it does not include mitochondrial and trinucleotide repeat?
No.
For that, you have to do separate.
Separate. So the whole genome can include the mitochondrial, some of the mitochondrial. But if you want to really be sure for mitochondrial, you want to do. So mitochondrial is a tricky situation because not blood alone may not pick it up. Mitochondria is different. It manifests in the blood. Sometimes you want to do the tissue. You have to take the muscle biopsy, extract the DNA from the muscle and sequence the mitochondria from that might have much better. And now the current whole genome sequencing, short read sequencing, in the next future, in 5 years down the line, I think the whole genome, the triplet repeat, all the triplet repeats will be picked up by the whole genome sequencing, mostly. You may not have to do it separately.
Okay, thank you, Dr. Vish.
Thank you.
So good afternoon, one and all. So today's case presentation, it's a 54-year-old right-handed gentleman, farmer by occupation, with nil comorbidities, apparently asymptomatic till 8 years ago. And he came with complaints of asymmetrical right more than left progressive paraparesis, not associated with any myalgias, cramps, or wasting, and with reasonably preserved ambulation, and with decreased temperature and sensation on legs while bathing, with no upper limb, cranial, cerebellar, or any autonomic symptoms. So on examination, there were trophic changes in his legs and feet with right toe drop and hypotonia of the lower limbs with a predominant distal weakness, right more than left, with differential weakness, hip extensors and abductors weaker than adductors and flexors. And dorsiflexes of ankle were weaker than plantar flexors with reasonably preserved quadriceps, with no wasting or fasciculations or contractures. And deep tenon reflexes were absent in the lower limbs and plantars were not elicitable. And sensory examination revealed decreased pain and temperature sensation till mid-calves. And waddling gait was seen. So with this presentation, with only lower limb involvement with a bit of sensory involvement, initially we thought was some only lower limb predominant CIDP versus myopathy with neuropathy. Predominantly we thought of GNE. Before coming to our institute, he was already being evaluated elsewhere since the last 8 years. So this was investigations done outside. His creatinine kinase was 434 with nerve conduction study suggestive of bilateral lower limb sensory neuropathy, upper limbs completely normal. And EMG was also done suggestive of a myopathic pattern. With he was evaluated elsewhere with CSF analysis as well, which showed normal study. And MRI of bilateral lower limbs was done, which was suggestive of asymmetric distal predominant muscular atrophy in both lower limbs, right more than left. He also underwent muscle biopsy from both right gastrocnemius and also from left tibialis anterior, which was suggestive of a combined myopathic and neurogenic changes, but predominantly myopathic pattern. He also underwent nerve biopsy in view of his sensory symptoms, and it revealed chronic axonopathy, small fiber predominant. So with these background investigations, he has come to us with a waddling gait and only restricted to lower limbs, weakness, absolutely no symptoms in the upper limbs, with mild small fiber neuropathy changes. And on examination, there was predominant distal weakness than proximal weakness with neuropathy. So clinically, we thought of a GNE myopathy. And actually, he has come for further investigations and prognostication. So we have done, because all investigations were completed elsewhere, we have went for a genome sequence, like genetic analysis. But to our surprise, it was actually reported as McArdle's disease, but clinically he had no such symptoms suggestive of any metabolic muscle disease. Yes. So.
Frankly, I don't know what this case is, but I'll make some general comments. When you say neuropathy and myopathy together and you thought of GNE myopathy, I don't think such a dominant neuropathy is clinically seen in GNE. It's usually an electrophysiological diagnosis or just a subtle, so it's primarily a myopathy. So here, the sensory system was strongly affected. So
yes, sir.
In that sense, it is not like GNE. Also, the distribution is not like GNE.
Was he diabetic?
Non-diabetics.
McArdle's disease is difficult to correlate. It's such a completely different disease. Firstly, it is not so common with us.
Yes, sir.
Secondly, it comes in the first decade of life in general, though form for us can come anywhere. So, I think there is a huge mismatch, and I don't think this is adding really to. Also, clinically, what is the diagnosis is, I'm not able to gauge. Sometimes when you see the patient, you get a little more hang, but can't go beyond this.
Clinically, what had we thought?
GNE myopathy, sir, because.
Can you show the genetics report? So I had on this slide to specifically show this one. This doesn't say that the the variant is likely pathogenic. No, it only says this variant is likely pathogenic. To have an autosomal recessive disease, you need 2 mutations. This patient has only 1 mutation. This patient has one autosomal recessive. I also may have. You also may have. In fact, of all this one in 20, we are supposed to harbor 20 autosomal recessive genes, every human being. 20 likely pathogenic or pathogenic autosomal recessive, every human being is supposed to handle. So we all may have this. So that doesn't mean that patient has this disease. If this patient was clinically matching McArdle's, and his biopsy showed glycogen deposits, everything is there. This is a classical case to go for a whole genome to look at the second hit. This is something which is called as the single hit. An autosomal recessive is 1 hit you got. You need 2 hits to develop the disease. You got 1 hit. If the clinical picture is not matching, leave it. There's no point in going on this. If its clinical picture is matching, then you can go for you can reanalyze the data and see if they have. The system has, the bioinformatics pipeline has missed a second variant. Because yesterday I got an email from MedGenome that first they reported as 1 single variant of GNE. Second day, the same patient's report, they gave it as 2 variants are there. They missed the first variant. And she called up and told that first thing we missed. That's the second miss. So that is one thing. And this muscle biopsy, if it's McArdle's was there, would have picked it up.
Yes.
So,
sorry, sir. Except for the lower limbs, there was no significant involvement. VSN was negatives.
So in nerve conduction studies, many times we write to be correlated clinically. So in genetic studies also we should write same.
Another thing about the quadriceps sparing is, the quadriceps sparing, if I don't know, Kadipal sir also would have, in motor neuron disease, in evolving stage, from the lower limb, when there was a flurry of GNE, a lot of people have talked about Nalini madam's talk and all. Everybody was diagnosing GNE for some point of time in all MNDs. It was like quadriceps. Next time you see a motor neuron disease with the lower limb, just see the quadriceps is spared or not. You see a foot drop patient and the proximal weakness. Usually quadriceps is little late affected in a motor neuron disease also, not just in this one. That is one point. So when another thing which recently, if you look at the neurogenetics paper, I think neurogenetics, there's a case report published where the same similar situation, patients clinically was matching in LGMD. They looked it up and found out they got a homozygous mutation in McArdle's. But they didn't, then they did a muscle biopsy and they found some glycogen deposits. Still they were not convinced because there was no fatigability, second wind, nothing was there. There was a clinically LGMD phenotype. Then they did a whole genome or something. They found a homozygous anactinomyopathy also. The patient was dual disease. The patient had two, McAdams and the predominant manifestation was as an anoctonopathy. So double trouble may be there. That is also there.
I would like to request whoever are reporting this, we are definitely not as knowledgeable as you are. They should, they don't give any final statement. This, pardon?
Most of the time, you can't blame them also because they don't know the clinical features. Like what we know, they don't. For example, if you give them a clinical picture of, for example, when we test sending, when the mail comes from them, kindly give the clinical terms. I write the 4 HPO terms. This is the age of the patient. This is the inheritance pattern. These are the 4. Proximal weakness in lower limb, distal weakness in lower limb, foot drop, quadriceps sparing, no upper limb involvement, no facial involvement, no scapular winging, no beaver. No human involvement, no sensory involvement. So you get 4 HPO positive terms and 3 or 4 HPO negative terms. That also will help you. Negative HPO term. No sensory, no spasticity, no human signs also help them in clearing out some variants, unnecessary variants out of it. If you give them that information, they will say, even in that, then they will see it is not there. They will not report it as if it's a single variant. They have reported up to likely pathogenic. Beyond this, they will not be able to do.
See, in EMG, NMG, even non-neurologists can understand this is suggestive of muscular disease, suggestive of See, we're definitely, all of us, we don't have so much of knowledge. So at least they should give one statement. They give 2-3 pages. I don't know. I cannot understand after 20 years of experience in clinical neurology. At least one statement, maybe, may not be, that they should give. I don't know whether all of you reflect my feelings or not, but definitely a neurologist, practicing neurologist, they should give some information.
Also, I think multi-specialty meetings on difficult cases go really far. I mean, if you have a clinical geneticist on board, all of them sitting together and looking at a case, of course, it's so difficult to organize. Yeah.
True.
Your point is well taken. Yeah.
To sum it up, for example, if this patient goes to NHS and get the testing under their NHS lab, they will not report this. They will report negative. Nothing is there. There is no confusion. They say WX is negative. They will report only thing which is 100% sure. Pathogenic disease is there. Their geneticists will discuss. Everything will be done. Finally, only those cases will be reported. Nothing of these single hits, nothing will be reported. Or they will communicate directly to the treating physician that this single hit is there. Otherwise, patient gets the report negative. Nothing else will come.
There's a very beautiful paper on heterogeneity and transmission. So those of you who are interested, you write to me. I can send the paper to you. It's a beautiful exposition of what homozygous and heterozygous states and transmissions mean.
Thank you. I would now request Sri Rangalakshmi Madam to felicitate Khadilkar sir. I would request Varalakshmi Madam to felicitate Vishnu sir. Please. Madam. Yeah, I would now request Sita Madam to felicitate Varalakshmi Madam and Sri Rangalakshmi Madam. We are having a lunch break now, and please come by 2:15. We are behind by about 15-20 minutes. Sir? Yeah. Yeah. Sir?
Okay, okay. ఇది చేస్తారు కావచ్చు.
Ma'am, 1 minute.
We'll start, sir.
So, good afternoon. We'll start our post-lunch sessions. The first topic will be peripheral nerve hyperexcitability syndromes. I request Kadilkar sir to come onto the dais and give his lecture. Then this sir is already familiar, so no need for further introduction. Over to you, sir.
Thank you again. So the front lights, can we take out? Right. So the topic is hyperexcitable peripheral nerve disorders. And basically I decided to build this talk around a paper that we published last year, because that was more a personalized experience, and I'll also make comments based on literature there. Right. So what are hyperexcitable peripheral nerve disorders? These patients get muscle stiffness, muscle cramps, muscle twitches, and this activity that you clinically see is electrically also represented. Basically, in this paper, we wanted to look at them long term and see what happens to them over a period of time, because that information wasn't much there. So we brought in all patients who we clinically suspected to have this disease, and some specific features on electrophysiology were the inclusion criteria. Antibodies were sent. And we followed up patients at least for 2 years or 2 years and longer. Now, just to say the exclusion criteria, there are hyperexcitable peripheral nerve syndromes that are genetic. And there are also hyperexcitable peripheral nerve syndromes that are on the sensory side. But they are very uncommon. But it's important to know that they exist. There are genetic hyperexcitable syndromes, and there are sensory hyperexcitable nerve syndromes. So this was our treatment protocol. When a diagnosis was made, patients were put on a membrane stabilizing agent, which is often carbamazepine or a similar drug, phenytoin in some cases, and corticosteroids. Now, if they were ambulant, we gave them oral steroids. If they were not ambulant, we pulsed them with methylprednisolone and then gave oral steroid. Then at 6 weeks, we divided them into responders and non-responders. Then we put them on steroid-sparing agents. The non-responders underwent IVIG or Plex or rituximab. And the best part of this paper was follow-up, that we had a follow-up at 6 months, 12 months, 6 weeks, 12 weeks, 24 weeks, 48 weeks, 98 weeks, and in some patients later than that. So we got to see the behavior of these diseases over long term. So as we know, the youngest patient was 12 years, oldest was 76, but majority were in the third decade of life. And as usual, males are overrepresented. Overrepresented is probably the best word to use. Now, clinically, what did they get? Look at the spread of symptoms that they can come up with. At one end, you got the twitching of muscles, which is probably the primary feature that points you to the disease. But look at what else. Shock-like pains, sleep disturbances, autonomic dysfunction, weight loss, in some patients, encephalopathy, and occasional patients, cerebellar dysfunction, seizures, and neuropsychiatric disturbances. So when you say hyperexcitable, peripheral nerve syndrome, it's not only peripheral, a certain proportion of them also have central involvement, as you see in this slide. And the most common or the most important autonomic dysfunction is sweating. So a patient who has twitching and sweats excessively, these two features directly take you to the diagnosis. In fact, recently we saw a patient who is not in the study who was actually getting bouts of sweating. She was about 30, 35, and she would sweat tremendously. The sweating will go on for 3 or 4 days, and there will be piloerection, and she'll become very uncomfortable and will feel cold. Then the thing will go away. It will come back again after a few days or a couple of weeks. And this was going on for 4 or 5 months. After that, she started getting the twitching, then she started getting the muscle pains. And at that point in time, she came to me, so making a diagnosis was easier. But the point in this patient is that some people start with autonomic dysfunction and then they go on. And this is where there is that little crossover between the talk that Dr. Madhu Nagappa gave, the autonomic neuropathies or autonomic gangliopathies. We are familiar with this sort of twitching. If you see it only in the calf muscles, then sometimes you wonder whether this means the syndrome or not. But when you see in other muscles, then you're more sure. Right. Now let's spend a little time on what does the electromyography show. First is after discharges or repetitive compound muscle action potentials. Like these. So this is one feature of the syndrome. You see the after discharges between the M response and the F wave. In this particular demonstration, it's on the left tibial nerve. The second is the electromyogram showing neuromyotonic bursts in a large number of patients. They're not seen in all. Let's see here. In what way is this discharge different from myotonic dystrophy? Anyone? It doesn't wax and wane. Right. And then most of these patients have autoimmune abnormalities. Now, which are the autoimmune abnormalities? Again, you see various combinations of LGI and Caspr2. Maximum 41%, as you see, is Caspr2 plus LGI. Some are only LGI. Some are negative for both. And look at that top, there are these uncommon ones. Mercury poisoning, paraneoplastic thymoma. I think Abhinay will remember this patient. And both negative. So most of them are autoimmune. Various combinations of LGI and Caspr2. Some are toxic and some are paraneoplastic. It's available where people who have taken Siddha medicine, which contains mercury, they develop, and I think some 20 odd cases are reported from south of India, where people developed HPND after taking mercury. And the patient which is included in this series is one of those only who would travel to Mumbai. And this one patient had a thymoma, and this came as a paraneoplastic manifestation. So you got this syndrome of HPND, where there are clinical features, there are electrophysiological features, there are antibody features, and there are unusual associations like paraneoplastic or toxic. Now, most importantly, there's a lot of literature on all this that you will find, but you won't find much literature on how to treat them, how long to treat them, and what happens when you treat them. So some useful information on that I will give you. Majority respond to corticosteroids. When they're non-ambulant, MPS. When they're ambulant, oral steroids. And at the end of 6 weeks, 25 out of the 32 responded. Now, how did we know about response? Patient's symptoms becoming better and electrophysiological discharges reducing and showing some characteristics which we documented as responders. So, we continued them on ambulatory oral steroids and membrane stabilizers. Non-ambulant, IV pulse, as I mentioned. So 1.5 months is a time when you can expect that they will become much better, 2/3 of them. And then they were put on some steroid sparing agent or a second immunosuppressant, or whichever term you would like to use, which was azathioprine or mycophenolate. Here, I think the choice depended on the profile of the patient and also the treating consultant's predisposition. So special situations I mentioned were 3. One was mercury poisoning, where stoppage of the Siddha medicine and giving him penicillamine along with IV steroids. He also was LGI positive. So in some way, the toxicity also brings autoimmunity. That's another point that you see in many neurological diseases, that autoimmune situation starts after the original thing is different. It can be toxic, it can sometimes be injury, it can sometimes be infectious, like you have an HSV encephalitis, and after that you see an autoimmune encephalitis of some type. So in the toxic ones, the autoimmunity is triggered probably by the toxicity. This patient required penicillamine. And at the end of 6 weeks with this, he improved. The patient with thymoma, removal of the thymoma and intravenous immunoglobulin was the thing that was required. And he improved a little slowly. He improved at 12 weeks. And the third patient actually had Parkinsonian features along with the HPND. And the Parkinsonian features took a little longer time to improve, but they also improved. Now, 4 patients out of 32 didn't respond to steroids. Now, who were they? These were the patients who were antibody negative. Now, from one study you can't extrapolate, but if you read the literature, there are comments that mention that antibody negative HPNDs may not respond very well to immunotherapy. So in our series, also 4 patients, all 4 who did not have antibody positivity, didn't respond too well. And they required IVIG and some required rituximab. But the steroid non-responders also, towards 6 months, had responded. So in the whole of the 32 patients, which is a reasonably large number for this type of disease, real non-responders who just didn't respond to anything, there wasn't anyone. Now, in what time frame did they improve? You can see that the gray bar is improvement, and the pale yellow, or whatever that color is, that bar is completely recovered. So you can see in first 6 weeks' time only, I think 75% were better. So you need to persist with the therapy, at least up to 48 to 96 weeks. That was another lesson from this. Now, what happened? Did they recur? 4 patients recurred. So when you reduce the steroids and bring them to maintenance dose, 4 out of the 32 had it second time. But when they had it second time, you again use the same medicines and they became better. So this is an interesting group of conditions where spontaneous discharges occur from the motor nerves. They're mainly immunological. And Casper2, LG1 are the main antibodies. But you need to look for toxicity and you need to look for malignancy. Now, what this study said, which was not in the literature, is that you need to continue treatment for a long time. Within the first few weeks, they'll start getting better, but you will need to persist. And everyone will improve, and you can take them off the drugs within 1 to 3 years of starting. Now, there are lots of terms in literature about various things, the cramp fasciculation syndrome, Isaac syndrome, Morvan syndrome, and limbic encephalitis. It's actually a continuum, like so many other things. At one end, you have just the peripheral nerves symptoms of cramp fasciculation, and then you got more and more going towards the central system. So muscle twitching and muscle cramps. Morvan syndrome, you give the name when the central nervous system gets affected. They are agitated. They have memory loss. And the limbic encephalitis, there are patients on record who start as HPND and then slowly become HPND plus limbic encephalitis. There are limbic encephalitis patients who additionally have cramp fasciculation syndrome. So that again, overlapping circles that you usually see. But I must say that I did not see any patient up till now, not in this study and not otherwise also, where both the syndromes are independently present, in limbic encephalitis and in HPND, independently present, that we didn't see. So this, the take-home message, this is a rare disorder with characteristic clinical features, characteristic electrophysiological features, and usually autoimmune antibody positivity. You require a strong suspicion. Now, maybe out of interest, what were the diagnoses with which these patients were sent? Some of them were sent as motor neuron disease because the twitchings were present. Some were sent as unexplained neuropathy. 1 or 2 were sent as a neuropathy with autonomic changes, those who were sweating. So a certain degree of clinical suspicion is necessary to go towards the diagnosis. Because they are immunological diseases, patients respond to steroids, and the pattern that I showed you, starting with injectable or oral steroid, expecting response in 6 weeks' time in majority. If you don't get response, you move on to a second line, which is IVIG or plasma exchange. If that also fails by 24 weeks, then the third line is rituximab. This is again a kind of a homegrown paradigm. I don't think this is in any textbook. And then look for toxins, look for paraneoplastic situations, look for unusual situations. But they respond favorably. Therefore, it's important to diagnose them and important to treat them long enough so that they stay well. And in a rare case, make sure that there's no toxicity going on. Right. Thank you.
Gives a spectrum of hyperexcitable nerve disease. I have also seen with thyroid antibodies also same thing happening and responding to steroids plus thyroid medication. And any idea?
Yeah, the TG and TPO antibodies, one of the problems with that antibody is it is present in so many that causal relationship is a problem. But there are people in all kinds of neuroimmunological syndrome where these antibodies are positive, like the steroid-responsive encephalopathy, a type of vertigo. So yes, it in a way is a marker. Yeah.
So which antibodies specifically we should send in this?
Casper and LGI.
That's enough.
Yes. They strongly link with Casper and LGI. I think it's more a suspicion. The suspicion.
Did you get any Isaac syndrome?
I mean, Isaac is a terminology that was used earlier, and the table that I showed you how people are classified. But really, most publications now will call them HPNDs, only peripheral, and HPNDs with central. Yes. We were able to take off medications. They were monophasic except for a few, but they require medication 1 year to 3 years. And they haven't recurred. We have almost a 6 or 7 year follow-up. Yeah. In fact, follow-up, long follow-up was the real strength of this paper, because long follow-ups have not been shown anywhere.
And two of our patients, we started straight away with rituximab because of the cost constraints. I don't know whether it is rational or not.
Good afternoon, sir. This is a case of a 68 years old male patient, known hypertensive, post-PTCA, chronic pancreatitis. The history started in April 2016 with stiffness in both lower limbs, predominantly in thighs, associated with pains. The patient had difficulty in climbing stairs and walking, and there were episodes of neck drop and drooping of eyelids, and involuntary movements, twitchings, predominantly in thighs. But there was no history of any altered behavior, convulsions, dysphagia, dysarthria, paresthesias, other autonomic symptoms, weight loss, or use of any other herbal medications. Examination-wise, the patient was conscious, vital salt stable, there was no ptosis, there was wasting of bilateral quadriceps and gluteal muscles, and he had bilateral upper limbs and lower limbs proximal muscle weakness. And reflexes are all normal, and sensory is normal, except for decreased vibration in both great toes, and there was generalized myokymia, predominantly involving both thighs. And this is the videos. He has twitchings predominantly involving thighs, and he has difficulty in walking. Imbalance was there. And his RNS was did not show any decremental response. EMG done showed spontaneous activity in the form of doublets and triplets, normal MUPs, and mildly decreased recruitment, suggestive of neuromyotonia. And other anti-acetylcholine receptor antibodies were negative, and anti-VGKC antibodies negative. PET did not show any hypermetabolic lesions indicating any malignancies. Anti-GAD65 is just above the normal range, and other workup for any other malignancies was negative. And initially, he was treated because of this neck drop episode and drooping of the eyelids. He was treated with pyridostigmine, prednisolone, and methotrexate, but with which he had only minimal response. So he was started on IVIG, with which he had improvement in the limb power, and twitchings also improved. And because he was requiring multiple times IVIG, rituximab trial was given, with which he had adverse effects. So currently the patient is doing well with IVIG, initially used to require once in a year, but now almost once in 6 to 8 months he is requiring the IVIG dose, 2 grams per kg. And also on pyridostigmine, pregabalin, carbamazepine, clonazepam medications. He's doing well, but we could not stop the completely IVIG. He's requiring the IVIG. Almost since 7 years he's on maintenance IVIG. He was being treated as peripheral nerve hyperexcitability versus stiff person syndrome. GAD was just mildly elevated, but because of the twitchings and the positive spontaneous activity in the form of doublets and triplets, he was being treated as peripheral nerve hyperexcitability. How long it requires the treatment?
Did you repeat the antibodies any time?
Antibodies were not repeated, sir. Baseline, it was done.
He is a gentleman. After about 6 months, he himself comes. That time now worsening, I need the dose.
Yeah, sir pointed out earlier also.
Yeah. But he couldn't take him off totally of immunomodulation. Rituximab, when we gave, he had a chest pain and tachycardia. They told that I don't want it. Therefore, IVIG agency is supporting him. Therefore, he is comfortable with that. Yeah. Okay. Okay. Yes. Yeah. Okay. Yeah. Thank you, sir. Now I would request Vishnu sir to present another important topic, mimics and chameleons of MND.
I think this topic is now requires more attention because we are now getting a newer molecule in the treatment of ALS, S4D positive.
Before Dr. Vishnu gears up, ALS is a very, legal point of view. I had an experience when I was heading the Gandhi department. High Court referred a case where somebody has sued for 1 crore for, diagnosing ALS mimic as ALS and prognosticated. So one should be careful and be aware of these mimics and chameleons before you stamp down or declare the diagnosis to the patients, because it has got a worse outlook.
Okay, thank you, sir. So let's go into the topic. It's the mimics. The topic is mimics and chameleons of motor neuron disease. So, as we all know, a motor neuron disease is a progressive disorder. There's a degeneration of both upper motor neuron and lower motor neuron involving bulbar, limb, thoracic, and abdominal muscles, with a relative sparing of ocular and sphincter muscles. So, MND is primarily as a clinical and electrophysiological diagnosis. There is no specific investigation to diagnostic marker. There is no biomarker or something that one test to do and it comes positive and you label it as ALS. That's the problem with ALS. That's why there are a lot of mimics involved in ALS also. If there is a younger onset ALS, we call it when it's an arbitrary cutoff of age of 45 years. And mostly mortality is likely to ensue within 5 years of diagnosis. That's what mostly patients are informed. That's why they get panicked. But a lot of ways there are outliers are there which you can live more than 10 years also. So what are the signs with a high, it's not a study-wise, but people say, some authors say the high positive predictive value for MND. That means if it's there, it's more likely to be in the presence of a weakness, not without weakness. In the presence of a motor weakness, what are the signs which are likely to be? One is a fasciculations. If generalized, it's not the occasional here and there fasciculations, it's generalized. And there is a bilateral wasting of the tongue, especially the lateral borders, where there are also fasciculations. Then there's a split hand, which Dr. Nalini has explained in the morning about the split hand phenomenon, and the head drop, and the emotionality, and some cognitive and behavioral, if the FTD overlap is there. So these are some of the signs or the symptoms which have some positive predictive value for diagnosis in the presence of a progressive pure motor weakness. There are a lot of diagnostic criteria all of you know the revised LS score criteria, the Avaji criteria would put fasciculations also into the picture. Then you have the Gold Coast criteria. But all the criteria said and done. So if you have a patient with UMN and LMN in all three segments, there are hardly, and an imaging relatively normal, there are hardly any differential diagnosis. You will less likely to go wrong. So when this the 3-segment rule is not being satisfied, then we go, because these criteria are used to pick up cases early. And you want to pick up cases early and milder, then that's the time when you are likely to go into the mimics. So obviously that's the one. So what are the red flags in the clinical signs? One, symptoms begin very early in life. That means more likely to be a genetic or some other disorder likely to be. Family history of another neurodegenerative disorder. Probably the only exception is an FTD, which is not there. So this is something which you will keep hearing about ALS and FTD and the C9orf72 involved. But that C9orf72 is mostly seen in the Caucasian population. In Indian population, C9orf72 is not very common. So we looked at more than 300 or 400 ALS patients. We hardly got 2 or 3 C9orf72 repeat mutations. It's not as common as that is seen in the West. And the musculoskeletal abnormalities like Pescavers, if there is a multi-axial involvement, multi-organ involvement outside the neuraxis, involvement of multiple neurologicals like optic atrophy, seizure, cerebellar degeneration. There's a prominent early sensory or autonomic symptoms, bowel and bladder incontinence, dysphagia, which is out of proportion to dysarthria, and only one side of the tongue, hemiatrophy of the tongue is there. These are some red flags for ALS. So mimics are based on if you put the mimics based on the clinical signs, if you are putting the pure human signs, you could be an HSP or a PPMS. All the three are there. Human plus LMN are there. Then you could, most common is a multi-level spondylotic myelopathy or a spinal cyst or a dural AV malformation. Sometimes ALGRU and spinocerebellar ataxia can also present with a motor neuron disease-like presentation. LMN is the most problematic, as we saw the cases that we discussed in the morning with the pure LMN syndrome. So you got an MMNCB or a musk myasthenia with a pure bulbar, with tongue wasting and fasciculations, a Kennedy's, a pure motor CADP, an IBM or a Tay-Sachs, late onset Tay-Sachs, all can present with a late onset as a pure LMN syndrome. There are some with some amount of sensory involvement, and that sensory may not be that evident, or you are not looked upon and missed and maybe labeled as MND. That's one is syringomyelia, syringobulbia. Kennedy's can have some amount of sensory involvement. Adult polyglucose and body disease can have some amount of sensory and bladder involvement. The Forsman and the late onset Tay-Sachs disease, all these things can also have some amount of sensory involvement. So technically they are not mimics if you have found the sensory involvement, but if your sensory is missed, they can still be mimic. Based on etiology, a lot of genetic syndromes, Kennedy's, Tay-Sachs, ALGRUVs, polyglucose and HSP, adrenomyeloneuropathy, SMA, late onset SMA, all these things can cause like mimics. So this, we'll come to each one later. So first thing is a case of a 32-year-old male physician. He has a history of anxiety disorder, complaints of muscle twitching in the left calf since 2 weeks. 2 weeks later, he complains of difficulty in chewing and swallowing, the spreading of muscles of twitching to right calf, chest, abdomen, face. And on examination, fasciculations noted on left gastrocnemius. She undergone multiple testing of NCS, EMG, endoscopy, all are normal. This is a classical case of benign fasciculation syndrome. So I have a patient of benign fasciculation syndrome who has visited every institute in the country, including NIMANS, PGI, AIMS. Everywhere he has gone up to Chitra, everywhere he has gone. So he's basically scared of a motor neuron disease. So typically under 40 years of age, rarely, usually fasciculations are not the first thing that patients complain in motor neuron disease. It is usually picked up late, or the physician asks for it, and then it comes to it. The site of fasciculations are not discriminatory. It's in 70% of the population. When you exacerbated by strenuous exercise, fatigue, increased age, alcohol, even a thyrotoxicosis. But usually there is no weakness or wasting. So when there is a fasciculations without any weakness or wasting, it should be taken with a pinch of salt. So there are a lot of studies based on that. There's a systematic review based on the 20 articles, around 384 patients, predominantly male. There is an overrepresentation of doctors in that who have benign fasciculations. Paresthesias, cramps, fatigue, these are the common symptoms. The most common psychiatric disorder is anxiety. The patient concern for MND are there for 14 to 100%. So next is the common condition is the MMNCB, which is something the multifocal motor neuropathy with or without conduction block. The prevalence, first thing is it is much more rarer than motor neuron disease, almost 10 times lower. And there's asymmetric distal weakness, usually starts with the yeah, I can do it. I didn't have a pen drive, that's why I don't have a pen drive. Okay. So younger onset of symptoms is usually 40 years versus MND. Now even we are seeing MND in younger age group in our population also. There's very little wasting initially. The reflexes are usually lost, but it's important to remember that 20% of MM and CB can have retained or even up to brisk reflexes also. The absence of bulbar involvement, demyelination on electrophysiology will solve the problem. And as we discussed in the morning, if you have alternative modalities like ultrasound or MRI and show that the nerves are involved, it will be easy to diagnose. So there is an absence of what are the pointers towards absence of bulbar involvement. The respiratory involvement is rare. Conduction block is usually diagnostic. You have an antibody also. Sometimes you see MRI T2 hyperintensity in the plexus also. So most of the differences, only thing is there's no response to steroids. There is response only to the IVIG, which we discussed already. So this is one controversial table. This is a table which has been taken from the chapter in practical neurology on mimics of MND. So the author says, this is the author's personal opinion, features that may support a trial of IVIG in a case of progressive motor neuropathy, or you want to give. So significant abnormalities in nerve conduction, okay, that's acceptable thing to give. Monomelic, slowly progressive element syndromes, especially distal. So that's a little controversial thing, whether you want to give a trial of IVIG on every patient. I mean, if that's antibody positivity, significantly raised CSF protein. So what is the significance of CSF protein? If you do a CSF examination in a motor neuron disease and find a protein of 50, you start giving IVIG in every pure motor syndrome. That's also a controversial thing. And evidence of an underlying malignancy without resectable tumor, that's still apparent. If you're thinking of a paraneoplastic motor neuron disorders, it's still acceptable. Now, next condition is a neuralgic amyotrophy, which everyone knows is like usually presents with pain. That's a main giveaway for this one in the proximal upper limb, typically unilateral. Initially starts with the pain, the weakness, amyotrophy, and the recovery phase. The main important point is it's not progressive. That's the good thing about that. And you'll have a sensory complaints also. There's a recovery phase, and usually patients recover. Sometimes you have a residual damage also. There is some condition called as hereditary neural amyotrophy also with the mutation of the SEP9 gene. So the differences is almost self-explanatory. I will not go into that. This is a case which I showed in the morning of a Kennedy's disease, which with severe gynecomastia. So this gynecomastia may not be apparent unless you palpate for the breast tissue under the nipples. So sometimes some cases are very apparent, but some cases are not. So this tongue atrophy. So Kennedy's is an X-linked disease. The CAG repeats in the androgen receptor gene with a gain of function mutation. So around 2%, in most of the disease, 2% of cases which are diagnosed as ALS are having Kennedy's disease. And every ALS expert will have a story of where somebody was diagnosed as ALS and 15 years, 20 years later, he's still walking around. And it later turned out to be a Kennedy's disease case. So this is that's a classical history that you will get in Kennedy's, that you are told that you will die in 3 months and 15 years later you're still walking around doing this one. So these are the Kennedy's can have an extramuscular manifestations like involvement of corticospinal tract, muscular atrophy, Brugada syndrome, gynecomastia, elevated cholesterol and triglycerides, impaired glucose tolerance. A lot of things are there. The good thing about Kennedy's is important to diagnose Kennedy's is there is an ongoing trial on Kennedy's. So next year, January, the trial is going to complete. So something we will look at it. So we have some around 5 or 6 cases of Kennedy's disease cases. Most of them are classically what is described in the clinical picture. So the most important, other than the gynecomastia, is the facial fasciculations that you see. So that usually don't. You get tongue fasciculation, but chin, tongue, jaw, that region fasciculations are usually more common in Kennedy's, and sometimes you get a sensory neuropathy also. So, and most of them have some amount of very pre-diabetic stage or diabetes which is well controlled in diabetes, and some hormonal abnormalities, LHFSH is also usually seen. Sorry. Then this is a motor predominant CIDP or the motor CIDP, an entity which I think is a controversial entity. My personal opinion is such an entity doesn't exist. It is something similar to MMN or something like that. It's a relapsing remitting course, maybe there. Symmetrical involvement, no wasting, demyelination, poor response to steroids, and it's only IVIG. It may be something similar to what of the seeing multifocal motor neuropathy. So this is the typical motor CIDP. There are the two variants at the end of the spectrum. That's the motor and sensory CIDP. The motor CIDP is the one which we're talking about, which is usually less than 10% of most of the common, of all the CIDPs. This one is a patient which presents with mainly proximal weakness, mainly quadriceps weakness, and the finger flexion weakness. So if you look at it, this is during the COVID time, so he can't extend the quadriceps. So he has to forcefully hold it, and in the upper limb also there is a significant finger flexor weakness. He can't make a good fist. So yeah, the muscle MR is showing the quadriceps involvement. So it's a slowly progressive muscle disease. Some people used to call it as an Alzheimer's of the muscle, where there's an inflammation and the degeneration both happening simultaneously, ultimately degeneration taking over. The preferential pattern of muscle involvement is finger flexors, quadriceps, and ankle dorsiflexors. Invariably, all these patients will receive IVIG, probably a cyclophosphamide or a rituximab also, but nothing works. So in most of the Western centers, they don't give anything for IBM. Most of the centers, I mean, even IVIG is also not given. Their prognosis is explained at this point of time. Recently, a trial was also done which was negative, which have an asymmetrical presentation. Dysphagia can be present in 1/3 of patients. Dysarthria is more common than dysphagia in MND, but here you have a dysphagia more common. CPK is elevated. You can have some amount of exaggerated reflexes in some cases. So EMG can appear neurogenic in 10 to 14. That's the one which adds to the confusion of whether it is a motor neuron disease or not. And muscle biopsies usually shows the rim vacuoles inflammation and TDP43 cells. Hirayama, I don't have to say anything much, but we extensively heard about Hirayama in the morning. So we get all those things. But Nalini madam will, whenever I see Nalini madam, first thing she says is don't tell about trial, RCT about Hirayama, which because she told an 84% improvement. I told her everybody is sending to NIMANS. Why? Why can't they do surgery? From UCL, patients send to NIMANS to surgery. Why can't UCL do the surgery by themselves? Because there is no evidence. There is no high quality evidence. Otherwise, their neurosurgeon would have done the surgery. They don't want to do it because there is no good quality randomized controlled trial evidence. 84% improvement. How much patients you need to do a trial? If you calculate the sample size, you may not even need 20 patients to do the trial. You do it on 30 patients, randomize and do it, you can get the result in 1 year. You can publish it in any JAM. So if you get this one. So it's not that difficult to do a trial in a Hirayama disease. Nobody is doing anything. There's no ethics issues. Nothing is there. You can easily could have done a trial and proved it. Then everyone would have done the surgery if it is proved in the surgery. So they may be working out, but at present the evidence is only for observational studies. Otherwise, you don't have a high quality evidence to say that surgery improves. So I'm not saying anything about the Hirayama. We are also around 140 patients. We just submitted it for review. So and I strongly believe, I mean, it's everybody they says that it is the dura involvement. Everything is dura is involved. Why dura is involved only in that particular age group patients, young patients, males predominantly. There could be some genetic component to it. You never know. It could be a pentanucleotide sitting in an intronic, which will discover 10 years down the line, which has not been discovered anything right now. I strongly believe that it has got a genetic component. Otherwise, this much amount of predisposition seen everywhere without geographical predisposition, it's seen everywhere. There has to be some genetic component to it. We have 2 families. Suddenly, we are doing a trio whole genome sequencing for the 2 families. 2 brothers, 2 have the similar phenotype. Let's see what comes out of it. Then you have the HSP, which is once used to be, and even now it is a wastebasket diagnosis of, if any combination of neurological neuroaxis you combine and give, you can get one of the HSP variants. So there are a lot of HSP variants which can produce in motor neuron disease. And if you look at the genetics profile, there is the clear overlap between distal hereditary motor neuropathy, HSP, mitochondrial, ALS. All these things, genes have a lot of overlap. So sometimes semantics, you label somebody as one thing, it later turns out to be, you call it as a CMT2 plus or a complicated CMT2 or a complicated HSP or a mitochondrial plus syndromes. So the semantics matters, but for naming purpose, but ultimately you need to know the gene involved. Musk myasthenia gravis, it's a very rewarding if you diagnose a MuSK myasthenia gravis in a MND patient, and finally turns out to be MuSK. Nothing like that. You're somebody who's been given a death sentence of ALS and turns out to be MuSK myasthenia, but you tongue atrophy and fasciculations, prominent bulbar weakness, prolonged disease course, minor fluctuations, but there will not be much upper motor neuron involvement. So any bulbar, pure motor, bulbar, recent onset, however improbable it is, you should look for myasthenia. Algrove syndrome, I have a very funny memory about Algrove syndrome because the first Algrove I diagnosed, I was sitting in PJ old side. The patient came with a discharge summary from PJ itself 15 years back, labeled as ALS, and came walking to that OPD and this one. So this cannot be ALS, 15 years of ALS. So he had a Heller's myotomy for the achalasia done, surgery also done in from PGI. They're also there, but nobody combined both together and see. And Algrove syndrome is combined of achalasia, alacremia, adrenal insufficiency, and autonomic disturbance. And usually it's present in very young age. It is very severe disease with adrenal insufficiency, adrenocortical insufficiency. Some around 10% can present with late onset. It can mimic like a motor neuron disease manifestation, but you will have other features. Sandoff disease also a lipid storage, autosomal lipid storage disease. Hexosaminase B gene can have late onset presentation. 50% can have cerebellar. So one thing is that either it is a late onset Tay-Sachs or Sandoff. So you have an MND with a significant cerebellar atrophy, seeing without much cerebellar attacks. So one thing one diagnosis, one is scar, obviously. If it doesn't have much cerebellar, one clue to is a prominent cerebellar atrophy. Then it's predominantly, as I told before, it's a predominantly LMN feature. Then it's adult polyglucosan disease. Adult polyglucosan disease, usually the clue used to be there, an MND-like presentation with sensory and a bladder involvement. When you have a bladder and sensory involvement, you think of polyglucosan body disease because it is a late onset also. It develops in the 5th or 6th decade. You can develop progressive spastic paraparesis, sensory motor polyneuropathy, and neurogenic bladder. So they have MRI changes, sensory shows axonal sensory motor polyneuropathy. Nerve biopsy will show the PAS positive polyglucosan bodies. Madras motor neuron disease is also an entity which is enigmatic entity. What is the genetic background? Nobody knows. Dr. Nalini's group and Dr. Gauridev has previously worked a lot on it. They tried to find out the genetic cause. They couldn't find out. They thought it is BBV alone, or they looked at the BBVL genes also. They didn't find it. Interestingly, I was in Pondicherry for 3 years and as a faculty, as a resident for 4 years. I have never seen a Madras motor neuron disease one in case. So I don't know whether it is actually a genetic disorder or not. It could be, but something. If it is a genetic disorder, because they have tried everything. They have tried a whole genome. Whatever possible in Madras motor neuron disease genetics till now, I think Dr. Nalini's group have tried. It could be if it is a genetic, it could be a repeat disorder, most likely, which has not been picked up till now. Then hyperparathyroidism, it will not cause a motor neuron disease. It produces signs and symptoms mimicking a motor neuron disease. Like it can have some amount of proximal weakness, reflexes can get brisk, some amount of bulbar symptoms also can occur. So this is something which whenever you work up for MND, thyrotoxicosis, calcium, the T thyroid function test and parathyroid functioning is part of our usual motor neuron disease workup. Eglon-5, something new has happened. And Eglon-5 again goes to the same lab and comes. A lot of things are coming positive for Eglon-5 also. That also, how much of them are clinically positive, we have to think about it. But this can also some presentations of some thinning and fasciculation, some muscles can present with. But most common manifestation of Eglon is chorea and other movement disorders are the usual other than the sleep, the manifestations that occur. Again, scar, it's a well-known entity, SCAR3, and other scars can have a MND, like amyotrophic presentations is well described in scar. And I'm not discussing these things. These are also proper. You can have PPMS, syringomyelia, adrenomyeloneuropathy, because the neck drop of OPMDs, isolated neck sensor myopathy, post-polio. And the most abused thing is Lyme disease. Every time you check for Lyme, because I don't think Lyme will, the amount of investigation that we do for Lyme for MND is overestimated, this one, and paraneoplastic, obviously. In fact, last 2 weeks back, the nuclear medicine HOD wrote to the neurology HOD and saying that a lot of unnecessary PET have been asked for motor neuron disease from your department. None of them are coming positive. So there's no need for doing this much PET scan for every motor neuron disease. But when you have a young, rapidly progressive, sometimes you can't blame the physician from writing a PET scan. Now coming to the chameleon. Chameleons is an atypical presentation of motor neuron disease. We thought the monomelic involvement, the isolated bulbar involvement, the head drop, the respiratory onset or the acute presentations, FTD-like presentation from the starting, then later on developing. Young onset MNDs, a lot of genes coming up. I think the genetics of MND is coming up more from the susceptibility genes to the monogenic genes. A lot of things are coming into it. The apparent sensory, mild sensory symptoms without any electrophysiology background, sensory symptoms may, as presentation can occur in MND. Parkinsonian features, Mills hemiplegic variant. All these things are atypical presentations evolving later on into a motor neuron disease. I think my final take-home message will be the true, as Sarah has told, the true mimics tend to be slowly progressive disorders, and 10% of MNDs turns out ultimately turn to have another condition. And misdiagnosing ALS is a devastating thing. So I think my first thing is I don't diagnose ALS on the first visit. I never conclusively say it is ALS on the first visit. I give it a time for some time. Misdiagnosis leads because first thing is breaking the news. That's itself a separate talk. How do you break the news of ALS to the patient? And it's just easy to say the first thing that this is ALS. So, and nothing will happen and you die, or something will likely to happen in 3 years or something like that. So first work up the patient, you give it a time for the patient to also digest it. And sometimes all the best of possible thing, if you don't have a 3 segments involvement in UM and LMN, for me, whatever be the criteria, probable, possible, it is always a probable or possible ALS. It's never definite ALS. It is a definite ALS when you have the 3 segments involved. That's my personal take on it. Thank you.
Extensive coverage of the mimics and chameleons. Just one point. Is that antibody test for IBM is also there, no? You're not mentioned.
I don't think it is a NCTN1 that antibody is there. It is not done here. I don't think it is done in India. I have not been checked it. No. But IBM, it can be reasonably diagnosed with a muscle biopsy and clinical features. It's not that difficult to diagnose IBM. The problem is IBM patients will keep getting IVIGs. It's very difficult to convince a patient when you say that inflammation is there in the body. In the clinician also outside. It's tempting to give immunosuppressant. Say that there is an inflammation there. Biopsy will show some amount of degeneration. That's beyond a point. I asked one of the biggest IBM experts in US, what do you give? I mean, is there a pressure on this? They give just nothing, just diagnosis. They don't give any other even not even trial of immunosuppressant and think the definite diagnosis.
That it mimics Alzheimer's disease.
Yeah,
that was the older statement. Nowadays, with the antibodies positivity, that has changed.
So even Alzheimer's is supposed to be now immune-mediated. Is all the monoclonal antibodies happening in this one? Some amount of inflammation is there in the Alzheimer's also. So what telling the statement it is an Alzheimer's of the muscle disease is it gives them the time to process that nothing is going to happen immediately. It is not a severe disease that tomorrow something is going to happen. It's a slowly progressive disorder. Some amount of time. It is only a muscle involved. So that gives them some process. Other than that, it's just an example. Other than beyond that, it doesn't have much connotation.
Any comments? Anything?
Thank you.
Okay. Thank you.
Good afternoon, everyone. So this is a case of a 16-year-old boy, a right-handed born out of non-consanguineous marriage. He had, at the age of 8 years, bilateral moderate sensory neural hearing loss, for which he was not evaluated but has been using hearing aids since then. So he has come to the OPD 8 years later with difficulty in swallowing both solids and liquids, nasal regurgitation, hoarseness of voice, slurring of speech, and difficulty in closing eyes completely since 2.5 months. On examination, he had bilateral element facial paresis and also tongue atrophy with fasciculations and also slurring of speech with So he had bilateral element facial palsy, Bell's phenomenon, and also he had dysarthria and hoarseness of voice. So we investigated him. Clinically, he had bilateral lower cannular paresis, and on examination, he also had wasting of FDI and hypothenar muscles with hand grip weakness. He also had thinning of legs with distal lower limb weakness. Deep tendon reflexes were normal, and plantars were also elicitable with no other sensory involvement, any other gait abnormalities. So we did investigations, and CT brain was normal, and the pure tone audiometry revealed bilateral right side moderate sensorineural hearing loss and left side mild sensorineural hearing loss, with nerve conduction studies revealing bilateral peroneal axonopathy and EMG suggestive of a neurogenic process, bilateral C8, T1 and L2, L5 segments, with acute innervation and chronic reinnervation changes. So because he had bilateral lower motor LMN lower cannular palsies with LMN both upper limb and lower limb involvement, with predominant history of sensory neural hearing loss to begin with. So clinically, we thought to have VVL syndrome, and genetic analysis was done, and it was proven to be BVVL. So we have started him on high dose riboflavin, that is 200 mg twice daily, and later, 1 month later, telephonic follow-up, he has a significant improvement in dysphagia, but hoarseness of voice was still persistent. So our topic, discussion is whether he could have been started earlier, because 8 years hiatus was there between development of sensorineural hearing loss and the other low motor cranial symptoms. So could he have been started earlier on riboflavin? And the next thing is that apart from riboflavin, do we have any other treatment options to be given to the patient?
Can you go back to the genetics? Yeah. So I mean, this is the classical case I told last time. The phenotype is absolutely matching.
Yes.
Okay. But still, you got only one hit. So it is not solved. I mean, it's a very promising variant you got. It's most likely it is BVVL. You are likely to get a second hit if you work it up more. It's an ideal case to do a whole genome. You get a second hit and find out. So having said that, you cannot say that it is solved genetically. It's very promising. You got a very promising single hit. So about the treatment side, I mean, I have experienced only 2 cases. I have only 2 BVL under my follow-up. Both are under high dose of riboflavin. The thing was, one patient's tongue was absolutely frozen. It will not move at all. With riboflavin, now she can move the tongue at least outside the mouth. That's the only improvement that has come. She has no other weakness of that sort. She has severe sensorineural hearing loss. So there is no improvement in the hearing loss part. But the tongue movements and the bulbar movements has some improvement with BVVL. BVVL in the treatment is, what is the treatment purpose of giving such high dose of riboflavin? There's a transporter deficiency there. You are trying to bulldoze the riboflavin inside with a high dose. That gradient has been to bulldoze the gradient across it, right? So there is a maximum tolerated dose of 400 milligram is a good dose. Normally, our RDA is 1 milligram. So we are giving 400 times the riboflavin that is required for it. It's a good enough dose. Whether it can be given earlier, problem is we don't think about transport deficiency when a hearing loss comes in the child. I think END people are more likely to be sensitized that such a thing exists because they are likely to come into more. Sir, I'll have more experience, I think so.
Yeah, I think it's quite an intriguing condition. And as far as recovery is concerned, the motor recovery can be unexpectedly good. Like from somebody who has a Riles tube in and not even able to vocalize anything. From that point, they can go on to speak and tube can be out. So it can be quite rewarding. Most of the literature says that the hearing doesn't improve that well. Now, whether they could have been started much earlier is speculative, but that's one area that remains. The other thing is that there are 2 genes in BVVL. One is this A3 and another is A2.
Yes.
and one of the two, I forget which one, can have a sensory motor syndrome. So BVVL is not necessarily a motor syndrome. In fact, we published one case in muscle and nerve where there was a B12-like signal in addition to everything of BVVL and a confirmation. And the signal went away after riboflavin. And sensory neuronopathies have been described, sensory neuropathies. So we imagine this to be a real mimic of ALS at younger age. But they can be sensory. What dose of riboflavin were you giving?
So 200 milligrams twice daily, sir.
And where did you get it from? Just for everyone to know, because the
Yes.
preparation in the market is 10 milligrams.
This boy is a resident of Visakhapatnam, sir. It seems it is available as 200 milligrams tablet. So he's taking it twice daily, it seems.
Amazon has 100 milligram riboflavin. And a lot of these over-the-counter medicines in America have 100 milligram.
I was just wondering whether this disease can be picked up at the stage of hearing loss. We can advise ENT surgeons. What is the atypicality between, I mean, this is something which can be manageable and things go unnoticed.
Now I request Satish sir to, the change in the talk, the sir wanted to share the experience of different case studies in neuropathies.
Right, so I thought I'll show you some interesting neuropathy cases. This patient is seen jointly between me and my colleague, Dr. Lal Kaka. It is originally Dr. Lal Kaka's patient, and when he was on leave, he asked me to see, and then went back to him and came back to me. So, yeah. So 33-year-old male. He started with tingling numbness of soles and palms 15 days before he presented. He had fatigue and calf pains 4 days before he presented, and he was unable to climb stairs. He had loose motions for 1 day, 15 days prior to the onset of these symptoms. He was a chronic smoker and had mixed diet. So what's your diagnosis? Loose motions, 15 days go by. Then tingling numbness, fatigue and calf pains, and motor weakness. GB syndrome. That was our working diagnosis. So vital parameters normal, chest expansion normal, mild weakness of the hand grip, and mild weakness of the hip girdle. A little decrease in touch and pinprick over soles and dorsum of feet. Decreased pinprick at tips of fingers. Okay with GBS? Somebody says no. What's not okay? No, some ascend, some descend, some come everywhere. So GBS, each one is. I mean, if at all, I thought at that stage, and I still think that this is within the umbrella of GBS. But if at all, sensory symptoms are most common in GBS. Sensory findings are not that common. But they're not against the diagnosis. So this is more to impress your examiner than to do anything. So, and periodic paralysis, what's the real difference between periodic paralysis and GB syndrome? Periodic paralysis comes back in 1 day. You know, one very famous doctor, Dr. O.P. Kapoor, some of you might know. He was a celebrated general physician. He once sent a Pathan to me. He said he was admitted in Karachi with GB syndrome. Next day he was discharged and he's come to Mumbai. Can GBS improve in one day? He knew exactly what was happening. And the patient had periodic paralysis. He had multiple events before and all that. Right, so come back to the case. This was his electrophysiology. Low amplitude slabs, delayed distal motor latencies, absent F and H. So proximal delay, distal delay. Temporal dispersion with multiphasic CMAPs. Comfortable with the demyelinating neuropathy. So clinically GBS, demyelinating neuropathy. CSF 146 cells, IgG elevated, SPP normal. GBS? Right. The routine workup normal. So we gave him IVIG. And he improved brilliantly. So Dr. Lalkaka came back, patient went home, everything okay. He came back a week later, again when Lalkaka was on leave, and this time left lateral rectus palsy, right proptosis, tremendous sensory ataxia. He was brought by people, facial palsy and proximal weakness. Now obviously out of the GBS range. What is out of the GBS range? The cranial nerve palsy. That's very, very uncommon. And the proptosis. So again we investigated him. MRI orbits, contrast, everything okay. There was a lymph node, which in the first slide I showed, there was a lymph node. The FNAC of the lymph node was done, which is inconclusive. MR didn't show anything. What next do you want? No, I don't think. Lyme disease.
In one such case, I did CSF, sir. It showed atypical lymphocytes, suggestive of some kind of a lymphoma.
Right, very good. Yeah. So, when a FNAC is inconclusive, you take out the whole node. Every surgeon will tell you that. And this is what his node showed. Did Vishnu forget this? Oh, okay. Yeah. So these are the Reed-Sternberg cells. So actually he came like an AIDP, but he actually had a paraneoplastic AIDP. It's important to look for secondary causes of AIDP. Very important question. I mean, then obviously his care got transferred to the lymphoma doctor. He did reasonably well with the first 2 cycles. And he was following up with me as well. But in 4 months' time, the whole thing relapsed again. And the lymphoma. His long-term wasn't good, but he responded to first two cycles, yeah. Right. Second case. A 45-year-old female, hypertensive, non-diabetic. 3 months prior to admission. This is also an old case when I was at the medical college. But I think it's very illustrative, so I brought it. 3 months prior to admission to the medical college, she had headaches, left eye ptosis and double vision, numbness over left side of face, deviation of angle of mouth, and a little bit of vertiginous phenomena. There was no fever, there was no weight loss. BP 170/100, no neck stiffness, no liver spleen, higher functions normal. Optic nerves normal, left pupil mid dilated, left third nerve palsy, partial sixth nerve palsy. Left-sided facial sensations impaired, and left corneal reflex lost. So what she basically had were multiple cranial neuropathies. The lower ones were normal. And she had no long track signs. Motor sensory reflex is normal. I think we'll skip this, we all know. So what was the clinical syndrome? Headache with multiple cranial nerve palsies on the left side without any long track signs. So what are the possibilities? Firstly, we always discussed intraaxial versus extraaxial. So more likely extraaxial because there were no long track signs. Having said that, once in an MD class at the medical college, I taught on 6 or 7 cranial nerve palsies without long track signs. It turned out to be a brainstem glioma in the end. So you never know. But without long track signs, extraaxial is more likely. So the problem may be at meninges, it may be at subarachnoid space, it may be a bony problem or soft tissue around. So we thought of skull-based pathology, meningeal pathology of various types, and inflammatory pathology of various types like polyneuritis cranialis, whatever that means, sarcoidosis, vasculitis, so on and so forth. So next, what will you do? Which test do you want? Imaging. Before imaging, we must do these things. No? ESR particularly, 05. HIV, VDRL, negative, not diabetic. So we did the MR. What does it show? Look at the left third now. Unbelievably large, no? I must say I've never seen a third nerve as big as this and as enhancing as this. Look at the fifth nerve. Now please hold this image in your mind. I'm going to come back to this fifth nerve image at the end of the presentation. So what do I want you to hold in your mind? You know, look at the shape. Look at the size. Right. 7th and 8th were also slightly larger, but nothing very much. So what did the MR show? Cisternal segments, so the left third, 6th, and the right 7th and 8th were thickened. There was homogeneous enhancement. There was no meningeal enhancement. And there was nothing in the parenchyma. So what thoughts go through your mind? Sarcoidosis, yes. Infiltrations, yes. IgG4 disease, yes. Sorry? Sjogren syndrome. So immunological infiltrative. I think one big point up till now is that meninges are not involved. It's a disease that has affected the cranial nerves and they've made them hypertrophic. So what would you like next? CSF. Cells 52, sugar 83. Simultaneous blood sugar not done. Reason, the MD person doing the CSF. You know, at the medical college we had people who rotated while they were doing the MD. So it happened. Protein 62, atypical Meininger cells negative on 2 occasions. Gram negative, AFB normal, fungal and AFB culture negative. So what does the CSF indicate? Could it be a chronic infective meningitis? Could it be an infiltrative disease? Could it just be non-specific inflammatory? It could be any, frankly, it could be any of the 3. So you want more tests. So Anuja said sarcoid ACE levels came 8. Calcium was 9.1, ANA blot was normal, repeat ESR was 10 millimeter. CT skull base was normal, CT neck, chest, abdomen, pelvis was normal. We didn't have a PET scan then at the medical college, so this is what we did as an alternative to PET CT. We didn't show anything. Now, what would you do next if this is your patient? There are cells and proteins in the meninges. Nerves are enhancing. Patient has multiple cranial nerve palsies. Start steroid empirically. Take a meningeal biopsy. Take a cranial nerve biopsy. Steroid. Now we started getting dysphagia. So something, we were investigating all these days. She was getting worse. So the relative said, when are you going to do something? Yes, yes. So she started getting tinnitus, she started getting everything. So we started on methylprednisolone and we gave her anti-TB drugs. Because frankly, you can never be too confident about using steroids alone in this situation. So we said, okay, we'll cover her with anti-TB drugs. She improved. After we started steroids, she improved. And then we had a discussion with the relatives that this may be an immunological disease and should we give cyclophosphamide? But the diagnosis is not confirmed. She said, look, I'm improving, I'll go home and I'll come back if there is any trouble. So we put her on anti-TB and steroid, but we left. We said diagnosis open. The discharge card didn't give a diagnosis. She got readmitted. More dysphagia. Now right-sided third nerve. Decreased sensation on the right side of the face. Significant deafness. Severe right arm pain. And now you see the other fifth nerve has become similar. Again, note this shape. This has improved, but this has become like that. Both sides, this image shows. You know, radiologists like animals. So the radiologist said this is hippopotamus in the brainstem. Brucella was negative. It's not on the slide, but it's negative. And Lyme was considered, but the test wasn't available at that time. So right third is also now involved. So what are you seeing in these images? Outstandingly hypertrophic cranial neuropathies. And the right cervical root is also thickening. Repeated the pulse methylprednisolone. Now this is where the case slightly went out of our hands because we had to transfer her to the neurosurgeons. And the neurosurgeon decided to take a cranial nerve biopsy. I must say we've never taken a cranial nerve biopsy. He said, look, the fifth nerve is completely gone. What more damage will I do? So he went ahead and took it. I must say that looking back, we should have gone for this, the C8T1 root, if at all we were going to take a biopsy. But this is what happened. I'm showing you what happened. Right, so he chose the left fifth nerve. This was the CT scan just before they took. And this is the histopathology. CD20 positive, BCL2 positive, CD10 negative, diffuse large B-cell lymphoma. Now today, if I look back, today's flow cytometry would have picked it up on the CSF. We did abnormal cells twice with cytocentrifuge and didn't pick up. But today, I think, subsequently, two more cases like this have come to me in Bombay Hospital, and both have been diagnosed on flow cytometry. Not only diagnosed, even typified on flow cytometry. So that's improved, but we didn't have it at that time. So what are the lessons here? When you see hypertrophic cranial neuropathies, hypertrophic, real big, like you saw here, you can see it in infiltrations, inflammations, and immune diseases. But they are so much more in infiltrations. Now, infiltrations go to which nerves? Infiltrations go to the large nerves. The fifth nerve, the seventh nerve are one of the largest nerves, and it goes there. So nerve hypertrophy without meningitis as you saw on the MRI, CSF did show meningeal, strongly favors neoplasm. So large nerves, not much in the meninges, is likely to be neoplastic. Now here, that particular plate I couldn't find. This fifth nerve had a diffusion restriction. The nerve was large enough for them to do the diffusion, and there was a diffusion restriction. So when you see a diffusion restriction in a nerve, it is almost certainly a lymphoma. Now let's go back to that image that I told you to keep in mind. Here. Now see where the nerve comes out of the cisternal segment, it stops being hypertrophic. So the lessons from this case are, hypertrophy without meningitis is very suggestive of infiltration. Within infiltration, if you see diffusion restriction, it is a lymphoma. And thirdly, when only the cisternal segment of the nerve is enlarged, it will be an infiltration. If you see a sarcoid nerve, as the nerve goes, it will still be hypertrophic. If you look at a CIDP nerve, the whole nerve will be hypertrophic. If you see an HMSN nerve, the whole nerve as it comes out will be hypertrophic. But here it is only the cisternal segment. So I think this case, a lot of learning points, so I thought I'll put it up. There's just 1 minute left, so probably no point in showing another case, but I'll show you only one image. Hypertrophy of hyperkeratosis of palms and soles in a patient with arsenic poisoning. Right, so I think 1 minute left, I'll stop there. Thank you.
In the first case where there was malignancy was proved, CSF cells were atypical in the first report.
In the first one, there were no atypical cells, but in the cytospin. Again, I believe that today's flow cytometry will pick it up.
Nice cases.
Thank you.
Thank you, sir. I would now request Councillor to give the momentous to the chairperson, sir. I would now request Sita Madam to chair the last session. Please, Anuja Madam and Jayashree Madam, please. Please come over. Please. Yeah. The last part, we have two cases. Anantram sir is not there. In place of that, Harikishore sir will be presenting. Sir, sir is here only. Please, sir. Sir. చూస్తాను ఇక్కడ విజయని పిలుస్తాను 2 minutes నెక్స్ట్ చేస్తారా లాస్ట్ 2 minutes we'll do it the next. And now request Vijay to present on reversible myopathy. Yeah. Yeah. Is there? Yeah, I will just check it.
Good afternoon, respected teachers and dear colleagues. Today I'll be covering on important reversible myopathies. My outline would be some drug-induced myopathies, mainly statin and steroids. Endocrine myopathies, most commonly the hypo and hyperthyroidism, parathyroidism. Few metabolic myopathies and some few slides on asymptomatic hypercemia. So, coming to the statin-related myopathy, statin myopathy is defined as inability to tolerate at least 2 statins, one at the lowest starting daily dose and another starting at the any dose due to objectionable symptoms or abnormal lab values which are temporarily related to the statin treatment and will be reversible on stopping of statins. There will be different stages or grades of statin myopathy. The most commonly seen with in the general population is asymptomatic CK elevation or asymptomatic hypercemia. Most commonly seen with statins, usually with less than 4 times elevation of serum CK. And the second stages, like stage 1 and 2, includes myalgias, the muscle symptoms in the form of myalgias, where CK would be less than 4 times elevated. And coming to the myopathy, where CK will be between 4 to 10 times elevated with prominent muscle symptoms and weakness. And in the stage 4, there will be severe myopathy, where the CK would be up between 10 times to 50 times elevation with prominent muscle symptoms in the form of severe muscle weakness. And the next stage is rhabdomyolysis, where CK can be elevated more than 50 times. It can precipitate AKI also. And the very rarest form is immune-mediated necrotizing myopathy, which positive antibodies to anti-HMG-CoA reductase. They present with non-specific symptoms in the form of pains, heaviness, stiffness, predominant in the lower limbs proximally, and 40% of these patients, they have a potential trigger in the form of addition of another drug or a physical activity. Most commonly, it will present within 1 month after the start of statin, and previous 80% of these people, they don't have any symptoms prior to the initiation of statin. And certain clinical risk factors are there for statin-related myopathy. This include elderly people with more than 80 years, female sex, low body mass index, and Asian, African ethnicity, and other comorbidities like alcohol, CKD, liver disease, hypertension, diabetes, hypothyroidism, and vitamin D deficiency. And drugs per se, simvastatin has the highest risk for myopathy, and the fluvastatin has the least risk for myopathy. The higher the dose, the higher the risk for myopathy. And concomitant use of CYP inhibitors like amiodarone, protease inhibitors, cyclosporine, and other anti-lipidemic agents like gemfibrozil, they cause, when concomitantly used, they increase the risk for myopathy. And other factors include the physical exercise and family history of any kind of muscle disease can precipitate statin myopathy. And dietary in the form of grape juice ingestion can cause CYP inhibition, cause predisposed to statin myopathy. And when coming to the pharmacogenomic factors, mainly the polymorphisms, like single nucleotide polymorphisms involving the different genes involving the metabolism of statins. They include CYPs, UGTs, or any hepatic uptake transporters or efflux transporters. Any SNPs called single nucleotide polymorphisms can result in increased statin exposure systemically. And the most important among these is SLCO1B1. It is consistently associated with myopathy. It is an sinusoidal influx xenomatic transporter. A single nucleotide polymorphism of the gene RS4149056, where at the 521 site, where thymine is replaced by cytosine in the exon 5. This results in the decreased activity of this ion, and this results in increased exposure to the statins. And the odds ratio for homozygous mutation to normal variant is up to 17 times. And the different pathophysiology in statin-induced myocyte dysfunction include the mitochondrial dysfunction, disturbed calcium signaling, apoptosis, reduced prenylation of proteins, and immune-mediated mechanisms which involve HLA-DR-B1, which is strongly associated with anti-HMG CoA reductase inhibitors. And statins may unmask the underlying neuromuscular disorders like any myositis or any neuromuscular junction disorders or any motor neuron disease. It may unmask. And coming to the management of SRM, and first we have to weigh the risk factors, cardiovascular risk factors in a patient with SRM, and we have to see whether the patient really requires a statin, whether he has a low risk cardiovascular risk factors or higher risk. So if he has lower risk for cardiovascular diseases, then encourage lifestyle changes, and if he has higher risk, then re-challenge with the same statin or in a different statin with a lower dose or alternate day dosing. And consider drugs other than statins like fibrates or ezetimibe. And among the fibrates, you better to avoid gemfibrozil. And the newer agents like PCSK inhibitors and bempedoic acid has been used, which also has a reasonable good control of LDL in reducing the LDL. And these are the some of the drugs which cause different types of myopathies. They include certain drugs cause necrotizing myopathy, as mentioned, the statins, important ones. Amphiphilic drugs like chloroquine, hydroxychloroquine, amiodarone, and antimicrotubular drugs like colchicine, vincristine, and some mitochondrial myopathy-like presentation can be seen with antiretroviral therapy. And certain drugs can cause inflammatory myositis like picture, like predominantly penicillamine and tryptophan. The second most common in the general practice is steroid myopathy, which results from chronic high to moderate dose exposure to systemic corticosteroids, and typically develops with more than 10 mg of prednisolone equivalents for more than 4 weeks. And higher doses can precipitate the symptoms within 3 weeks also, and predominantly affects the lower limb muscles proximally. And the characteristic feature is muscle weakness and atrophy, but there will be no pain associated. And in the ICU setup, there can be acute steroid-induced myopathy with higher doses of intravenous corticosteroids. And most commonly, this steroid myopathy is associated with oral and intravenous formulations. However, with inhalational agents also, there can be intercostal myopathy also. And most common with fluorinated glucocorticoids like dexamethasone, triamcinolone, and betamethasone. And these are the potential risk factors for steroid myopathy. Includes the elderly patients with low body mass index, underlying malignancy, prior history of muscle disease, spinal cord injury, chronic respiratory illness, poor nutritional status, sedentary lifestyle, and concomitant usage of neuromuscular blocking agents in the ICU. The clinical factors includes insidious onset of symptoms over weeks to months, and the lower limbs proximally more involved, and there will be no pain associated. There will be underlying atrophy, but it will be masked by the Cushingoid habitus of the patient with obesity. And here cranial nerves are not involved. And patient may also have other stigmata of steroid exposure like Cushingoid faces, obesity, cataracts, and all. And how do these steroids alter the cause myopathy? They alter the balance of muscle protein because they stimulate the proteolysis, and it includes the degradation of myofibrillar proteins like dissociation of actin and myosin. They induce the apoptosis of myocytes. They reduce the expression of myogenic transcription factors, and they increase the expression of myostatin, which is the anti-myocyte protein. And also some steroids have mineralocorticoid activity, which lower the serum potassium, and also it aggravates the myopathy. And muscle biopsy shows classical atrophy of type 2 fibers or the fast twitch muscle fibers. There will be variability in muscle fiber size. There will be no inflammation. And high degree of suspicion is needed, especially when treating a myositis patient with corticosteroids. We have to make sure that the increased weakness is related to corticosteroid or the flare-up of underlying myositis. In the certain things can help, like serum CK, AST, all these lab parameters can help. They will be typically normal in steroid myopathy, and EMG will be typically normal in steroid myopathy, but in case of underlying flare-up of myositis, there can be increased insertional activity or positive waves. And the management will be reduce the steroid dosage to the lowest possible level, and whenever possible, you switch to the alternate agents or non-fluorinated agents, and alternate day regime is should be used, and consider steroid sparing agents early in the disease, like azathioprine, mycophenolate, or rituximab can be used depending on the disease, and resistant therapy can prevent the steroid-induced myopathy. And coming to the other most commonly seen is hypothyroid myopathy. They present with non-specific symptoms of myalgia, stiffness, cramps, muscle weakness, and exertional weakness. This hypothyroid myopathy is a different set of symptoms where the muscle symptoms predominate the clinical picture rather than the typical symptoms of hypothyroidism like weight gain, loss of appetite, cold intolerance. And the most common cause of hypothyroid myopathy is Hashimoto's disease. And these are certain syndromes in hypothyroid myopathy. They can be asymptomatic hypercemia, which is most commonly seen. There can be myalgia, painful cramps. There can be myoedema, which can be elicited by locally percussing the muscle. The visible swelling can be seen, which lasts for a few seconds. This is due to local release of calcium ions. There can be muscle hypertrophy due to increased deposition of glycosaminoglycans or increased fiber size and increased endomysial fluid, and these can result in entrapment syndromes like carpal tunnel syndrome and others. And there can be proximal myopathy. In very rare cases, there can be acute compartment syndrome or rhabdomyolysis, which have very high elevated CK levels with muscle pain. However, this is very rare. The pathophysiology is a reduction of intracellular T3. T3 is mainly useful for contraction relaxation of the muscle fiber, and it helps in regulation of multiple genes involved in the Krebs cycle and oxidative phosphorylation, and this also regulates the glycogenolysis, and there will be defective utilization of glycogen. So the hypothyroidism mimics a metabolic myopathy, and there studies also shown there will be low carnitine in muscle, which can be reversed after supplementation with thyroid. And there will be the phenotypic switching of muscle fibers, where the muscle phenotype switches to a slow twitch type. There will be atrophy and loss of fast twitch type 2 fibers and be replaced with slow twitch type 1 fibers. And also these type 1 fibers, they have central hollows with loss of enzymatic activity. And there will be some rarer subtypes of hypothyroid myopathy. They can rarely present as a myasthenic syndrome, an atrophic form, a Coker-Debris-Semelin syndrome, and Hoffman syndrome. The Hoffman syndrome is very rare syndrome in patients with long-standing untreated hypothyroidism. There will be proximal muscle weakness, pseudoatrophy, hung up reflexes, and most commonly calf hypertrophy can be seen. This is due to increased deposition of glycosaminoglycans and can be reversed with optimal thyroid supplementation. This Coker-Debris-Semelin syndrome, it is predominantly seen in the pediatric group, most commonly with severe hypothyroidism, mostly seen in cretinism due to thyroid dysgenesis. And they have Herculean habitus, pseudomuscular hypertrophy, and myxedema picture. And the most strikingly seen in the trunk, limbs, and tongue. The next one is thyrotoxic myopathy, most commonly seen in Graves' disease, and with the female predominant. There will be severe, there will be muscle weakness and atrophy, and wasting can be seen predominantly in the proximal musculature. And the bulbar involvement can be seen in thyrotoxicosis. Whenever there is bulbar involvement, you should look for underlying myasthenia gravis because both are autoimmune conditions. Very rarely there can be a thyroid storm where there will be rhabdomyolysis and myoglobinuria and AKI. And thyrotoxic periodic paralysis, it is commonly seen in Graves' disease, but here it is male predominant rather than female, which Graves' disease most likely happen in females. And there will be recurrent attacks of painless proximal weakness of variable duration precipitated by heavy carbohydrate meal or muscle cooling or rest after a prolonged exercise. Here bulbar muscles are spared and they can be lab value shows associated hypokalemia and hyperthyroidism. This is due to loss of function of invert rectifier potassium channel, which is seen in up to 35% of patients with thyrotoxic periodic pulses. And there's a group of syndromes called primary, secondary hyperparathyroidism and metabolic bone disease. And they are grouped put together because they share the similar clinical and lab characteristics features. They have symptoms related to hypercalcemia in the form of polyuria, constipation, hypophosphatemia and myopathy, elevated alkaline phosphatase, hypercalciuria and osteopenia. However, they have normal levels of serum CK. And most commonly, they present with non-specific symptoms in the form of muscle cramps, weakness, and fibromyalgia kind of presentation. They have symmetric proximal weakness and atrophy. These patients have pain everywhere in the body, and patient will be having a waddling gait and inability to walk predominantly due to pain, not due to weakness. And secondary hyperparathyroidism seen in CKD due to excess PTH and uremia, vitamin D carnitine deficiency, aluminum toxicity. All this together can cause together contribute to the pathogenesis of myopathy. And also osteomyelasic myopathy in vitamin D deficiency and renal tubular acidosis. They also present similarly in the form of proximal weakness, myalgias, and they have diffuse muscle pains, which is a clue to the diagnosis. And lab value shows increased ALP, reduced vitamin D, and elevated parathormone. Next most important topics is metabolic myopathies. Metabolic myopathies, they can present with the dynamic symptoms in the form of reversible acute muscle weakness and cramps precipitated by excess, or they can have static symptoms in the form of fixed weakness. And in order to clinically differentiate what type of metabolic myopathy the patient have, we have to first know the basic idea of what muscle uses, what fuel the muscle uses at different types of activity. At rest, the muscle predominantly uses free fatty acids. And at the other extreme, that is maximal, extremely intense exercise, the muscle uses anaerobic glycolysis as source of energy. However, in between, at submaximal exercises, at a submaximal low intensity exercise, predominantly the muscle uses blood glucose and mobilization of free fatty acids. And at a submaximal high intensity exercise, the muscle glycogen will be the main source of energy. So when a person does a prolonged low intensity exercise, gradually the glucose is replaced by the free fatty acids. And the common clinical features of all myopathies include episodes of exercise intolerance, fatigue and muscle pain and weakness. Indirectly, they may be free of symptoms, and it depends on the type of exercise. For example, a short burst of high-intensity exercise, that is like sprinting activities, they can precipitate symptoms in case of glycogen storage disorders. Whereas prolonged periods of low-intensity endurance activities, they precipitate symptoms in fatty acid oxidation disorders or mitochondrial myopathies. Second wind phenomenon is seen in myocardials. In second wind phenomenon, initially there will be usage of the glucose from the muscle. When the glucose is exhausted, muscle glycogen has to be released from the muscle, where the myophosphorus deficiency in myocardials results in reduction of release of glucose from the glycogen. Hence, the patient will have symptoms within 5 minutes of exercise. However, if the patient continues to do the exercise, and the metabolism shift takes place where the free fatty acids comes into picture, where beta oxidation of fatty acids takes place, and the patient will be relieved of the symptoms. This is called second wind phenomenon. And the other symptoms include the out of wind phenomenon seen in Tourette disease, where glucose supplementation aggravates the symptoms in Tourette disease, because there is, if you supplement glucose in this patient, there will be shifting the there will be reduced availability of free fatty acids, so there will be precipitation of symptoms. And nausea and vomiting can be seen in Tourette disease. And rhabdomyolysis, this can be seen with high intensity exercise in glycogen storage disorders, whereas prolonged fasting and intercurrent illness can precipitate rhabdomyolysis in fatty acid oxidation defects. And there will be warning signs in case like myalgias and cramps in glycogen storage disorders. The warning signs are absent in fatty acid oxidation disorders. And interictal CK will be very much, can be elevated in glycogen storage disorders, and it will be normal in fatty acid oxidation disorders. These are the different types of glycogen storage disorders and fatty acid oxidation disorder. Most common CPT2 deficiency, VL-CAD and MAD. The most common one is the McArdle's disease due to deficiency of myophosphorylase, which converts glycogen to glucose 1-phosphate, which enters the glycolytic cycle, or there will be a blockade of anaerobic glycolysis because the muscle glycogen is not released, and there will be a second wind phenomena as described. And coming muscle biopsy shows subsarcolemmal glycogen vacuoles, and the will be negative phosphorylase stain. And the treatment would be regular moderate aerobic training with 60 to 70% of VO2 max. And because with this exercise, the muscle uses predominantly fatty acids. And ingestion of glucose before the exercise can help in these patients. And there will be low pyridoxine levels in patients with McArdle, so pyridoxine supplementation can be helpful in some. And PFK deficiency called TORIS. The important things are lack of second wind, and patients have out of wind phenomenon. There will be increased bilirubin concentration and reticulocyte hemolytic anemia. That is a clue for this disease. And there will be no specific therapy, and biopsy shows subsarcolemmal past positive polyglucosan-like inclusions. High protein diet and aerobic training helps in treating these patients. Pompe's disease, infantile form, they have macroglossia and present as floppy infant. The important differential diagnosis is SMA, and in needle EMG measure positive waves are complex repetitive discharges, which is a clue for this disease. And the childhood form, they resembles DMD Duchenne with cough hypertrophy and respiratory failure. These don't have a macroglossia or cardiomegaly. And the adult onset form has progressive myopathy involving proximal musculature and axial musculature. They can cause dysphagia. Respiratory muscle involvement can be there, which causes early morning headaches and exertional dyspnea. Paraspinal muscle wasting can be there on examination. They can have intracranial aneurysms or dolicoctasia of the intracranial vessels. And there are certain myopathies called pseudo-metabolic myopathies, where they mimic the metabolic myopathies, but they underlying they have a genetic defect, most likely seen in the carriers of dystrophin, like Baker's muscular dystrophy or carriers of Duchenne muscular dystrophy. Certain types of LGMDs, predominantly dysferlin, ANOC5, malignant hypothermia, RVN related, statin exposure. They can also mimic the pseudo-metabolic myopathies. The clue for pseudo-metabolic myopathies, persistence of CK beyond 10 days after a bout of rhabdomyolysis. Fatty acid oxidation disorders, so seen in young adults, male predominant. They have, as I earlier told, they have normal CK between the attacks. And attacks of myoglobinuria not heralded by painful cramps. There are no warning signs for myoglobinuria. And the CP2 deficiency is the common one. With they have neonatal fatal form precipitated by cold exposure, lack of sleep, and intercurrent illness like fever. The myopathic form in the adults or adolescents, they have recurrent myoglobinuria, and TMS shows increased long-chain fatty acids, and ictal CK can be very much elevated, more than 4,000 times. The lifestyle modification, and patient should avoid prolonged fasting or prolonged exercise. And supplementation with medium-chain carbohydrate triglycerides can be helpful. And MAD, it is due to the deficiency of electron transfer flavoprotein chain. These carry the redox reaction that carry protons from the different dehydrogenases to the electron transport chain. And these are cofactored by riboflavin. They have this fatal neonatal presentation, and late onset adult forms, they have proximal limb axial muscle weakness with dysphagia. They can, the typical symptom, the treatment option is they dramatically improve with riboflavin supplementation, and CoQ supplementation also can help in some of these patients. VLCAD, this is the first step of mitochondrial beta oxidation. It is due to the mutations of this ACA-DVL gene, and they have late onset myopathic form in the form of intermittent rhabdomyolysis muscle cramps, and TMS shows elevated long chain acetylcarnitines. And management would be the medial chain oil called triheptanoin or carnitine supplementation, and increase the total dietary protein intake. And linoleic arachidonic acid can help in some of these patients. And this triheptanoin affects 7-carboxy fatty acids hydrolyzed in the small intestine to 3 molecules heptanoic acid, which enters the beta oxidation and results in formation of acetyl-CoA and propenyl-CoA, which helps in Krebs cycle. And the rarest form is the mitochondrial trifunctional protein deficiency. They have recurrent myoglobinuria, cardiomyopathy, pigmented retinopathy, sensory motor neuropathy. And the treatment triggers would be common in all these fatty acid disorders. And the treatment is avoidance of fasting and high carbohydrate meal. And the last 2 slides on asymptomatic hypercemia defined as elevation of serum CK more than 2 standard deviations on 2 separate occasions. They can be due to underlying many causes. The systemic causes include endocrine disturbances, connective tissue disorders, electrolyte disturbances, pregnancy, renal failure, and certain myopathies like dystrophinopathies, LGMDs, myofibrillar myopathies, desminopathies, myotonic dystrophy, congenital myopathies, inflammatory myopathies. Any kind of myopathy can initially may present with asymptomatic hypercemia. This is a study published in Neurology in 2006, where they analyzed 104 patients with asymptomatic hypercemia, where they could reach a definitive diagnosis in 55% of patients, where the most commonly identified diseases were glycogen storage disorders, muscular dystrophies, and inflammatory myopathies. Another paper, they have studied a large group of population with muscle biopsies, where they could find the most common one would be dystrophinopathies, followed by CPT deficiency. Here is evaluation of hypercemia of a patient with elevated CK levels. Ask them to take a rest for a week and again repeat the serum CK and also obtain the basic metabolic profile. If it is still elevated, do an EMG to rule out a myopathic process or it's a neuropathic process. If any neuropathic findings or neurogenic findings are there, you work up for motor neuron disease and other findings. If any myopathic findings are there, go for muscle biopsy. But however, in the current generation of genetics, we can directly go for a genetic test and we can give a diagnosis of this myopathy. Thank you.
One thing I wanted to ask, steroid myopathy, CK is normal, EMG is normal. How can we definitely say it's only steroid? Is just a drug association or something else?
High degree of suspicion is needed, especially in the steroid, because the patient will have some kind of weakness which previously he didn't have. And we can do one thing, we can reduce the steroid to the lowest possible dose and we can see spontaneous improvement in such cases.
I think it was a very good talk. Covered everything.
Thank you, sir.
About this asymptomatic cemia, it happens after exercise also, and how much of exercise and how much of CK should be? Suppose somebody has got 500 or 600. Should we worry about
normative values are there. Depending on the ethnicity and sex, they have identified some normative values. For Indian data, usually they tell it is more than 2 times the elevation, more than 2 standard deviations, or more than 1.5 times elevation of the upper limit of normal.
So does normal exercise also increase
yes,
or no?
Normal exercise also can increase CK. And if the patient is already using statin or some other drug, exercise can precipitate the increase in CKs.
Thank you then.
Thank you.
Yeah. It was okay, but just we'll finish off the talk. sir is interventional radiologist who did from Sri Chitra, and he has been there since last 3 months now.
Sorry. Sir, can we have the slide, sir? So good evening all. I don't know how much this topic is palatable, so I tried to keep it short. So this is overview of my presentation. So what exactly is MR neurography? MR neurography is nothing but the generation of 3D data sets. So we can get reformatted multiplanar and curved images and MIP images as well. So to put together all these 3D data set actually limits the artifacts so that we can better visualize the neural tracts. So why MR neurography is so challenging? So to understand that, we need a little bit of anatomical knowledge. So if we cut down and open a neuron in a brain and spine versus a periphery, usually in the brain, the ratio of, as we see here, light. So if you see this exoplasm to Schwann cell layering, in brain actually it is 2 times compared to periphery. So in the brain, when we use T2 weight sequences, so they are fluid sensitive structures, so we can easily visualize the neuron when there is lot of exoplasm. But whereas in the periphery, usually too much amount of Schwann cell layering is seen compared to the exoplasm. So when we try to do the T2 weight sequences, so it will be very difficult to acquire the signals from peripheral neuron. So why should the signal intensity should increase in any abnormal nerve? So whenever there is some blockade of exoplasm, so the neuron continues to be in a depolarized state, so there will be large amount of calcium influx leading to mitochondrial injury. So this actually leads to the fluid accumulation, leads to increase in the signal intensity. So apart from that, the signal intensity can increase due to vascular congestion or Wallerian degeneration. So coming to the various techniques of MR neurography, so I have highlighted here it in 2 boxes. So one is in red and one is in yellow. So this red can be, red box can be done at all centers. So we don't need high degree of hardware, or we don't need a high-end technology. So coming to this first, these anatomical sequences. Anatomical sequence can be a non-nerve selective or it can be a nerve selective. So we can see at this image. So in non-selective nerve images, usually we don't concentrate on a nerve. Rather, we concentrate on the adjacent structure. So most often in the periphery, usually the nerve is accompanied by surrounding structures like a blood vessel, or there can be some joint fluid, lymph nodes. So in this image, this is a amputated leg, and here we can see a plantar nerve. So surrounding the plantar nerve, we can see bright vessel, and we can also see some bright vessels, and we can see some joint fluid. So what we do in non-selective images is, first we try to suppress this blood vessel, and we try to suppress the fat so that the nerve stands out. But the problem with this non-selective images is, we are not highlighting the signal within the nerve. We are only suppressing the surrounding structures. So if someone asks me a single sequence, a single nerve sequence, so that we can better visualize things, or we can screen a nerve, means in the spine we can do this. In the spine we can do this stir space, and in the periphery we can do this spare. Why should one do a 3D stir space in spine? Means usually spine is a heterogeneous structure. Usually we do have a lot of fat and and vertebrae. So all these are T2 hyperintense structures. So usually stir space can suppress, usually suppress the fat nicely. So we can get homogeneous fat suppression. So stir space is always better in the spine. So whereas in the periphery, usually in the periphery, the nerve and blood vessels, they go in hand by hand. So it is always important to suppress a vessel as well as fat. So in the periphery, we can do a spared space so that we can suppress the fat as well as blood vessels. Whereas in the spine, there is not much of need to suppress a vessel because usually the nerves and vessels, they don't go hand in hand in the spine. So next, coming to nerve selective imaging. So in the nerve selecting imaging, apart from suppressing the surrounding structures like fat and blood vessels, here we also highlight the signal within the nerve. So to highlight the signal within the nerve, usually we apply the gradients. So in this image, you can actually clearly see. So this was a non-nerve selective imaging, and this was a nerve selective imaging. Here we have suppressed the blood vessels, and we have suppressed the joint fluid, and we also have highlighted the nerve signal by using the diffusion gradients. So this is one new technique. This technique is called actually a 3D Shenki technique. This was developed by Japanese. So here we have done three important things. One is a spare. So in the spare, actually here we have suppressed the fat and fluid signal, vessels, and so we have suppressed. And we have used one more sequence called motion sensitive driven equilibrium. So we have suppressed the blood vessel, and we have also highlighted the nerve signal by applying a 3D rare sequence which has variable flip angles. So, but this sequence was later on bought by Philips company, and they have now named it as 3D nerve view. So this is how we can get 3D neurographic images with this nerve imaging. We can nicely see the roots, trunks, divisions, and peripheral nerve. Even in the limb, so we can see all the peripheral nerves with this 3D nerve view. So this is functional nerve selective imaging. In the functional nerve selective imaging is not routinely used on a routine OPD basis. So mainly this is used for nerve recoveries, and this can also be used to generate the tensor nomograms. Actually, we can see the usage of this 3D tractogram in this image. So this is a case of Pancoast tumor, but with routine anatomical imaging, no matter what, we can't delineate the involvement of a brachial plexus. Whereas with this 3D tractogram, we can nicely see the involvement of the entire brachial plexus. We can see the uninvolved portion of roots and part of trunk of upper plexus, and we can also see the complete involvement of lower trunks and roots. So this information we can't get with routine anatomical images. So this is how we do the neurography. To summarize, so it's always better to use 3 Tesla because 3 Tesla has better SNR, so it's always better to use the 3 Tesla and coils, and so it's better to use phased array coils. And these are all the basic sequences. So T1, T2, T2FS, and spare. All this can be done for all the cases. Then, basing on the center and availability, we can use this 3D nerve imaging. And if contrast is required, then we can do contrast imaging and so. So how to interpret a MR neurography? So before interpreting any MR neurography, we should have sound knowledge about the anatomical region which we have sequenced, and we should have thorough knowledge of the nerves in and around. Then after knowing the basic anatomical knowledge, then one should see the nerve. In the nerve, we have to see various things. First, we should try to course the entire nerve, and we should see the continuity of a nerve, and we should try to see the size and the fascicular pattern and perineural fat and enhancement and fascicular pattern. And after seeing the nerve, then one should look at the muscles. So we should see any T2 hyperintensity for denervation edema, or one should look for any fatty atrophy. So after seeing this entire neuromuscular unit, and then basically looking after the clinical scenario and basic lab investigations and electrophysiology studies, then one can come to a diagnosis, or at least to a close differential diagnosis. So these are the various applications of MR neurography, and this list goes on increasing day by day. And here are some interesting cases. So this is a 6-week-old child came with the complaint of right upper limb paralysis, and on examination there is some hypotonia and his hand grip is normal. So for this patient, MRI was done, and in the MRI we are seeing some thickening of nerve roots C5, C6, C7, and we are seeing some bulbous dilatation of lower nerve root. This is actually a neuroma, and this coronal stir image, and so we are seeing some stir hyperintensity in the scalene muscles. And this is a T2 axial image, and in the T2 axial image, we are seeing a long thickening of a nerve root, and we are seeing a bulbous dilatation, and actually this is a neuroma. So this patient had stretch injury at the time of birth, and this is a case of Erb's palsy. So this case is a 35-year-old male, and he's a heavyweight lifter, and he came with the complaint of left shoulder pain. And on examination, there is some shoulder weakness, and these are the sagittal oblique stir images. And here we are seeing the stir hyperintensity in the infraspinatus muscle, and apart from that, there is some atrophy of infraspinatus muscle. So this patient had a compression near the compression of suprascapular nerve near spinogluteal notch, and actually this is a case of Turner personage syndrome. So 42-year-old male came with the complaint of recurrent pain in the forearm. So his examination is normal, and for this patient, ultrasound was also done, and it is also normal. So this patient was kept on conservative treatment, but again he came after 4 weeks with the complaint of recurrent pain. So for which we have done MRI. And in the MRI, actually there is a thickening along with enhancement of radial nerve. So, and we have imaged the entire limb, but we could not find the cause for his radial nerve thickening and enhancement. So this is a case of radial nerve neuritis. So this is another case. So this is a case of 58-year-old male. He came with the complaint of paresthesias in the ring and little finger of 9 months duration. And on examination, this patient had tenderness near the elbow joint, and MRI. So first ultrasound was also done for this patient. There is some thickening near the thickening of ulnar nerve, but we could not find any cause for this ulnar nerve thickening and pain. So we have done MRI for this patient, and in the MRI, these are the stir axial images, and here we are seeing a thickening of nerve fascicles of the ulnar nerve. And apart from that, we are seeing some stir hyperintensity anterior to this nerve, suggestive of some inflammatory changes. And we are seeing some inflammatory changes in and around the epicondyle. So this is a case of epicondylitis leading to ulnar nerve compression. So this is another case, 45-year-old male. He came with the complaint of foot drop. So on examination, he had a weak foot eversion, and he has some sensory loss over the dorsum of foot. But ultrasound was done for this patient. Again, ultrasound is normal. But for this patient, now conduction study was done. So there is some conduction block in the common peroneal nerve, for which MRI was done. And in the MRI, there is a thickening of common peroneal nerve. And in and around the common peroneal nerve, there is some T2 hyperintensity in the fibular head. And there are some degenerative changes in the fibular head. And these degenerative changes have led to the compression of this common peroneal nerve, leading to the common peroneal nerve thickening and enhancement. So this is another interesting case. This is a patient of 48-year-old male patient. He came with the complaint of burning sensation in the sole region, and on examination, his toe flexors were weakened. So first we had done high-resolution ultrasound for this patient. So 2 images were acquired. First, this image is acquired when the patient is in the standing position, and this image is acquired while the patient is doing plantar flexion. So in the standing position, actually this tibial nerve is round in contour, but whereas in plantar flexion, this tibial nerve size has been significantly decreased, and it is getting compressed against the soleal muscle. So for this patient, we had done MRI later. So in MRI, so first we had done images in the lying down position. So here again the tibial nerve is round, and there is not much of any signal intensity changes in lying down position. But second, when we have flexed his foot, his nerve have become flattened. This tibial nerve have been flattened, and there is some signal changes within the tibial nerve. So this tibial nerve has been compressed within the soleal sling. So this is a soleal sling syndrome, and this commonly is seen in prolonged standing patients with the flexion. So this is this another case, a 52-year-old female patient. So this patient has large lipoma in the pelvis. And this lipoma is even extending in between the gluteal muscles. So first the patient underwent surgery. So again, after 8 weeks post-surgery, he came with the complaint of leg paresthesias and weakness. So we had done MRI for the same patient. So here we are seeing stir thickening and stir hyperintensity within the muscle, and some susceptibility artifacts were seen in and around the muscle. So in this axial T2 image, so we can see some hyperintensity within the muscle. And for the same patient, we had done CT, and in the CT, actually the surgical clip is actually compressing this sciatic nerve. So later, the surgical clip has been removed for the patient, and he had some clinical improvement. So this is one interesting case. So this patient is an 18-year-old male. He presented with subacute onset left hip pain with numbness over the dorsum of his left foot. And he also had similar complaints in the past. So so this patient was ordered for MR neurography. So while acquisition, we had done this T2 coronal MR images. And in the T2 coronal MR images, usually this is the femur and this is fibula. Usually in this end plate, usually we do expect some amount of fat in the end plates. But in this patient, he had significant amount of T2 hypointensity. So, and again for the same patient, we had seen this alpha nerve root thickening, and even some hyperintensity seen in the gluteal muscles. So, and this patient also had some medullary island of necrosis within the femur. So, this patient had medullary infarcts and extra amount of hematopoiesis within the end plates. So, we thought this patient had some systemic abnormality. So, this patient. So we had given the possibility of sickle cell anemia, and this patient came out. This patient had proven to have sickle cell anemia. So we thought we want to publish this case, but when we searched the literature, by then actually many similar cases were there in the literature. So this is another case. So this is a case of he's a 31-year-old female. So he had a subacute fluctuating distal and proximal limb weakness, and he had hyposthesis and generalized areflexia. So nerve conduction was done for this patient, and this patient had multifocal conduction blocks, and CSF was done for this patient, and there is some albumin-cytological dissociation. So for this patient, MRI was done, and MRI showed diffuse thickening of this lumbosacral plexus, and there is also thickening of this sciatic nerve. And one interesting find in this patient is this patient had symmetric thickening of this bilateral cysternal segment trigeminal nerves, and contrast was also done for this patient, and there is this thickening of cysternal segments of bilateral trigeminal nerves. So after seeing the clinical history and NCS, we have given the possibility of a CIDP. And one interesting point in this case is there is even this cranial nerve thickening and enhancement. So this patient actually underwent a biopsy for sural nerve, and it was consistent with non-uniform demyelinating and axon neuropathy, and this proved to be CIDP. And this is another case, a case of 60-year-old male. He had bilateral lower limb paresthesias of 4 years duration, and he also had limb weakness and wasting. And he also had positive family history, and where his younger brother had similar complaints. So electrophysiological tests were done for this patient, and he had reduced amplitude of muscle action potential and preserved connection velocities. And again, MRI was done for this patient, and there is diffuse thickening of roots, trunks, divisions, as well as nerves of this bilateral upper limbs. And even in the lower limb, also he has this diffuse thickening of lumbosacral plexus, sciatic nerves, and even intercostal nerves were also thickened in a significant way. So biopsy was done for this patient from sural nerve, and it was consistent with this hereditary demyelinating neuropathy. And again, this patient, exome sequencing was done for this patient, and he had this abnormality in PMP22 gene, which is consistent with Charcot-Marie-Tooth disease. And this is another interesting case. This patient is a 56-year-old patient with the progressive numbness on the lateral aspect of his shoulder associated with weakness in the limbs, and examination showed asymmetric weakness of both extremities, and NCS showed partial motor conduction blocks in the median nerve. And ENMG showed denervation and reinnervation pattern, so MRI was done for this patient. And in the MRI, actually this patient had diffuse thickening of this bilateral lumbosacral plexus, and basing on the history, and after seeing this history and the electrophysiological test, we thought this is CIDP. And initially the patient was started on steroids, but after tapering the steroids, this patient is again getting worsened. So this patient was again started on plasma exchange therapy, and in spite of plasma exchange therapy, patient has significantly worsened. So this patient underwent a biopsy, and after doing a biopsy, this patient turned out to be a lymphoma. So this is another case. This patient is a 68-year-old female patient, and this patient, sorry, not right breast, left breast. This patient had left breast carcinoma, for which he underwent mastectomy and radiation. And 2.5 years after this radiation, he came with the complaint of paresthesias in the hand with proximal extension along the forearm, and also with weakness in the forearm muscles. So MRI was done for this patient, and in the MRI, actually we could see the significant thickening of this brachial plexus in the trunks and along the and also along this nerve roots. And contrast, and these are the sagittal T1 post-contrast images. And here we are actually seeing this enhancement of this trunks and roots of this brachial trunks and at the level of trunks, where we are seeing the enhancement. And there is some heterogeneous enhancement is also seen in and around this brachial plexus. So we thought that this was a recurrence, and we reported this as a recurrence with nerve root involvement. But PET-CT was done for this patient. There is no uptake along this trunks. So this is actually a case of radiation neuropathy or radiation brachial plexitis. So MR neurography is not without any limitations. So it takes much time compared to brain. It takes at least twice the time of brain. So it needs patient cooperation. And if you see the peripheral nerve, usually the length of a peripheral nerve course is too much long. So we can't actually acquire the images of the entire nerve. So it is always important for clinical localization, so that we can concentrate on that particular region, and we can acquire the images so that we can cut down the time. And we actually need some quantitative data. And so if for example, if we want to say thickening of any nerve, for example, sciatic nerve or any nerve, we actually need normative data, which is actually lacking for many nerves. And last is this magic angle effect. Magic angle effect is actually the artifactual increase of signal intensity. If we take the course of a peripheral nerve, usually the peripheral nerve is not straight in course. Usually it has many turns. It goes medial, lateral, it goes up and down. So if we see this graph, so this is the angle of B naught, that is magnetic. This is the angle of magnetic field, and this is the course of a nerve. And at 0 degrees and at 0 degrees, this is the signal intensity of a nerve. But at 55 degrees, there is slight increase in the signal intensity of the same nerve. Actually, there is no pathology in this nerve, but there is some artifactual increase in the signal intensity of a nerve. This is because at 55 degrees, usually the protons better align with the B naught magnetic field. So there will be this artifactual increase in the signal intensity. So this has to be addressed. So we should have some idea where this magic angle affects, and then only we have to interpret the images. Thank you. Sir, if you have any suspicion for example, if you have any suspicion of entrapment neuropathy, or if you have any feeling of lymphoma or any neurofibroma, schwannoma, or any nerve sheath tumors, then contrast is always better. There is no harm in giving contrast, but it takes time, at least 4 or 5 minutes extra. Yes, sir.
And more cost.
More cost.
But more information will come because of
Yes, sir.
And do you suggest that it also depends, I mean, should we do it both plexuses together, lumbar plexus and breakthrough, or it depends on the indication?
Yes, sir, it depends on the indication.
Yeah, as we end, there's only one case presentation before our IT, and I request all of you to give the feedback forms and suggestions for next sessions. Sukrit. Before that, Sita madam, kindly give the... Vijay.
Yeah, good images.
Madam.
That's why we are asking you.
Come.
Good afternoon, everyone. Today's case is a 56-year-old male, diabetic and hypertensive. The patient had a history of CVA right dorsal medullary infarct in December 2022. A recent ACS for which the patient underwent PTCA in April 2024. He presented on 28th April with history of acute symmetric progressive weakness of the proximal muscles of both upper limbs and lower limbs since 2 days. Preceding that, the patient had pain in both lower limbs since 20 days. The patient was on antiplatelets and rosuvastatin 40 mg. On examination, the patient was conscious, coherent, the vitals were stable. In the power, there was predominant proximal weakness in the upper limbs, 3/5, and in the lower limbs, the proximal power was 3/5. Distally, the power in both upper limbs and lower limbs was 4/5. The rest of the examination was normal. On investigating the patient, the CPK levels were significantly high, around 17,000. The creatinine was elevated and there was hyperkalemia. There is a clear response seen to these levels with hemodialysis with decrease in the levels sequentially. In the liver, enzymes were elevated with SGPT of 200 and SGOT of 395. The EMG showed a myopathic pattern. As the patient was on dual antiplatelets, muscle biopsy was deferred due to the high risk of hematoma formation involved. As an autoimmune etiology was suspected, C3, C4 were done, which were normal. Anti-ACHR antibody and ANAF were negative. Also, the anti-HMG-CoA antibody was negative. The diagnosis was statin-induced myopathy with specifically rhabdomyolysis. The patient was managed with 2 cycles of hemodialysis, following which there was decrease in the CPK levels and improvement in the renal function. Even then, due to the persistent CPK elevation and suspecting autoimmune etiology, patient was treated with an IVIG. A total of 140 grams, as in 2 grams per kg, was given over 5 days, following which the patient improved symptomatically. It's the summary of the case with the proximal predominant weakness and a history of statin usage. The investigations indicating a statin-induced rhabdomyolysis and a response to dialysis and IVIG. The clinical question involved in this case is that even though the antibody was negative and the common etiology is suspected to be autoimmune, is statin associated with the direct muscle pathology is involved with statins, or is there only autoimmune involvement?
No, the thing is that the receptor antibody is negative, right?
HMG CoA.
Yeah, therefore, but there was response to IVIG was there. It may be over time or response to IVIG. After the hemodialysis also there was a partial
CPK
response.
levels were lowered, sir.
Yeah. Jayashree madam.
After dialysis, CPK went down, sir, and we withheld and thought patient is improving. Again, the CPK level started increasing. Like initially it was 17,000 and after again it was increasing 12,000 after they came down. So then discussed with NIMS Megha madam, they were doing HMG CoA antibodies. So we have sent the sample and they also wanted biopsy, muscle biopsy, but we did not shift the patient to NIMS. He was hemodynamically. Then, no.
Negative.
It was negative, but we started off on IVIG thinking of immune-mediated necrotizing myopathy instead of waiting for the antibody. IVIG, patient improves. No, no, we took their clearance under their this one. We couldn't do it. Only this.
No, sir.
I thank everybody, all the delegates who have stayed back, and we will be, as already told, we will be conducting it every 6 months. The next month will be in the second week of December, and hopefully you will also join at that time. And I thank Kaul sir, Sita madam, Mohandas sir, and all the residents who have been collecting the cases, Jayashree madam and Anuja madam. And apart from that, Srinivas and all the staff of the KIMS hospital, and definitely Dr. Bhaskar Rao sir and Dr. Sambit, who have been helping us and continuously who have supported us. Thanks you. Just join us for a high tea, please. Huh?